ఇదంతా
బ్యాక్గ్రౌండ్ అంతా కనపడదు.
ఇది సార్
ఇందులో
బ్యాక్గ్రౌండ్.
మనకి నాకు ఇక్కడ నుంచి అవన్నీ రిఫ్లెక్ట్.
సో Bashir, hello. Can you hear me, Bashir?
Yes.
Hello. Hello. Hello.
Hello.
నా వాయిస్ క్లియర్ ఉందా అండి?
Yes.
సార్ ఒకసారి డ్రైవర్ అనుకున్నాం సార్, అది వద్దు సార్, అది సైడ్ టాక్ మొత్తం అందరిది తీసేసుకుంటాం. అదే
Sir.
Good morning to all the delegates, faculty, and members of eAPAPI. On behalf of APA Amlapuram, Konaseema Institute of Medical Sciences, and Organizing Committee of eAPAPICON 2021. I extend a warm welcome to you all with folded hands to this much awaited 48th eAPAPI conference. I am Dr. Subbarao, Chairman, Scientific Committee for this conference. Now, for the recorded version of the formal inauguration of this eAPAPICON 2021.
From Konaseema Institute of Medical Sciences and Research Foundation, Amlapuram. Welcome to all of you for this eAPAPICON 2021, the 48th Andhra Pradesh State Conference of Association of Physicians of India, being organized by API Amlapuram and the Department of General Medicine, KIMS Medical College, situated in this land of greenery, the Konaseema area. I deem it a pleasant privilege to invite the dignitaries onto the dais for this August inaugural function. I call upon Dr. M.R. Sharma sir, Professor and HOD of Medicine, API, Dr. K.V. Raman Rao sir, and Chairman-elect of APAPI, Dr. G. Ishwar sir, and both of them will deliver their message online. Garu, the patron of AP chapter of API and the former Director of Medical Education, Government of Andhra Pradesh, and the former Vice Chancellor of Dr. India University of West Health Science. I now invite Dr. V. Raghavendra sir, Chairman, API Amlapuram, and Vice Chairman of the Organizing Committee of this conference. Cordially invite our Chief Patron, Sri J.D. Satyanarayana Raju Garu, Chairman, Konaseema Institute of Medical Sciences and Research Foundation, Amlapuram, and Chairman and Dynamic Managing Director of KIMS and ex-MLC, Sri K. Ravikiran Verma Garu. Sir also will deliver his message online. I now request our respected Dean of Konaseema Institute of Medical Sciences and former National President of Indian Society of Anesthesiology and National President of Indian Training Society, Dr. A.S. Kameshwar Rao sir, to come on to the dais. Our Principal, Dr. Anandacharya sir, to come on to the dais. P. Subbarao sir, Superintendent of KIMS General Hospital, sir will deliver his message online. I now request Dr. K.S.R. Swami sir, Honorary Secretary of APAPI and Vice Chairman of the Organizing Committee of this conference, to come on to the dais. Sir, Professor and HOD of Medicine, Rangaraya Medical College, and the Honorary Treasurer of APAPI, to come on. Sir, the Dynamic Organizing Secretary of this conference, onto the dais. Sir of Medicine, Dr. P. Subbarao sir, the untiring Scientific Committee Chairman of this academic series, onto the dais. Now I hand over the mic to Dr. M.R. Sharma sir, the President of this auspicious ceremony of this conference, to conduct further proceedings.
Tushar Education and former Vice Chancellor of India University of Health Sciences. Chairman eAPAPICON Dr. Day1 Chairman elect eAPAPICON Dr. G. Iswar, Honorary Secretary of eAPAPICON and Excellency Sri K. Venkataraman, Dean, First National President of ISA and IPS, the Indian Health Society, Dr. S. Thomas, Principal Dr. Anandacharya, Superintendent of KIMS General Hospital, Dr. P. Subbarao, President of eAPAPICON, Dr. C.S.S. Sharma, Chairman Scientific Committee, Dr. P. Subbarao, Organizing Secretary, Dr. K.L. Johar, respected members of AP chapter of API, respected guest faculty, dear delegates, good morning and warm greetings to you all. I heartily welcome you all for this 48th State Annual Conference of Andhra Pradesh chapter of API, that is eAPAPICON 2021, being organized by the APA Amalapuram and Kolasima Institute of Medical Sciences and Research Foundation Amalapuram, being conducted in a virtual way for the first time in the history of APA via the prevailing COVID-19 situation. We started in the right August to conduct this conference in this very picturesque and lush green Kolasima area, with all the natural beauty and hospitality of this area, in addition to the scientific feast. We sent preliminary communication to all medical colleges and APAPI members and printed an elegantly designed conference brochure also. But alas, the sudden imposition of lockdown all over the country, due to the rapidly spreading COVID-19 pandemic, the state conference has to be cancelled for the year 2020, like the similar fate of all other conferences across the country. When we were contemplating to conduct this in March, April 2021, the unfortunate second wave of COVID-19 swept across the nation, and we lost several of our colleagues and young postgraduates who fought valiantly in this pandemic by saving thousands of lives. May their souls rest in peace. Against this background, the Executive Committee of API has decided to go digital this year, and this virtual eAPAPICON 2021 was planned just about 2 months ago only. Thanks to our scientific committee headed by our colleague Dr. P. Subbarao, Professor of Medicine, with the guidance from Dr. G. Iswar, Chairman and Chairman Scientific Program of APAPI for the year 2021, who took all the pains in formulating the scientific program. Hope all of you will enjoy the scientific content. We profusely thank We-Do Technologies, who are instrumental in organizing this virtual scientific arrangement into a reality. Our sincere thanks to our guest speakers and panelists, the live wire for this academic program. We pay Dr. K. Venkataraman for all his guidance, and our Vice Chairman Dr. P. Ramanandarav and Dr. K. S. Swami for their valuable suggestions all through. Dr. K. S. Johar for all his good work for the success of this event, and all our postgraduates who helped a lot in making this a successful presentation with their unfathomable enthusiasm and hard work. We are very much grateful to our patron and managing director of KIMS, Sri K. Venkataraman, and Dean Dr. S. Kanasarao for their constant support, cooperation and guidance. Dr. Anandacharya, Principal, and Dr. P. Subbarao, Superintendent of KIMS General Hospital, for their support, and especially the General Manager Sri Narasimha for his technical services all through. I also thank Sri Ramesh, the General Manager, and the staff of Office of the Dean for their cooperation, especially in organizing this inaugural function.
Hello.
I also thank AP Medical for allotting 6 credit hours for this 3-day state conference. I request all the delegates to kindly keep login for the entire conference, as we need to send the delegate log in record to the AP Medical Council for their final approval before issuing the attendance certificates. Kindly keep in mind this. APAP's future endeavors. Hope all of you will enjoy our efforts. Thanking you all. Long live APAPI and Jai Hind. request Dr. P. Subbarao, Chairman Scientific Committee for this eAPAPICON 21.
Hello. Faculty and all the delegates for our the scientific sessions spans over 3 days, 10th of September, 11th and 12th of September. One day on 10th September has been entirely earmarked to the postcard aides to present their papers and the posters. And day 2 and 3, 11th and 12th of September, orations, guest lectures, and then field expert sessions have been planned. Now, the story behind the opinions of postgraduate students of KIMS and nearby medical colleges have been taken into consideration in selecting the topics and even the guest speakers. We have selected senior physicians with lots of experience and wisdom and juniors with abundance of talent and enthusiasm as guest speakers, and the receptors faculty, keeping the right balance between adults and the juniors. We have kept down the number of subspecialty speakers, or in other words, the super specialty speakers, to less than 30% as per the guidelines of our eAPAPICON. And we have invited speakers not only from our state, but from Telangana and Maharashtra as well. A total of 4 orations, 2 mandatory, and 2, of course, all 4 are mandatory, but 2 are definitely by API China and API German elect. And the 2 other in reverence of great people in the field of medicine that we planned, Dr. Ishmeri Memorial Oration and Dr. Jogarao Memorial Oration that we planned. And the APMC, the APM bringing has been kind enough to about 6 credit hours to all the delegates for attending this conference, and of course, based on strict vigilance on the delegate login and logout data. A total of 4 orations, I said, and then 3 meet expert sessions and 28 guest lectures have been planned as academic content of this event. Now I sincerely welcome you all to actively participate, interact, contribute, benefit, and give us your valuable feedback. Thank you all. This is Dr. Subbarao, Chairman Scientific Committee. Thank you.
Thank you, Dr. Subbarao.
And all, dear delegates, a warm welcome to the 48th Annual State Conference of the Andhra Pradesh chapter of API. Never in the last 100 years of living memory, the medical profession faced the kind of challenge that we are facing today in the form of COVID-19 pandemic. At the same time, it has also brought out several innate qualities from us and helped us to rise to the occasion in a quite effective and successful manner. While we lost several colleagues to the pandemic at such an young age and offer our condolences to the bereaved families, we must also take some comfort in the fact that medical scientists worked hard to identify the virus and its pathogenesis and finally discover the vaccine. I congratulate the organizing team for taking up the challenge and conducting the conference in a hybrid manner and ensuring good number of delegates. Let us utilize this conference to share our experiences and research outcomes on various medical disorders and use them to deliver the best of healthcare to our valued patients. I would like to mention at this juncture that internal medicine is the most intellectual domain in the field of medicine, and let us not rely only on investigations, but mainly on history and clinical examination to choose the appropriate investigation. We are slowly forgetting the intensive care unit, leaving it to the anesthetists and other intensivists. The physician is in a pole position to reclaim the acute medical care units and provide wholesome treatment to our patients, right from the emergency room to the ICU, to the step down, to the ward, and finally to the OP for follow-up. My best wishes and regards to the Chief Patron of API, Dr. I.V. Rao, and I congratulate the Chairman of the Organizing Committee, Dr. M.B.R. Sharma, and heartfelt thanks to the Chief Patron of the conference, Dr. K.V.B. Satyanarayan Raju, Founder and Chairman of Chaitanya Group and KIMS, Amalapuram. And Patrons of the EPICON 2021, Dr. K. Ravi Verma, Managing Director of KIMS, and Dr. A.S. Kameswar Rao, Dean of KIMS, for their support, and to all the esteemed members of the organizing committee. I very much appreciate the efforts of Dr. P. Subbarao, the chairman of the scientific committee, for the meticulous arrangement of the scientific program of the conference in a very prudently structured manner to cover all aspects of internal medicine, and I wish the conference a grand success. Thank you.
At the outset, I congratulate the team of organizers of API Andhra Pradesh chapter, which is conducting its state chapter in Amalapuram by KIMS professors. And particularly, my sincere thanks go to the team headed by Professor D.M. Sharma and Professor Subbarao for their unstinted and Herculean task, in which they have received an enormous number of papers amounting to about 217 and 230 posters, and they have given us a huge academic feast by arranging about 28 lectures and orations, 4 orations from all parts of southern India, including Telangana, Andhra Pradesh, and Karnataka, and so. And at the outset, I congratulate all my office bearers and the doyens of the great institution that is Associate Mission of India by giving me this opportunity of a chairman-elect for this year 2021 and 22. And they have given me, they have shouldered me an Herculean responsibility, particularly to guide this august institute and steer it forward. And I will hope and expect and experience the unstinted support of the doyens of our association in the former chairman-elect and many of the academicians to give me their support to take this august body into a future organization in this difficult periods of a pandemic of corona. In spite of these difficulties and restricted amount of availability of manpower and other things, the team organized by Dr. Professor Sharma and Professor Subbarao has made a brilliant comedown in the show of our API academic work. And they have arranged a very, very good feast of lectures and academic activities, for which I congratulate them. I am taking the responsibility from my young predecessor, Dr. and Professor Ramana Rao, who has headed this post of the chairman in the last year, and hope I will carry this mantle in for further to heights and make this academic institute proud of my services in the coming future. Thank you one and all.
Next, Chairman-elect. Now I request our Dean, Dr. A.S. Kameswar Rao, to give his message.
Respected President of today's function and organizing Chairman, Dr. A.B.R. Sundar, Producer Day1 Medicine KIMS and former Director of Medical Education Andhra Pradesh. Chief guest of today's function, Dr. Ravi Rao, Patron eAPAPICON and former Vice Chancellor of Dr. A.K.R. University of Health Sciences and also former Director of Medical Education of Andhra Pradesh. Vice Chairman, Dr. D. Raghavendra Rao, also Chairman of API Amalapuram. Dr. K.S.R. Swami Garu, Professor of Medicine KIMS and also Honorary Secretary eAPAPICON. Honorary Treasurer eAPAPICON, Dr. C.S.S. Sharma Garu. Organizing Secretary of the Conference, Dr. Jawahar Garu. Scientific Committee Chairman of the Conference, Dr. P. Subbarao. Dr. Anandacharya, Principal KIMS. And all the invited guest speakers of the conference, delegates, ladies and gentlemen. Very good morning to you all. First of all, let me thank eAPAPICON for allowing us to host the 48th State Conference of eAPAPICON KIMS Amalapuram. And I thank our beloved Chairman, Dr. Satyanarayana Garu, and Managing Director of KIMS, Raghuvaran Garu. for encouraging and providing us the venue to host the conference in the year 2020 actually. But due to COVID pandemic, we could not conduct physically, and the same situation is going on this year also. It is decided to conduct the virtual conference by eAPAPICON for 3 days on 10th, 11th and 12th September. I wish to mention here that the King's Medical College has a standing of 17 years and hosted several departmental conferences. To mention a few, 2 state conferences of anesthesia and 1 national CME of anesthesia conference were held here, and 1 national conference of pulmonology and 1 state conference of pulmonology, and also the state conference of orthopedics, and the regular smart conferences organized by the students of the medical college, pre-final year students, successfully for 5 years, inviting all the students from various colleges of the country, and more than 10 workshops on 2 days. That is a regular activity going on in this. With all this experience, the management has decided to host the first physicians conference in a grand way in this institution, but unfortunately could not do it physically due to COVID pandemic. But this virtual conference will definitely benefit the postgraduates and practicing physicians to update their knowledge as best speakers of national repute selected as faculty for the conference. And already 6 great hours mentioned by our chairman, and that is another advantage of attending this conference. I wish the virtual conference a grand success. Thank you, Ananda.
Professor HOD of General Medicine, National Institute of Medical Science. Respected Chief Guest of today's function, Dr. I.V. Rao, ex-Vice Chancellor and DME of Andhra Pradesh. It is my privilege to be the part of this inaugural session. As Sir has told that because of COVID, we have to shift to e-conference. We are very much eagerly waiting for this conference, and we have so many different ideas to make it more grand and more successful, but won't be possible, would not have been possible to do that, even though it would be a very nice experience for my postgraduates and my faculty and all other participants who will be joining this session, this scientific session and all. I would like to request, or it's my personal request, that whatever proceedings of scientific session will be there, I would like to publish it in the form of a book. I have already talked to some publishers, and they are ready to publish it having ISSN number. So it will be a permanent record in our library, and it will be a kind of things which will be kept for academic purpose and for references for all other people. It's a learning experience for us also, people like us who is new to this. It will be definitely a memorable event to work with all senior learneds of the medical profession. I wish it a grand success, and it will be a very encouraging things for us to part of that. Thank you very much.
Dr. Rameswar Rao, Chairman Organizing Committee, Dr. M.V.R. Sharma, Secretary, Dr. Jawahar, Dr. Raghavendra Rao, Vice Chairman, Organizing Committee, Dr. Subbarao, Chairman Scientific Committee, Dr. Amdacharya, Principal, King's Medical College, guest speakers, senior physicians, delegates, postgraduate students, and the other invitees. I deem it a privilege to be associated with this 48th annual conference of the AP chapter of the API. At the outset, I would like to compliment the management of King's Amlapuram for coming forward to host this conference. And unfortunately, due to COVID pandemic, this conference scheduled to be held last year, that is 2020, could not materialize. And this year, the KIMS management stuck to their promise and were very proactive to conduct the conference on an online platform. The AP chapter of the API, since its inception in 2003, has come a long way, and the membership has gone beyond 1,000 delegates, 1,000 members, which is really commendable. The chapter has been conducting an annual conference every year and 2 year conferences, providing very valuable scientific updates in medicine to the practicing physicians and the PG students. It has also created a platform for the PGs to project their original work through platform and paper and poster presentations. In fact, the entire day preceding the conference has been allocated to these presentations, which is a boon to the graduate students. The entire medical fraternity has been overwhelmed by the care rendered to the COVID patients last year and also this year, and the physician community played a vital role in the management of these COVID patients. A large number of lives have been saved, though several have been lost due to the pandemic, and it is a tragedy that many of the physicians have also succumbed while providing care to COVID patients. We all pay homage to them and their families for their sacrifice and selfless service in saving many lives. The COVID management protocols have been changing with the evolving pandemic, and the physicians had to be abreast with the latest developments. And this has been made possible by periodic webinars organized by the various regional chapters of the API. And in this context, the webinars conducted by the Visakhapatnam and Tirupati chapter need special mention. Dr. Alani Mohan, Professor of Medicine, SWIMS, and Dr. Krishna Prasanthi have been providing the latest information in COVID management in various online platforms, and it is a very commendable gesture. It is a matter of immense pride that our physician, one of our physicians and a professor of medicine, Dr. Rambabu, was heading the State Task Force Committee for COVID Management at Vijayawada. He was providing the scientific inputs to the government of AP in their public health management of COVID. He also has been instrumental in organizing weekly webinars on COVID-related issues, bringing in experts from within and outside the country for their advice. The task force was also training medical, paramedical, and nursing staff in the healthcare of COVID patients. It is also worth mentioning that our physicians have been actively involved in educating the public regarding the pandemic and also formulating strategies in the containment of COVID with government officials in the districts. All in all, one can say that the physician community of the state rose to the occasion and took very active part in the young physicians. Experience of more than 4 decades as a physician has taught me the value of complete clinical examination. With a plethora of investigations which are available today, and
The legal examination today has taken a backseat and it is becoming a routine practice to entirely rely on investigations to treat patients. It can prove very costly sometimes, and the investigation should be utilized only to confirm the clinical diagnosis. Now, this conference provides a lot of insights into the various aspects of medicine for expert speakers to evaluate and elucidate each one of them, and one can raise the bar of knowledge to a higher level, and I'm sure you all will be enjoying scientific content and become wiser for a better patient care days to come. I wish the conference all success and express my thanks for giving me this opportunity to be with you today.
At the outset, I express my heartfelt thanks to our chief guest, the founder and the patron of the eAPAPICON as a registered body, and the former TME and the Vice Chancellor, Dr. Ravi Rao, for sparing his valuable time and coming all the way to grace the occasion despite the present situation. I express my sincere thanks to Dr. K.V. Ramanrao, Chairman eAPAPA, Dr. G. Eswar, Chairman-elect and Chairman Scientific Committee of eAPAPA, Dr. M.B. Shamgaru, Chairman of the Organizing Committee, Dr. Arvind Rao, Vice Chairman Organizing Committee, K.S.R. Swami, Honorary Secretary eAPAPA and Vice Chairman Organizing Committee, for their continuous guidance and support all of you. My special thanks to Dr. P. Subbarao Garu, our untiring Scientific Committee Chairman, for formulating this academic vision. I thank Dr. C.S.S. Sharma, Honorary Treasurer, eAPAPA, for gracing the occasion with us. My special thanks to our Chief Patron, Chairman Kim Salar, and Chaitanya Education Institutions, and ex-MLC, Sri K.V. Satyanarayana Raj Garu, and Patron and ex-MLC, our Dynamic Managing Director of this institution, Dr. K. Ravi Verma, and our Dean, Dr. S. Nageswara Garu, for their continuous encouragement and support. I also thank our Principal, Dr. Ananda Acharya, and Superintendent Teams Hospital, Dr. P. Subbarao. Special thanks to the Executive Committee, members of the eAPAPA, for their valuable suggestions. My sincere thanks to the AP Medical Council for allotting 6 credit hours from this video conference. Sincere thanks to Dr. G. Narasimha GM Teams for his technical advice all through, and Sri Ramesh, GM, Balu, Suresh, and other staff of office of the team for their cooperation. My special appreciation and thanks to BDO Technologies and its GM, Mr. Mother, for their technical support for this workshop. My thanks also to the faculty of the General Medicine Department, Teams Medical College, and members of the EV Allapuram branch for all their services. My heartfelt thanks to all of them and untiring postgraduates for their excellent groundwork to make this event a grand success.
Now I invite AP Medical Council Observer, Dr. P.S.S. Sharma Garu, for his message. Sir, Sharma sir, please log in. Dr. P.S.S. Sharma, Observer from AP Medical Council. Bear with us, we are waiting for Dr. Sharma. Dr. Sharma, if you are having any trouble logging in, contact our technical staff. You have the number with you. Yes, because of technical difficulties, you could not log in, I believe. Now let's continue with our original program. After the colorful inauguration, let's start off with the guest lectures from two eminent personalities, none other than Dr. Ladi Mohan and Dr. G. Narasimha Garu. Well, they need no introduction. They are well known to you all. Now, the first lecture would be by Dr. Ladi Mohan. Diagnosis of extrapulmonary tuberculosis, what is new? Brief biodata of Dr. Mohan. He did his MD medicine from AIMS, New Delhi, FRCP, Edinburgh, FMS India, FCCP USA, FICP, PG Diploma EPID, Professor, Senior Grade and Head of the Department of Medicine, SWIMS, Tirupati. Best outgoing student, first among the first ranking students, and with 25 gold medals, wow, and prizes including the Sri Mohanlal Big Gold Medal from AIMS, New Delhi, Outstanding Review Award from API, first of the 4 Shakuntala Amirchand prizes from ICMR, AP's Best Scientist Award in 2008, Best Teacher Award from Government of Andhra Pradesh in 2011. He has got to his credit more than 290 publications in reputed, indexed, international and national journals. He has edited 4 books, including the very popular textbook of tuberculosis and non-tuberculosis diseases. And then he is the editor of Indian Journal of Chest Diseases and Allied Sciences. He is also the associate editor of Lung India. He is the member of International Advisory Board for Hutchinson's Clinical Practice. In the 4th edition, he is a part of the API and is also the member of Governing Council of IACF. Well, I would say a rare blend of physician, teacher, and researcher. Now, I request Dr. Ladi Mohan sir to deliver the lecture.
Good morning, sir. Thank you very much, sir, for those kind words of introduction. I request permission to share my screen. The topic of the day's presentation I have chosen is a topic of importance to all the physicians particularly. I will summarize in the next 25 odd minutes what is new and probably exciting in the diagnosis of extrapulmonary tuberculosis. Now, I submit that I have received no funding for this talk and I have no conflict of interest to declare. I have structured this presentation under the following headings. I will first deal with the crux of the terminology of EPTB and the case definitions therein, keeping in mind the postgraduates who are listening to this presentation, I presume and I believe. I will discuss about the burden of the problem because only recently we have objective data regarding the burden of the problem of EPTB in the form of evidence. We will also talk of in whom we should screen EPTB, what has been the guideline. I will focus on what is exciting and new in the diagnosis of EPTB in terms of imaging as well as laboratory diagnosis. I will deal with the most controversial area, which is the treatment of drug susceptible EPTB. In the interests of time, we have the Indian standard time, not the Indian stretchable time. So I will focus on drug susceptible TB only. I will not be talking about drug resistant EPTB. I'll touch upon the treatment duration and also the role of the corticosteroid treatment. Quickly going on to what is EPTB. It looks trivial, simple and fundamental, basic, which in the last couple of examinations, when I went as an external examiner, most postgraduates were confused on this. Extrapulmonary TB refers to active TB disease involving one or more extrapulmonary focus without pulmonary parenchymal involvement. There are 2 other terms to add to confusion: disseminated TB and miliary TB. Disseminated TB refers to active TB disease characterized by concurrent involvement of at least 2 non-contiguous organ sites or demonstration of mycobacterium tuberculosis by molecular diagnostic tests or by culture in the blood or the bone marrow, and a particular reference to a peculiar form of disseminated TB, which is miliary TB, earlier thought to be disease of children, but now quite rampant in adults and the immunosuppressed as well. It results from a massive hematogenous dissemination of tubercle bacilli, which results in tiny discrete foci, usually the size of millet seeds, more or less uniformly distributed in the lungs and other viscera. The point to note is intrathoracic, mediastinal, and or hilar lymph node TB or TB pleural effusion without radiographic abnormalities in the lungs is classified as ePTB. Even intrathoracic lymph, though it is intrathoracic, it is ePTB. Similarly, miliary TB, which is a systemic disease with involvement of multiple organ systems virtually, is categorized as pulmonary TB because there is lung involvement concurrently. Keep this in mind when you try to understand the epidemiological data. These case definitions should be kept in mind when you interpret information regarding ePTB. Having said this, what are the current case definitions for ePTB? I quote the case definitions which are evidence-based case definitions which were put up in the index TB guidelines that were published in 2017 after a 3-year deliberation periodically. This is the case definition referring to ePTB as presumptive, bacteriologically confirmed, and clinically diagnosed. Presumptive is simple, one who needs to be investigated. We do not use the word suspect these days because of, in the era of political correctness, suspect has some negative connotation. This is also clear where it is clinically diagnosed. But please pay attention to bacteriologically confirmed case is a patient who has a microbiological diagnosis of ePTB, which is microscopy, culture, or a validated PCR-based test. Validated PCR-based test means CB-NAT, which is the expert MTB RIF, and the LPA, and so on. Presumptive, bacteriologically confirmed, clinically diagnosed case. So, postgraduates, when you make your discharge summary in your wards, please make a note. What is the diagnosis of ePTB? Don't simply discharge lymph node TB, disseminated TB. Please indicate what type of case it is. It is the physician's domain because most cases of ePTB are system related and they present to the physician. They don't go to the pulmonary department. And PUO is a bulk common presentation which is seen by physicians who pick up TB at obscure sites. And therefore, the postgraduates should familiarize with the current case definitions. We had cited these in our publication, which was published about a month ago. So what is the burden of ePTB? We know a lot about the burden of pulmonary TB, but it is necessary to know how huge is the burden of the ePTB globally. The 2020 Global TB report is the latest till the month of October. In September, this is the latest report. This report has the latest data from 2019. The ePTB constituted 16% of the 7.1 million incident cases notified in 2019. What is the scene in India? If you look at the Government of India data 2020 TB report, which has breakup of the ePTB. Site-wise, ePTB constitutes nearly 1/4 of all the notified cases of TB. I purposefully did not quote the 2021 India TB report because 2020 data on TB are skewed because of COVID. It is commonplace understanding that today in India, nearly 1/4 of all the TB burden is ePTB. Now, having said this, what is the organ involvement in ePTB? This is a very famous cartoon which was published a while ago, which is still relevant. If you look at the HIV negative individuals, EPTB constituted 80%, and the pulmonary TB constituted 80%, EPTB constituted 20%, 15% pure EPTB, pulmonary and extrapulmonary TB together, that is the disseminated and miliary varieties, in 5%. Pleural effusion, lymph node are the common forms of EPTB, with all others are seen in about 5 to 10%. If you see the HIV seropositive individuals, only 1/3 have pure pulmonary TB. EPTB is seen in about 2/3 of the patients. And this includes both pure isolated EPTB as well as EPTB with associated pulmonary involvement as well. This is one of the most cited articles in 100 years that were published in the IJMR. We recently came out, after about 17 years of that earlier article, the extrapulmonary TB current situation today, we brought out in the July 21 issue of the expert reviews. I will be using some data from that review. It was not only a narrative review, but we did a systematic review, meta-analysis of what had happened during the recent past about extrapulmonary TB. So when we look at the diagnosis of extrapulmonary TB in clinical practice, more often it has been a diagnosis of elimination rather than diagnosis of confirmation. However, in the last 5-6 years, things have changed, and we are into the era of evidence-based EPTB. So what is the diagnostic approach and what is new in this diagnostic approach? There are two questions to be answered when we deal with extrapulmonary TB. Where is the disease? This is possible by close clinical examination, imaging, endoscopy of various kinds. This is the anatomical localization. Having done that, the second question to be answered is, what is the diagnosis? Is it TB or not TB? This is possible by testing the appropriate tissue or fluid by histopathological, microbiological, and molecular methods to obtain a proof of diagnosis. A word about a very old, a decade-old Gazette notification of Government of India. We should not use serological diagnostic tests for diagnosis of TB. This is particularly relevant for EPTB because this is history now. We don't use these tests. I based the content a lot from the index TB guidelines, which were the initiative of the Central TB Division with the WHO and the Department of Medicine at All India Institute. I was one of the leads for these guidelines, and we published this in 2017 in the Indian Journal of Medical Research. So the question is TB or not TB? TB or not TB is diagnosed based on lab testing. Lab testing includes imaging. What is new in imaging? Many times, if we are fortunate, we get a clinical clue like this to access and biopsy, or a swelling like this to put a needle in, or fluid like this to test. This is all the images and the clinical photograph of the same patient, but often we are not that lucky. So we have to look into the eye very carefully. A seemingly subtly normal looking chest X-ray. The fundus exam shows choroid tubercles. The chest CT shows miliary pattern, and there is CNS involvement in the form of meningitis as well. So careful clinical examination for a rash or a lump or a bump or even the fundus examination is crucial. The conventional radiograph, ultrasonography, computed tomography, MRI is well known. But the game changer for EPTB has been the PET CT and PET MRI. This provides two useful benefits. One is disease extent mapping. Where all is EPTB existing in the given patient? It is also helpful for the stopping rule. When can we safely and confidently stop the treatment for EPTB? So this is the pre-treatment photograph. See these brightly lighted bulbs. bright light bulb like areas of increased uptake. This is the PET image. This is the fusion image. After ATT, completion of the treatment, these bright light bulbs have switched off. So this light is off. So you know, yes, there is no activity. While conventional CT may show a 1 centimeter or larger shadow, the activity, whether disease is active, is known by doing a PET CT or PET MRI. It is costly, it has radiation exposure, it is not widely available. Importantly, it won't tell you what the disease is. It won't tell you that it is TB, but it will tell you where all is the disease, and whatever is the disease, it is active or not. So if you keep this caveat in mind, you can easily utilize this imaging modality. So since the talk is regarding what is new, I focused on what is current and new in terms of imaging as far as localization, disease mapping, and stopping rule in terms of extrapulmonary TB. The diagnostic yield for conventional diagnostic tests. No, I'm not going to provide you a extra Zoom facility or a binoculars to read this slide. The conventional tests of cell count, biochemical characteristics, protein, sugar, ADA, interferon gamma, and the histopathology and all. The specificity is high, but sensitivity is low. This was the era of rule out everything, therefore it may be EPTB because it is common, that era. But we have moved forward. What is new? What is game changing in the diagnosis of extrapulmonary TB? We have 4 new technology classes. The first technology class, which is almost available to everybody in gully in India, are the moderate complexity automated NATs, nucleic acid amplification tests for detection of TB as well as resistance to rifampicin. These are the expert MTB is there in every medical college in the country, more or less, every district in the country. It is available in the field level. In fact, during COVID, this TrueNat and this expert were diverted for COVID diagnostics also. So the TB program did a service to the nation indirectly, unassumingly for the diagnostics. So expert MTB RIF and TrueNat are virtually available in the length and breadth of the country. Expert Ultra is due for expansion. The other expert, for example, gives you only rifampicin resistance detection. It does not tell you about INH as it is existing now. So moderately complex automated NATs include the Abbott real-time MTB and the Abbott real-time MTB RIF INH, the products from Becton, Dickinson, Roche, and so on. A word about TB LAMP also. We also have low complexity automated NATs, which is what I told just now, and the line probe assays, which are routinely used in clinical practice as per the universal drug susceptibility testing algorithm. Upfront today, when we see a patient with TB under the National TB Elimination Program, the first test that is done is expert. Hallelujah to the smear and solid culture. A word about expert Ultra. Expert Ultra is different from the routine gene expert, which we are having. It incorporates 2 different multi-copy amplification targets, the insertion sequence 6110 and the insertion sequence 1081. It has a larger DNA detection chamber. So this is the chamber for the conventional expert, which we are using now for the last 3-4 years. This is almost double the size. This chamber is double the size, 50 microliter tube. And the important thing is it has a limit of detection of 16 bacterial colony forming units per ml compared with 114 colony units per ml for expert MTB RIF. So it is a very useful tool. A word about TrueNat. TrueNat is not CBNat. TrueNat is a chip-based diagnostic method. And TrueNat MTB and TrueNat MTB Plus, they use the real-time micro PCR with a chip for detecting MTB and the rifampicin resistance in the DNA that is extracted from a sputum specimen. We also have the moderate complexity, the Becton-Dickinson, the LaRoche and other products which I have told. These are all on the threshold of field confirmation, and maybe before I retire, I will see them in the NTEP in India. A word about LAMP. LAMP has emerged as a good replacement test for sputum smear examination in addition to UV microscopy, because this manual assay requires less than an hour to perform and can be read with the naked eye under the UV light. But the thing is, it does not detect drug resistance. It is a yes/no test for the presence of M. tuberculosis. Lot useful in pulmonary TB, not much useful in EPTB as it is today. But this is new. So when a patient with a lymph node TB can have a lung lesion, and if you have access to LAMP, may come through the program, and we may be able to diagnose within 1 hour in a reliable, rugged, and a reproducible way. This is positive, this is negative. No need for any confusion. Now, what is the sensitivity and specificity of extrapulmonary TB by various methods? The conventional methods have relatively lower sensitivity, but a good specificity. In this being a conference of Andhra, I would say Dorikte Donga. The line probe assays, they have a good specificity. Two, if we look at the pooled sensitivity and specificity for expert, for CSF, lymph node, aspirate, lymph node biopsy, pleural fluid, urine, bone and joint fluid, peritoneal, pericardial fluid. You may ask me, what about eye? What about skin? Yeah, we need to have data on that. We don't have large published data on that. So data will get added. So let's move forward with what we have. See the specificity, pretty good, decent. Sensitivity is also fairly tolerable. This, we have pulled the sensitivity and specificity from our own data from several centers in India. We did a systematic review meta-analysis for this paper. It is not a narrative review alone, but this is an analytical review, SRMA, systematic review as well. If you look at the specimens, if you look at compare global data versus Indian data, specificity is damn good. Sensitivity for CSF and lymph node TB are quite good. So as on date, we are really ready to deal with the CSF and lymph node TB. Let us move forward with these. Other data will get added. So if you look at the diagnostic accuracy, same. Pooled sensitivity for CSF, pooled specificity, overall pretty balanced. 3 fluids, CSF and lymph node. This data got updated. Earlier, sensitivity was lower for with expert alone. With expert ultra, the sensitivity also picked up. This is expert ultra. Sensitivity also picked up for pleural fluid. So what are the recommendations? New latest recommendations. Last month, these data were issued by the WHO. TB meningitis, expert or expert ultra should be used in the CSF as the initial diagnostic test. The new addition is rather than smear microscopy and culture. It is a strong recommendation. But please remember, if CSF expert or expert ultra is negative, don't withhold anti-TB treatment. This is not a rule out test. It is a rule in test. If you catch it, you know whether it is MTB, whether it is R resistance detected or not. For TB meningitis, you have to use the expert as a first line test. For lymph node aspirate, lymph node biopsy, it is a conditional recommendation, pretty useful. It is actually a replacement for microscopy and culture. Please go ahead and use it. When you look at pleural fluid, peritoneal fluid, pericardial fluid, synovial fluid, and urine, it is a conditional recommendation, moderate certainty of evidence for pleural fluid, low certainty for peritoneal fluid, synovial fluid in the other fluids, and a very low certainty for pericardial fluid. But still, if you have access to free expert testing as it is available in most medical colleges. Please do it. If the patient has to pay money through their nose, then you can have a second thought. But expert being available in the program, it is a do win-win situation. When you look at HIV positive adults and children with EPTB, it is said expert or ultra is the upfront test than culture and phenotypic DST for rifampicin resistance detection. It is a strong recommendation. This is lymph node, pleural fluid, CSF, and so on. But if you look at peripheral blood PCR in HIV positive individuals, especially CD4 counts very low, less than 200, probably less than 50. It is a conditional recommendation, low certainty of evidence, but worthwhile testing if nothing else is found in a PUO patient. This is new. How new? August 2021. This is August 2021 recommendations of the World Health Organization based on evidence. So what is the diagnostic algorithm? When you have a clinical suspicion, look for anatomical localization, find out the fluid. If it is available, do procure the fluid, test with expert upfront. It is detected, fine. Not detected, it goes as clinically diagnosed EPTB. Not available, do other diagnostic testing, establish an alternative diagnosis. So you have the categories, case definitions I have mentioned upfront earlier: bacteriologically confirmed EPTB, clinically diagnosed EPTB, and you have an alternative diagnosis. A word of caution regarding drug sensitive TB, extrapulmonary TB treatment. Now, how long do you treat? This is a good question. The arthropods and the neuro groups like to treat for 12 to 18 months. So what is the evidence available? While we don't want to contest anybody's view, we have to go from the era of emotion-based medicine to evidence-based medicine. Now, if you remember from 2020, even the program is giving daily treatment with 4 drugs in the intensive phase and HRE in the continuation phase. Till now, we used to give ethambutol for 2 months. Now, ethambutol is continued throughout the treatment. If you extend beyond 6 months, 9 months, 12 months, 18 months, how safe it is on the eye. We are now seeing ethambutol eye toxicity, which we did not see so frequently before 2020. 2 of my projects are running with regard to ethambutol eye toxicity. We are doing the visual evoked responses as well as perimetry serially in all patients to document the burden of ethambutol toxicity with the changed regimen. What is the stopping rule? We don't know. PET-CT, PET-MRI gives some kind of exception, but not always available. For peripheral lymph node TB alone, if you don't do the chest X-ray and don't do the ultrasound, you may miss a disseminated TB. And abdominal TB, broadly the guidelines say 6 months. For TBM, the index TB said 9 months. The other guidelines say 9 to 12 months. Neurologists want to treat for a lifetime. For bone and joint TB, minimum is 9 months, extendable to 12 or 18 months. Pleural TB, certainly 6 months. Pericardial TB, 6 months. Disseminated miliary TB, peculiarly, most guidelines say 6 months, but it may be longer if TBM or bone and joint TB is present to the tune of 9 and 12 months. So what is certain? Do we know? We don't know. We have to wait for more evidence to emerge. But it is clear the big number here is 9 months. 2 months of intensive phase and 7 months of continuation phase. Maybe extendable to 12 months seems logical. Beyond that, individualize the decision to the patient. One size does not fit all. With upfront universal drug susceptibility testing being available, it is possible to logically say it is TB or not TB. Quick word about corticosteroids. TB meningitis recommended. Pericarditis recommended in HIV negative. And pleural effusion not routinely recommended. Corticosteroids may be used in HIV seropositive people also when other life-threatening opportunistic infections are absent. Whoever is reminding me, I am using the introduction time to use my presentation time. So bear with me. The conclusion I wish to convey, leaving aside controversies, is clinical presentation of EPTB is varied. Constitutional symptoms are not evident. Atypical manifestations, no symptoms, for example, will result in a delayed diagnosis, misdiagnosis, misdiagnosis. We need a high index of suspicion. Imaging will tell us where the disease is. Testing upfront with molecular tests will tell us what the disease is. And in conjunction with the liquid culture, CBNAT, LPA, it is possible to know within a short period of initial diagnosis whether it is drug sensitive or drug resistant TB. The treatment of drug resistant TB is an entirely different ballgame I didn't deal with today. Anti-TB treatment with corticosteroids, where indicated, will be life-saving. And I once again salute to all the teachers of medicine, the esteemed faculty of medicine, who have spent their lifetime battling TB. While pulmonary TB may go to some other specialty often, but EPTB is a physician's domain. It is our proud privilege to diagnose and to treat EPTB with certainty, with scientific rationale, and adding life to years. I conclude my presentation here. Thank you, sir. If there are any queries, questions, I'll be glad to take them.
Hello.
Yes, sir.
Dr. Mohan, am I audible? I'm Dr. Ramandra speaking.
Yes, sir. Welcome, sir. Good morning, sir.
Good morning. Good morning. How are you?
I'm ticking like a time bomb, sir.
Thank you. Sir, one question, which is simple, of course. In the incidence I'm asking, suppose the diagnostic yield is around 30%, 40% for EPTB, what I understand. Suppose, what is in your experience, how many cases you will treat clinically, circumstantially presumptive ETB and diagnose EPTB? For example, smear, culture, or whatever you employ, including strong imaging findings. Is it 50-50 or 40-60?
Brilliant. It's a very good question, sir. This is the paper we are writing up for publication right now. So I have the data on my hand from my center. Sir, today with upfront expert testing, clinically diagnosed EPTB is less than 20%. We try and fail. There are situations in neuro TB, bone and like spinal TB, where there is no tissue to access. Very difficult to access. Otherwise, broadly, 70 to 80%, it is possible to establish the diagnosis of TB on molecular, smear, culture, and histopathology. If you couple all these things, it is possible to catch EPTB in a certain way. We had serially 2 postgraduates working on their MD thesis, coupled with our own program data. 60 to 80% definite certainty. Molecular tests are possible to the tune of 60%, especially CSF and lymph nodes, sir.
One more question, sir. Just in HIV patients who are on ART, nowadays dolutegravir is very much used in place of NNRTA. So in this scenario, in extrapulmonary TB, EPTB, which is common in patients with HIV, is there any change in the regime nowadays? Earlier, we were hesitant.
Yes, sir. This is a good question. I did not touch upon it because the time constraint given to me was 30 minutes. The NACO and the NTEP have a good crosstalk these days, depending upon the baseline assessment of the HIV patient, the CD4 counts, the viral load, etc. The regimens are tuned. The standard NTEP treatment regimen remains same, sir. RHZE for drug. We know today with universal drug susceptibility testing that it is drug susceptible TB. So depending on because earlier the problem was we did not know. Only after, even if we test pulmonary, we will know the drug susceptibility status at 12 weeks. Today we know upfront within 24 to 48 hours of testing what it is. So the NTEP regimen has 4 drugs to begin with in the intensive phase and 3 drugs in the continuation phase. And the timing of initiation there are guidelines from NACO depending on the patient's stage of HIV disease. And if we strictly follow the algorithm, we will minimize the issues related to the paradoxical deterioration or the iris or the drug-drug interaction.
Thank you, sir.
Dr. Alladi, may I ask a question?
Yes, sir.
Namaste. Alladi, nice to see you and hear you. I miss you people a lot. Just I have one question. 1978 National TB Control Bulletin, they made a Montauk test grade 1, 2, 3, 4. The grade 3 more than 35 mm, grade 4 bullous lesions or central necrosis. If that is there, don't investigate, go for ATT. Still, it works good?
No, sir. I read that bulletin you were referring to. That is older data because tuberculins have changed from that time also. Presently, the TST positivity tells two things. The same information you get from IGRAS. It says, one, there is evidence of infection with M. tuberculosis. It does not tell anything about disease activity. Two, it says the immune status of the person in whom we have done the test is good enough to mount a delayed type hypersensitivity reaction. Only in very small children, less than 1 year old, maybe sometimes less than 5 year old, a TST or a BCG test is taken as evidence of disease activity. In adults, we being adult physicians, TST positivity simply means individual is infected. So now the program also is making inroads. The next thing to come is the treatment of LTBI. We don't talk of chemoprophylaxis because prophylaxis is something you do before something starts. Here the individual is already infected. So we treat a latent TB infection. It is the guidelines are due to MHSR. The basic problem is if we miss LTB, if we label active TB as LTBI and treat, it will become isoniazid monotherapy.
Any data, Montauk's grade 3, I mean more than 35 mm or central necrosis bullous lesion, done PET scan. PET scan shows no disease inside, but only immunologically is very strong. Any data on that? Am I audible already? Hello? Hello? Hello?
Yes, sir. Audible.
My question is clear to already. Is there any data where Montauk's is more than 35 mm or central necrosis or bullous vesicle lesions, having done PET scan?
Sir, please ask once again.
Like already, I want a small question. Is there any data? Patients have Montauk's more than 35 mm induration, central necrosis, vesicular or bullous lesion. A PET scan done on this data? Any data?
Sir, PET CT has been used. Sir, normally the TST positivity is not the indication for PET CT because your rheumatology people, before you give infliximab, etanercept and other monoclonal antibodies, you want to rule out active TB.
Yeah, that's right, exactly.
Hard published data in a large body in a systematic study are not available for only TST positivity stratified as per the size and type of reaction with PET CT, sir. Large data are not available. There are some reports.
We started using infliximab in the late 90s, 96, 97 onwards. First started in Western countries. Whenever a Montauk's was positive on infliximab, a significant death due to extrapulmonary tuberculosis, mainly TBM. Montauk's negative were not there. Then the guidelines came. You once Montauk's positive, after 1 month of ATT, go for biologics.
Yes, sir. Many people are doing HRCT. Professor Anand Malviya, he also had a long discussion. He published one paper that in the footnote he gave on some acknowledgement what we told. Basically, chest screening has been done using HRCT for pulmonary, but systematically using in every patient PET CT, there are no large studies.
It is mostly extrapulmonary tuberculosis, not pulmonary.
If the clinical examination shows a lead or basic imaging, chest X-ray and ultrasonography give a lead to extrapulmonary site before giving infliximab. It makes sense to do a PET CT if you have access to that. At least you know what is the activity, and you can put a needle there and see it is TB or not TB.
Thank you, already. Nice talk. Nice to see you also.
Thank you, sir. Thank you, Dr. Aladi Mohan Garu and Dr. Nasimula Garu for inspiring him to talk more and more about his favorite subject. Now, for just 1 minute, for Dr. P.H. Sharma, Observer, AP Medical Council, to give his message. Dr. Sharma ji.
Good morning to all of you. I'm very happy to be here at this wonderful conference. And my namaskaram and pranams to Mohan sir and my good friend Dr. Tilak, who is my senior in the college, and we are very happy to see all of you here, Narsingh also. And also, when I bring greetings on behalf of the AP Medical Council to all the participants and also the faculty members. And it's a really wonderful opportunity. And so, friends, when all of you know that, so now in the present day of technology and this present COVID here and virtually, and of course, I'm very happy that Dr. Subbaraw and Dr. Sharma Garu have all the trouble, and they are organizing the conference in a wonderful way. So once again, I bring greetings on behalf of the AP Medical Council, and I hope that all the participants will have good knowledge, they become better, good doctors. Once again, I thank all the organizers for giving an opportunity. Thank you very much, sir.
Thank you, sir, Dr. Sharma ji. Now for second guest lecture by none other than Dr. G. Narasimhan Garu, an international figure, virtually the father of rheumatology in the states of Andhra Pradesh and Telangana, and the inspiring force behind many rheumatologists of the present times. The topic is the current concepts in systemic lupus erythematosus. Now for the biodata of Dr. Narasimhan Garu. He is a former professor in the Department of Rheumatology, NIMS, Hyderabad. He is a former Dean, Indian College of Physicians. He is a former president of eAPAPICON. He is also a former president of Indian Rheumatological Association, the Conference on Medicine and Rheumatology, and he is organizing secretary chairman for many of these committees. And regarding his publications, well, the list is a too big one. Right. Sir, Dr. Narasimhan Garu, kindly start.
Thank you, sir. Thank you, Dr. Subbaraw Garu. At the outset, I am immensely thankful to API and all its members. I feel API, I'm part of that. I was a former chairman of API. Me, Ivira, together we started this way back 2003. Now it has become a very big. I am immensely thankful to Dr. Jawar, Dr. Subbaraw, Dr. Ivira, Dr. Tilak, and Dr. Aladi, Dr. Madan, and Dr. Sharma, and to take all the names, there my tip of the tongue. I feel so happy to see them in the inaugural function. Very nice. My topic today is essentially current concept. My friends, essentially when I was a student, I know, and every year the concept the mortality due to SLE before corticosteroids, less than 30 to 40% of the people used to survive more than 5 years. After corticosteroids, only nearly 40% will survive. After immune modulation started, nearly more than 50% are living now with a better understanding of SLE. Next slide. Next slide, please. Hello, somebody be attentive. Next slide. Now, with the advent of newer modalities of drugs, better understanding of autoimmunity and organ damage, and various measures of activity and damage assessment, SLE patient lives near normal. Now, previously, kidney was second cause of death after infection. Number 2 was CNS. Now, kidney no more number 1. Brain also number 2 continues. Infection is number 1 cause of death. That was the coming down with better understanding of the natural history of the disease. Today, SLE patient is not dying because of SLE. It dies of because of increased coronary cerebrovascular, increased malignancy in these people because they live normally. But incidence of these comorbid conditions like malignancy and atherosclerosis is more than non-HLA patient. Next slide. Next slide. Now, if you see in 1940, the treatment regime, how it's evolved. 1940, we were using only antimalarials. Next, corticosteroids. Next came cyclophosphamide, azothioprine, and rituximab. And in between 70s, 90s, we started methotrexate and cyclosporine. And new drug which has entered in the clinical practice, belimumab, which have been approved by FDA in 2011. And addressing the comorbid condition, we are much better state today than in the past. Next slide. Next slide. Now, what are the causes of death? First 3 to 5 years, the kidney is to be common if you don't control the disease. You control the disease, kidney no more first cause of the death. Patients who survive first 5 years of the disease die from increased cerebrovascular at much younger age than free individuals. Women with SLE, ages 35 to 40, have MI 50 times that of age-matched controls. So, increased coronary and cerebrovascular is going to contribute. Having said this, now just you have a small introduction of what is SLE. SLE is a syndrome of unknown etiology, most commonly affecting young women. Virtually any organ of the body may be involved. Typically, course of the disease is a series of remissions, exacerbation. With good management, the 10-year survival may have been more than 90%. If you correctly handled in the department, it is almost 98-99%. Next slide. The chronic autoimmune connective disease that can affect any part of the body. As in other autoimmune diseases, immune system attacks body's own cells and tissue, resulting in inflammation and tissue damage. Known as a great imitator because it often mimics or mistaken for other illnesses. Next slide. Next slide. Now, inflammation of the SLE is multi-system disease, primarily seen in the females. Highly variable course of the prognosis often has a significant constitutional symptoms like fatigue, feverishness, body ache, and sleeplessness, loss of appetite, associated with the calcic autoantibodies. Next slide. Now, what are the symptoms of lupus? It can involve skin, synovium, polycirrhosis, kidneys, central system, lungs, heart, lymphatic system. Next slide. Next slide. And abnormal SLE has abnormal immune system, sustained presence of autoantibodies, increased apoptosis, impaired clearance of apoptosis, hyperactive B cells and T cells, increased expression of surface molecules participating in cell activation, both B and T cells. The overproduction of interleukin 6 and 10. Defective immune regulatory mechanism. Next slide. You are skipping some slides. Okay. The clinical feature SLE, the non-ulcerative palpable purpura over both, or sometimes the initial present only palpable purpura. The different diagnosis is NS colon purpura. The remainder of the examination unremarkable. We follow over period of time other organ question. Next slide. Now, this is a maculopapular eruption. Next slide. Next slide. This is a discoid lupus. Next slide. The scarring is there. Next slide. And vascular skin lesion, the tip of the finger that you can see. Infarcts. Next slide. Alopecia, non-scarring alopecia. Next slide. And painless oral ulcers in the nose and mouth need to be observed and documented by a doctor. Next slide. Next slide, please. Now, having shared the various symptoms or signs of SLE, there need to be uniformity in making a diagnosis and management and data collection. We started first 1971 American College of Rheumatology classification criteria. It developed. Again, it was revised in 82, 97, 2012. Now, 97 onwards, most of we have rich experience, but 2012 also we have enough experience. Very simple, increase sensitivity and without losing the specificity. Next slide. Now, 1971 criteria, these all of you know in the books, is become history, facial erythema, discoid lupus. It has a sensitivity of 80 to 85%. Next slide. Next slide, please. Somebody attend to. Next slide, please. 1982, again, a revised criteria, where 4 of the 11 to be present. Next slide. Next slide. Next slide, please. And 1997, revised classification criteria, all were same. Go to previous slide. Go to previous slide. Somebody is not attentive. where instead of immunological disorders, any of the double-stranded SM and any of the antipersonal antibody, any should be taken to criteria. It has improved sensitivity, specificity almost 90 to 95%. Next slide. Now, 2012, Systemic Lupus International Core Committee classification criteria become so simple and easy. One clinical criteria and one immunological criteria is enough to make a diagnosis. Or lupus nephritis by biopsy with ANA. The previous 1997 criteria were missing good number of lupus nephritic variety, where only kidney involved, other organs not involved, skin is not involved. So patients used to come to us with acute renal failure, stabilize with dialysis, and find out the cause of renal failure. We used to do biopsy. It used to say grade 3, grade 4 lupus nephritis, and on doing ANA double used to positive. So we are missing good number of lupus nephritis 1997 criteria. But 2012, we don't miss. Even a kidney biopsy with the ANA double ANA positive, we can label this as a systemic lupus erythematosus with lupus nephritis. Next slide, please. Next slide. Now, the 2000 Systemic Lupus International Core Committee classification criteria. What are the clinical criteria? They are acute cutaneous lupus and chronic cutaneous lupus. They should be lupus specific. See, skin lesions are classified, various manifest skin lesions classified, lupus specific, lupus non-specific. One of the lupus specific lesions has to be there. Then oral or nasal ulcers, non-recurring alopecia, arthritis, sclerositis, renal disorder, neurological disorder should be specific with lupus. Hemolytic anemia, leukemia, lymphoma, and thrombocytopenia. When any of these clinical, 11 clinical criteria, 1 plus 1 lab criteria like ANA positive, double ANA positive is enough to classify as a systemic lupus erythematosus. Next slide, please. Next slide, please. Now, this one word of skin biopsy lupus. This is one situation where dermoepidermal junction, there is a lymphocytic infiltration with immunofluorescent band. This doesn't occur in any other disease except in subacute cutaneous lupus. So this is very important. Sometimes only skin involvement. Clinician is confused. Dermatologist or physician or confusion. This skin lesion is due to SLA or non-SLA. SLA. At the time, if we do kidney biopsy, it is the lymphocytic infiltration at the dermoepidermal junction with lymphoid band positive, just to label as subacute cutaneous lupus. It is very useful. Next slide, please. Next slide, please. Now, performance classification criteria, 97 criteria, and system. See, it was sensitivity of 97 criteria, 86%. It improved to 94% without losing the specificity. So this is a new 2012 classification criteria, simple, easy for clinicians to practice with improved sensitivity and specificity. Next slide, please. Now, autoantibody SLA, ANA, you can see specific, it not specific SLA, can be seen in many inflammatory, infectious, and neoplastic diseases. ANA could be positive 5 to 50% normal people. Just the presence of ANA don't make a diagnosis of SLA. Next slide. Next slide, please. Other antibodies seen are more specific, double-stranded DNA and SM. SM is more specific, but only thing SM is positive, generally kidney not involved. Next slide. Now, if we see ANA positive occurs nearly 10 to 12 years before clinical diagnosis of SL. ANA positive and cumulative increase in the autoantibodies, and after nearly 10 years, 5 to 10 years, clinical SL occurs. So we are attempting, can we make a diagnosis of SLE as a preclinical SLE and prevent occurrence of SLE? We are working. One of the drugs found useful in this is hydroxychloroquine. Next slide. Next slide, please. Now, autoantibody SLE antibodies, which are again different type of classified as cell nucleus component antibodies, antibodies to cytoplasmic antigen like SSA, SSB, and cell-specific autoantibodies like anti-erythrocyte, anti-platelet, anti-neuron, lymphotoxic antibodies, and antibodies to serum component like antiphospholipid antibodies and lupus anticoagulants. Next slide. Now, this is a new investigation. It's been in the practice. Still, FDA had to approve the microRNA analysis of the bone marrow. It can not only make a diagnosis of SLE, it can differentiate active lupus or inactive lupus. Next slide. Next slide. It can diagnose normal people, inactive SLE and active SLE. So this microRNA gene technique is come in the clinical practice. Some centers of John Hopkins are doing only for research purpose because if they had to approve this. Next slide. Next slide, please. My friend, next slide, please. Hello. The prognosis. 30 years ago, few patients with a severe class 4 nephritis survived 1 to 2 years. Of the severe disease used to die within 5 years. Marked improvement in treatment. So with 10 to 50% only progressive end-stage renal failure. Sepsis used to be a major cause of death. And transplant is very common in SLE patient. Now it become very rare because we're able to prevent end-stage renal disease or chronic renal disease significantly. So renal transplant become a rare in SLE now. Next slide. Next slide, please. Now, frequency of serologic abnormalities in systemic lupus erythematosus at the onset is to be less. Over a period of time, the prevalence of percentage of antibodies positive keep increasing because a cumulative increase in the serum levels of antibodies, the positive test becomes more common. Next slide. Next slide. Next slide, please. Naturally, actually, a person who has a genetic predisposition having environmental effect, ANA becomes positive, it is called as preclinical SLE. Once over a period of nearly 5 to 10 years, the clinical manifestation of the clinical SLE, like where inflammation, involvement of the first organ, then flares, remissions, and relapses, involvement of additional organs, damage occur in different organs like kidney, brain, and next, if we treat them properly, survive them for longer period, the comorbidity like infection, atherosclerosis, malignancy, going to remain predominant cause of mortality. Next slide. Next slide. Now, management of treatment is art. First, to make a diagnosis. After making a diagnosis, you have to assess a target organ management. With kidney involved, brain involved, lung involved, heart involved, liver involved, peripheral nerves involved, or vessels involved, like secondary vasculitis. Each organ involvement, major organ, minor organ, treatment is different. And next we have to measure the activity. Is a mild lupus activity, a moderate lupus, a severe lupus? Then organ damage. Organ damage you measure now and continue measuring every 3 to 6 months. The damage progress increasing, again the feature disease not under control. And safety, the drugs we give, we should know their safety profile. Because patients should not have a mortality or morbidity to drugs. So safety profile of the drugs is very important. And special issues in SLE like surgery, pregnancy, these are the issues we need to address. Next slide. Now diagnosis. Next slide. Next slide, please. So now, monitoring lupus patient, it can be emphasized too strongly that lupus is a disease requiring a regular, careful follow-up lifetime. Kindly counsel, we need to counsel the patient that disease requires a treatment lifetime, like hypertension, diabetes, heart disease, and stroke, hypothyroidism, rheumatological problems like SLE requires a lifetime follow-up. Important advice should be given about avoiding ultraviolet light like sun exposure, a prompt treatment of infections, extreme stress or fatigue to be avoided, a laboratory test, a blood test, ESR, complements, liver function test, SDN antibody to be done regularly every 3 to 6 months. Next slide. Next slide, please. Now, guiding clinical activity, highly variable nature of the syndrome, evaluate lupus activity at the base and beginning of the therapy and every 3 to 6 months. Non-life threatening features such as arthralgia, skin rash, Raynaud phenomena, alopecia is a different treatment. Severe complications, renal, cerebral, heart involvement has a different treatment. Next slide. And now, how to measure a disease activity? This is a systemic lupus disease activity index. This is given in most of the books. A score, different scores are given. A total score is less 1 to 3 is a mild lupus. More than 3, less than 12 is a moderate lupus. More than 12 is a severe lupus. The treatment regimes of mild, moderate, severe lupus are different. So, like a cardiologist, a diabetes measure every 3 to 6 months. What is the BP? What is the blood sugar? What is the liver profile? what is the residual function of heart. Like this, we have to measure lupus activity and damage every 3 to 6 months. It is not a test. It is a questionnaire where different organ involvement will be there. It's very simple. Once you practice, just in 5 minutes, you can finish. Next slide. Next slide, please. Now, this is measure different types of activity measurement. SLEDA is the most clinical practice, where a biolog is a useful assess the efficacy of the drug, mainly to use in drug trials. European Council lupus activity measurement also one, but most popular is SLEDA. And system lupus activity, SLAM also some of the countries using, but in India, Europe, most of the European countries, SLEDA were using. Different outcome measures, among them SLEDA is more popular. Next slide, please. I having shared about activity, about damage, about the damage. Now, in the damage, two types of measures: system lupus internal core committee damage index, ACR damage index. Most of us ACR damage index were using because simple to calculate. Next slide. Next slide. Next slide, please. The clinical therapy. There are 4 main groups of drugs useful in the treatment of lupus: non-steroid inflammatory drugs, antimalarials, corticosteroids, and cytotoxics. How to treat the lupus is hard. This comes by practice. Which and what the dose of drug to use to treat the patient depend on lupus activity, like a mild, moderate, severe, or major involvement or minor involvement. Next slide, please. Next slide, please. Now, there are different drugs: NSAIDs, corticosteroids, antimalarials, dapsone, thalidomide. Each one has effect on some organs. Like constitutional feature, you can have NSAIDs, small dose steroids, antimalarials. Whereas musculoskeletal disease, again, corticosteroids, NSAIDs have effect. Cyclophosphamide, micromold don't have effect on musculoskeletal system. Polysaccharide again same. Putinase again same. And each organ, the drug, which is drug effective, which is not drug effective, shown in the table. It is given in almost all books. Next slide. Next slide. Now, design the treatment goals. Do good. Use the drugs which bring down the disease activity, prevent organ damage, and prevent the flares. Do no harm. Means safety profile. Drug-related damage. The drugs can cause sometimes cytopenia, bone marrow suppression. It can cause liver damage. It may cause kidney injury, like NSAID, analgesic nephritis. Already, we are handling a patient lupus nephritis. But indiscriminate use of NSAID don't cause any kidney damage. A word on hydroxychloroquine, very important. Hydroxychloroquine reduces the flares, reduction in the lipids, reduction in the thrombosis, reduction in organ damage, improves the survival significantly, and triples the microbial response, prevents seizures, and reduction in the complete outlook in neonatal lupus. Not only that, number of flares decreases, number of hospital decreases, and decrease in the mortality in a group where hydroxychloroquine is used. So hydroxychloroquine we are using very regularly. Next slide, please. Next slide, please. Now, vitamin D also very important. Low vitamin D increases lupus activity. So correction of vitamin D very important. Not only that, it also has significant impact on the reduction of avascular necrosis head of the femur and fraction neck of the femur, and osteoporotic fractures to the vertebra. Next slide, please. Next slide, please. Now, overview for SLE management. Just establish the diagnosis and determine the disease activity, and assess severity in organ damage and lifestyle topical agent symptoms. A mild lupus, no major organ involvement. We use antimalarial low dose steroids like 0.25 milligram of prednisolone per kg, azathioprine, methotrexate. Wherever a major organ involvement, there is a need for cyclophosphamide, microphenolate, and like cyclosporin and tacrolimus, biological like rituximab and belimumab, new drug. And sometimes newer drugs are yet to be approved in by FDA. There are nearly another 6 to 7 drugs are there in the various phases of the drug trials. Next slide. Next slide, please. Next slide, please. Now, this is a very important. I told you, infection is number 1 cause of death. Now, most of the physicians are going for adult immunization. Follow adult immunization, prevent infection-related mortality. So, these are various patients used in the patient lupus in the follow. Next slide. Next slide. Now, what triggers SLE? Exposure to sunlight, infection. So, prompt early infection. Pregnancy. Effect of pregnancy SLE, increase activity, and effect of SLE and pregnancy, increase fetal loss. So, both has impact. This has to be well managed. And effect of surgery, because TNF liberation, lupus activity increases. So, when you do surgery, plant surgery, elective surgery, you have to see that SLE is under control. Sudden stopping of the medication, one of the important cause of relapse in India because of ignorance and economic reasons. And some drugs like procainamide do causes lupus relapses. A mild SLE activity can be managed by NSAID antimalarials. Prednisone remains the drug of the choice of lupus control activity. Dose is generally 0.25 milligram per kg body weight. It comes to 7.5 to 10 milligram per day. Next slide, please. Next slide, please. Now, use of corticosteroids against various diseases. Again, same corticosteroid, according to the organ involvement, is different. In skin, 0.25 milligram. Arthritis, 0.5 milligram per kg body weight. And so also in pleuritic pericarditis, where the hemolytic anemia, thrombocytopenia, we go for 1 milligram per kg body weight. Nephritis, 1 milligram per kg body weight. Neuropsychiatric lupus, it has to go 1 to 2 milligram per kg body weight. Either equivalent of prednisolone or equivalent methylprednisolone. In acute cases, we go for methylprednisolone, and subacute chronic cases, we go for prednisolone. Now, what are the comorbidities going to contribute for mortality in SLE? Infection, atherosclerosis, hypertension, dyslipidemia, diabetes, osteoporosis, avascular necrosis, head of the femur, and malignancy, especially non-Hodgkin lymphoma, is significantly contribute mortality of late. Next slide. Next slide, please. And what are the cytotoxic drugs used in SLE? Azathioprine, cyclophosphamide, mycophenolate, and biologics. Next slide, please. Next slide, please. Azathioprine, cyclophosphamide, mycophenolate. Now, treatment regime. FDA approved only Praquenil, aspirin, and steroid belimumab. Most of the drugs we use cyclophosphamide not approved by FDA, but we do have rich clinical experience and evidence, and we have authorized to use it. In lupus nephritis, FDA approved use of mycophenolate and cyclophosphamide. And medication lupus, this approval has come only in 2012. Next slide. Next slide, please. Other specific and special therapies involved in SLE, plasma exchange. Some thrombotic, thrombocyte purpura, we use this. And sometimes thrombocytopenia, we use intravenous immunoglobulin or plasma exchange. Intravenous immunoglobulin are very useful whenever there is active infection and active lupus. And stem cell transplant is there in the therapy FDA yet to approve. And immune therapy like IL-10, anti-CD20, and immune tolerant therapy have come in the practice. Belimumab got entered in the clinical practice in the year 2012. SLE and pregnancy, one slide is very important. When to plan pregnancy? SLE should be stable for more than 1 year. Prednisolone is no more, you should be less than 10 milligram per kg body weight for minimum period of 6 months. And SLE patient can have a plan pregnancy, can have a child, but only thing, and try to have a number of pregnancy less, and SLE be planned during remission. And most of the drugs are teratogenic. Among all the drugs, still you want to go take a risk. Tacrolimus is found to be safe in pregnancy. Next slide, please. Next slide, please. No, this is a NABH criteria practice where there is a strong organized practice, clinical practice, where primary care physician and rheumatologist, 3 levels of tasks are there. Patients generally go to primary care physician. Where he suspect SLE, he referred to the rheumatologist. They will make a diagnosis. A mild case is referred back to the primary care physician. He manages the primary mild disease like minor organ involvement like skin and joints. A major organ involvement, it will be on the follow-up of the rheumatologist. This has significantly improved mortality and morbidity in NH data. They are practicing this from 2010. Next slide, please. Next slide, please. Now, reason to referral to rheumatology when it comes to guidelines of NABH, that is confirmed diagnosis, assess disease activity and severity, provide general disease management plan to be given, manage uncontrolled disease, manage organ involvement or life-threatening diseases, to manage prevent treatment toxicities. In other specific circumstances, like including antipospin antibody syndrome, pregnancy, surgery, they need to follow under the rheumatologist because they very tricky situation. Take home message: SCL is heterogeneous multisystem disease, varies among various races and ethnics. Its pathology is complex and dysregulation of multiple arms of immune system is there. Systemic lupus diagnosis and disease monitoring remains a challenge for treating physicians. And systemic lupus erythematosus 2012 revised criteria, improved sensitivity and retained the specificity when compared to 97 criteria. So it becomes simple and with increased sensitivity specificity. I appeal all of you get acquainted with this new criteria and set the treatment goals for identifying the disease manifestation, comorbidity, testing the activity and chronicity, and prioritize the acute disease manifestation. Use of least toxic medicine, lowest dose to treat, and most concerning disease manifestation. Balance the treatment of active disease versus the complication of the treatment. With this, keep the SLA under control. See, our aim is there are different clinical spectra on SLE, active disease, next low disease activity, next remission on treatment, next remission of the treatment, means complete cure. We are not able to achieve this remission without medication, but remission with the medicine we are able to achieve, and hardly any patient remain active now. Now, finally, the approach of SLE, the current concepts are workup, diagnosis workup, then assess activity, then assess damage, then assess comorbid condition, design treatment goals according to mild, moderate, severe lupus, or minor organ involvement, major organ involvement. By practice, it is art. It comes by practice and updating yourself. Next slide, please. Next slide, please. Next slide. Next slide. Next slide, please. Next slide, please. Hello. Raman Rao Garu, they are not changing slides. Next slide. They have changed the slide numbers, and my thanks to eAPAPICON for giving this opportunity, sharing with you, seeing you, and interacting with you. Thanks to one and all, and my friend Dr. Jawar and Subbarao, Raman Rao are there. Thank you, Subbarao.
Thank you, sir. Thank you very much, Dr. Sival Garu. Sir, I am running behind schedule, sir. I am discussing with the.
One question, sir. One question. Please.
Oh, okay. The chair, whatever you say goes, right.
Dr. Narsimlu.
Yes, tell me, sir.
Good morning, sir.
Good morning, Ramana Garu.
One question regarding that palpable purpura in the lower limbs.
Yeah.
In a young patient, say between say around 20 years or so, in such a patient, how often this turns out to be SLE? Unless otherwise such a presentation goes with HS purpura and often remains so. What is the percentage of such patients to probe further to see whether such cases turn out to be SLE? Is it a harbinger? How often this is a harbinger?
Sir, a very good clinical question. If you see a patient palpable purpura, don't jump to diagnosis of either SLE or HS purpura. What is a palpable purpura? It is only leukocytoclastic vasculitis. Leukocytoclastic vasculitis doesn't occur only in SLE and HS purpura. All hypersensitive vasculitis do occur. We set criteria to differentiate. IgA antibody will positive to HS purpura. It involves only kidney. IgA nephropathy it occurs. When SLE, ANA is positive and full-blown spectrum will be there. And I told you, lupus band means dermoepithelial junction, the lymphocytic infiltration with lupus band. That is a feature of SLE. Because treatment is very different. But leukocytic vasculitis of HS purpura is different. Leukocytic vasculitis of SLE different. And leukocytic vasculitis associated infection is different. It can occur HCV, HIV infections also. There we should not use steroids. So, having seen a palpable purpura, attempt to make a diagnosis, is it due to hypersensitive vasculitis, HS purpura, infection related, or lupus?
Thank you, sir. I think Raman, I think
you,
he
sir.
has answered your questions very, very well. Now for the major events of the day, the two consecutive orations. The first one by Dr. eAPAPICON Chairman of K.V. Raman Rao Garu. It's a B. Lakshmi Reddy Memorial Oration. And the oration ceremony will be presided over by his son, Dr. B. Ramchandra Reddy Garu, who is a retired professor, is head of the Department of Medicine, Kurnool Medical College, Kurnool, and is senior consultant of physician at Apollo Hospital, Kurnool. And in this conference, we are creating a new tradition by inviting the founder or the donor to preside over the oration issued by them. Now, Dr. Ramchandra Reddy Garu, please conduct the proceedings, sir. Dr. Ramchandra Reddy.
Thank you, sir, for inviting me to conduct the oration lecture in the honor of my father, Sri B. Lakshmi Garu. Good morning to all the delegates for this virtual conference. I welcome you all for this wonderful oration in the name of my late father, Sri B. Lakshmi Garu. At this juncture, I will be failing in my duty if I don't thank the efforts of Dr. M.R. Sharma, Dr. I.V. Rao, and Dr. Krishnapasan, the MD, to institute an oration in the name of my father. To institute an oration, he or she should be doctor, but my father was not doctor. This protocol was debated in my case. I thank them all once again for getting the oration done. This I did by date of my late father. Already I got a bad throat infection, laryngitis. Please excuse me if my voice is not clear. My father, Sri B. Lakshmi Garu, was born on 1st July 1928 in Kotala village in Anantapur district to Sri B. Lakshmi Garu and Srimati Ogulamma. My father's name and my grandfather's name are the same. He had his high school education in Gutti, 34 kilometers away from his village, and was the lone member in his village to have studied up to degree BCom in Guntur in those days. He was also proficient in English grammar and geography. He joined as audit clerk in 1953 at Bellary in erstwhile composite Madras state and was allotted to Andhra Pradesh after the formation of Andhra state. He was very honest and sincere in his job and used to be transferred every 3 years as per the rules in Vogue at that time, except when his eldest son was studying MBS in Kurnool. He retired as regional deputy director in 1988. He was an ardent follower of the habit of writing diary every day, all through his life. And these diaries are preserved by his son, eldest son, even till today. He also wished his children to follow the same. He was married to Srimati B. Lakshmi Devi, who unfortunately passed away when he was just 36 years old. As a lone parent, he brought up well all his 4 children. He learned Sanskrit language at the age of 36 years after his wife passed away, and acquired proficiency in that language to do in-depth study and analysis of all of our great epics, Ramayana, Mahabharata, and Bhagavatam, etc. His deep love for literature and scriptures made him acquire all great books and neatly sorted, indexed, and bounded them as a divine book library, despite his meager salary and pension, to be handed over to his progeny. All these are well preserved today by his eldest son, that is myself. Sri Mahatma Gandhi's call for participation in our epic freedom struggle aroused great patriotism in him, and they used to sweep Harijan Vadas during his school days and used to raise Vande Mataram slogans to defy British police officers. He used to contribute money regularly to Indian Army, even when he was drawing a meager pension of rupees 520 per month, as a mark of gratitude and appreciation of their sacrifice to safeguard the people of our country. These were examples of his great patriotism. He passed away on 19 September 1993 due to idiopathic cirrhosis of the liver with hepatocellular carcinoma. He was survived by his 2 sons and 2 daughters, whom he single-handedly molded them into well-educated, disciplined, and honest citizens of this nation. He was gem of a man with exemplary conduct and character, with an immaculate self-discipline and honesty and patriotism, and adored himself with unfathomable knowledge and literature from the scriptures. In honor and fond memory of this noble and erudite person, Sri B. Lakshmi Garu, this endowment lecture is instituted by his eldest son, Dr. B. Ramchandra, and myself, former professor and head of the Department of Medicine, Government Medical College, and additional director of medical education, Government of Andhra Pradesh, and past chairman of eAPAPICON 2012. Thank you, one and all. Now, I welcome the Dr. K.V. Raman Rao Garu to the virtual podium. I will read the biodata of the speaker, Sri K.V. Raman Rao. He is born in 1953. He has completed his MBBS 1979 and MD at 1984 at Andhra Medical College, Visakhapatnam. He is present chairman of eAPAPICON. He was born in 1953 again, I am telling. He worked as professor and head of the Department of Medicine till 2011. He also served as postgraduate examiner for several colleges. The contributions are by him. He actually reported a series of cases of epidemic dropsy. This is present in several academic fora and recommended for ICMR project. He has several other publications to his credit. Awards are achieved by him. He got the gold medal Sri I.V. Jogarao Arrest at Guntur. He successfully conducted a combined state conference of APICON and in 2011 as organizing secretary. He is also permanent member of national and state APAs. He is presently chairman of eAPAPICON. Now I request the speaker. Dr. K.V. Raman Rao, to don the gold medal and deliver the oration.
Good morning, everyone. Respected Chairperson, Dr. B. Ramchandra Reddy garu, all the senior colleagues, senior faculty, all the delegates, students, and friends. I thank the organizing committee for choosing me today to deliver this oration on endocrine emergencies. This is in memory of Sri B. Ramachandra Reddy, Sri B. Lakshmi Reddy, the father of our beloved chairman, Sri B. Ramchandra Reddy garu, who is also chairing this oration. And I feel it's a proud moment for me. More so because the medal is instituted by him and the chairperson has immense credentials, both academic and conduct. He is a very popular person in our academic circles. The medal is bestowed upon me today, and I don it in front of you. With this brief introduction, let me proceed to the oration. The topic, as I said,
Sir, before that,
is
please
endocrine
wait
emergencies.
count the gold medal and deliver the oration.
Chosen because I like emergency medicine as a physician, and I am involved in treating many medical emergencies to the best of my knowledge, to the best of the satisfaction of our patients, and to my satisfaction. Introduction. Endocrine emergencies are commonly encountered in medical practice, particularly involving pancreas, thyroid, adrenocortical, and pituitary hormones. These emergencies are often attended by physicians in emergency room and intensive care units. They require immediate treatment even before obtaining results of investigation and a high index of clinical suspicion. These emergencies include usually diabetic ketoacidosis, hyperglycemic hyperosmolar state, hypoglycemia, lactic acidosis associated with diabetes, myxedema coma or myxedema crisis, thyroid storm or accelerated hyperthyroidism, acute adrenal failure, also referred to as Addisonian crisis, pituitary failure, acute pituitary failure, or apoplexy. First, the most common one, diabetic ketoacidosis. It may be the initial manifestation of type 1 diabetes or may result from increased insulin requirements during infection, trauma, myocardial infarction, surgery, and missed insulin. It's a life-threatening medical emergency with a mortality rate of about 5% in patients under 40 years of age and over 5% in patients of elderly age groups. Ketoacidosis may develop in patients with type 2 diabetes in severe stress, such as sepsis or trauma, particularly with long-standing diabetes and irregular medication. Signs and symptoms. Ketoacidosis is usually preceded by a day or more of polyuria and polydipsia associated with marked fatigue, nausea, and vomiting. If untreated, mental stupor and coma ensues. Frank coma occurs in about 10%. Evidence of dehydration, acidotic breathing known as Kussmaul breathing, hypotension, tachycardia, abdominal pain with or without tenderness are usually seen. Laboratory findings. Typically, the patient with moderately severe ketoacidosis has a plasma glucose of 350 to 600 milligrams per deciliter. Serum ketones at a dilution of 1:8 or greater. Urine acetone usually up to 4+. Mild to moderate hyponatremia. Elevated blood urea and serum creatinine could be prerenal. pH of 6.7 to 7.2. Serum bicarbonate of 5 milliequivalents per liter to 15 milliequivalents per liter. Fluid depletion is marked, typically above 100 ml per kg. The average total potassium deficit is 3 to 5 milliequivalents per kg body weight due to osmotic diuresis, acidosis, and GI loss. Hyperkalemia occurs because of the shift of potassium from intracellular to extracellular spaces in systemic acidosis. Leukocytosis, as high as 25,000 per cubic millimeter may occur with or without associated infection. Elevation of serum amylase is common and non-specific usually, but serum lipase may be useful. Patients are generally hypothermic if not infected. Management. Patients with mild ketoacidosis are alert, have pH between 7.25 to 7.3. Moderate ketoacidosis have pH between 7 and 7.24, and those with severe ketoacidosis or sucrose have pH less than 7. Mild ketoacidosis can be treated in the ER. Those with moderate to severe ketoacidosis require ICU admission. Therapeutic goals are restore plasma volume and tissue perfusion, reduce blood glucose and osmolarity to normal, correct acidosis, replenish electrolyte losses, identify and treat precipitating factors. Gastric intubation is recommended in comatose patient to prevent aspiration due to gastroparesis, which is common in diabetes. An indwelling catheter may also be necessary, and CVP catheter in severe cardiovascular or renal failure patients. Blood glucose should be recorded hourly, electrolytes and pH at least every 4 to 6 hours during the initial treatment period. In most patients, the fluid deficit is 4 to 5 liters. 0.9% saline or normal saline is the solution of choice to re-expand vascular volume and should be started in the emergency room. The saline should be infused rapidly to provide 1 liter per hour over first 1 to 2 hours. Failure to give enough volume replacement, at least 3 to 4 liters in 8 hours, adversely influencing recovery. When blood glucose falls to about 200 to 250 milligram per deciliter, the fluid should be changed to 5% dextrose. This will prevent the development of hypoglycemia and reduce the likelihood of cerebral edema due to rapid decline of blood glucose. Immediately after initiation of fluid replacement, regular insulin should be given IV in a loading dose of 0.1 unit per kg. After the initial bolus, continuous insulin infusion at a dose as low as 0.1 unit per kg per hour is maintained. It is pertinent to note here that after the advent of low-dose insulin continuous infusion has changed the scenario of diabetic ketoacidosis and its prognosis. Many patients recover nowadays due to fluid replacement early and institution of low-dose continuous insulin infusion, appropriate potassium infusion, and broad spectrum replacement of insulin helps to correct the acidosis by reducing the flux of fatty acid to the liver and thereby reduce ketone production and improve clearance of ketones. Insulin infusion reduces hyperosmolality, increases peripheral utilization of glucose, inhibits gluconeogenesis and glycogenolysis. These are the usual actions of this hormone insulin. Reduces hyperglucagonemia, which is seen in some extent. In a rare patient of immune insulin resistance, the insulin dose is doubled every 2 to 4 hours. Hyperglycemia does not improve. Insulin dose should be piggybacked into the fluid line or administered separately by a syringe pump for constant infusion. Potassium. Total body potassium loss may be as high as 200 milliequivalents, but appears apparently normal or high due to shift of potassium from cells as a consequence of acidosis. Replacement should be started if initial serum potassium is low or low normal. An ECG can be of help in monitoring the patient's potassium status apart from laboratory values. When the patient has recovered sufficiently to take food orally, foods high in potassium should be prescribed. Tomato juice, for example, has approximately 15 milliequivalents of potassium per 250 ml. A medium-sized banana provides about 10 milliequivalents. Sodium bicarbonate in antibiotics. The sodium bicarbonate in the management of decay is questioned because of development of hypokalemia from rapid shift of potassium into cells, tissue hypoxia due to reduced oxygen dissociation from hemoglobin. However, when severe acidosis exists, bicarbonate is recommended preferably in 0.45% saline by infusion. Broad spectrum antibiotics are prescribed as indicated. Cholecystitis and pyelonephritis may be particularly severe in these patients. Prognosis: low dose insulin infusion, fluid and electrolytes replacement, careful monitoring of patients' clinical and laboratory parameters have dramatically reduced the mortality rates of DKA to less than 5%. In patients with profound coma, acute MI and elderly patients with severe acidosis, the mortality still remains high. Symptomatic cerebral edema occurs primarily in pediatric population due to severe acidosis, excess IV fluid administration, and rapid correction of hypoglycemia. Now, hyperglycemic hyperosmolar state, HHS. Hyperglycemia, generally more than 600 milligrams per deciliter. Serum osmolarity, usually high, more than 310 milliosmoles per kg. No acidosis generally. Blood pH above 7.3. Serum bicarbonate more than 15 milliequivalents per liter. And normal anion gap, because there is no acidosis, less than 14 milliequivalents per liter are the cardinal features. It is the second most common form of hyperglycemic coma, characterized by severe hyperglycemia, dehydration, insignificant ketosis, and affect pathogenesis and clinical findings. A precipitating event such as infection, MI, stroke, acute and CKD, recent operation, second drugs like corticosteroids and diuretics have been implicated. Severe osmolarity and causes mental confusion leading to coma. Reduced levels of growth hormone along with portal-vein insulin concentrations may restrain ketogenesis and hence insignificant ketosis in this setting. Onset may be insidious with weakness, polyuria, and polydipsia. Reduced intake of fluid due to inappropriate lack of thirst and lack of access to fluids in the very elderly. Profound dehydration and prostration without air hunger are usual clinical features. Management: blood glucose values ranging from 600 to 800 milligrams are common. Serum sodium may be 120 to 130 milliequivalents per liter. Ketosis and acidosis are usually absent or mild. Blood urea and creatinine are raised, usually pre-renal. Serum osmolarity is high, 330 to 440 milliosmoles per kg are usually seen, and hence it is also called hyperosmolar. Fluid replacement is of paramount importance in treating non-ketotic hyperglycemic coma. The onset is more insidious in the elderly without ketosis. Fluid replacement: if hypotension and oliguria is present, therapy with 0.9% saline is initiated. In all other cases, half normal saline, that is 0.45%, is preferable because of marked hyperosmolar state. As much as 4 to 6 liters of fluid may be required in the first 8 to 10 hours. Once blood glucose reaches around 200 milligrams, fluid replacement should include 5% dextrose in saline or half normal saline. An important endpoint of fluid therapy is to restore urine output to 50 ml per hour or more. Insulin, less in dose for non-ketotic patients. Fluid replacement alone can reduce hyperglycemia considerably, which then increases GFR and excretion of glucose. An initial insulin dose of 0.1 unit per kg as bolus is given, followed by infusion of 0.1 unit per kg per hour until blood glucose falls to around 200 to 250 milligrams per cell. there is less severe total body potassium loss than in DKA. Potassium chloride 10 milliequivalents per liter can be added to the initial bottle of fluids if serum potassium is not elevated. Prognosis. The overall mortality rate of hyperosmolar coma is significantly more than DKA. Complications such as MI, stroke, pulmonary embolism, mesenteric thrombosis, and DIC may occur due to severe dehydration and low output. Hence, fluid replacement remains the primary approach. Low molecular heparin can be given as prophylaxis. Rhabdomyolysis is recognized a complication and hence should be looked for. Lactic acidosis occurs when there is inadequate tissue O2 delivery and resultant hypoxia. Sepsis with shock, cardiogenic shock, hypovolemic shock, renal and hepatic failure, and occasionally bigonad therapy in renally impaired patients are usual causes. The primary goal is to restore tissue perfusion, treat the cause, and administer bicarbonate to maintain pH above 7.2. Hypoglycemic coma. Hypoglycemia occurs in diabetes as a result of treatment with insulin and oral hypoglycemic agents, example, sulfonylureas. Usually occurs when blood glucose falls to less than 60 milligrams per deciliter. The risk of hypoglycemia limits the goal of attainment of near normal glycemia. Nocturnal hypoglycemia in type 1 diabetes is common, but often as it does not usually awaken a person. Hypoglycemia in a non-diabetic person is called spontaneous hypoglycemia. Common causes of hypoglycemia: missed or delayed meal, usually after insulin. Usual exercise, unusual exercise, alcohol, error in oral hypoglycemic agents and insulin dose, factitious in some cases, unrecognized disorders, example, Addison's disease, hepatic and renal failure, extremes of age, and long duration of diabetes. Clinical features and management. Severe hypoglycemia can have serious morbidity and mortality of up to 4% in insulin-treated patients. Rarely sudden death during sleep occurs in young patients with type 1 diabetes. Poor sleep quality, morning headache and vivid dreams or nightmares, profuse sweating and restlessness, twitching or seizures, neurologic deficits, example hemiparesis, diplopia, can occur. Impaired awareness of hypoglycemia affects 20 to 25% of people with type 1 diabetes and less than 10% with insulin-treated type 2 diabetes. Symptoms can be less intense or absent even with blood glucose levels of 45 milligrams per cent, particularly with autonomic impairment. Treatment of acute hypoglycemia depends on severity and whether the patient is conscious or comatose. In unconscious patients, 100 ml of IV dextrose, 25% or 50% is rapidly given. IM glucagon 1 mg, if available, should be administered. 10% dextrose infusion is started to titrate patients' blood sugar. After recovery, patients are educated to recognize hypoglycemia. Now coming to thyroid emergencies, myxedema coma or myxedema crisis. It refers to severe life-threatening hypothyroidism. The manifestations of hypothyroidism are present and more severe. Patients have impaired cognition ranging from confusion to coma. Convulsions and abnormal CNS signs may occur. Patients have severe hypothermia, hypoventilation, hyponatremia, hypoglycemia, and hypotension. Acute kidney injury may also occur. Myxedema is most often seen in elderly women who had a stroke or stopped taking their thyroxine. It's often induced by underlying illness, respiratory illness, CNS illness, cold exposure, or drug use. The mortality from coma is high. Hyponatremia is severe and may be refractory to treatment. Treatment should preferably begin before biochemical confirmation. Triiodothyronine is given as an IV bolus of 25 micrograms, followed by 25 micrograms 3 times daily until there is sustained clinical improvement. After 48 to 72 hours, oral levothyroxine 100 to 200 micrograms daily can be substituted. Often there is hypothalamic or pituitary disease, and hence IV hydrocortisone 100 milligram 3 times a day is given, pending T4 TSH and cortisol results. Other methods include slow rewarming, gaseous IV fluids, broad spectrum antibiotics, high flow nasal oxygen, and mechanical ventilation if required. Thyroid storm or accelerated thyrotoxicosis. This disorder, uncommonly seen today, is an extreme form of thyrotoxicosis. It is triggered by stressful illness like sepsis, thyroid surgery, radioactive iodine administration, factitious thyrotoxicosis, discontinuation of antithyroid drugs, acute MI, and stroke. Most patients have partially treated hyperthyroidism. Clinical features and management. Thyroid storm is a state of physiologic decompensation. It presents with fever out of proportion for infection, dehydration, diaphoresis, or diarrhea. Atrial tachyarrhythmias are common. Hypotension often resistant. Mental confusion and agitation, psychosis, stupor, and even coma. Progression to cardiovascular collapse and death can occur. Mortality is high. First line of treatment for thyroid storm is cardiovascular resuscitation with volume. Administer NS or dextrose NS until blood pressure and urine output stabilize. Beta blockers to control heart rate, preferably non-selective beta blocker, example propranolol, 80 mg orally 3 to 4 times a day, or IV up to 5 milligram 3 to 4 times a day is given. Logal iodine orally to prevent conversion of T4 to T3. Metamazole or propyl thiouracil are administered to control T3, T4 levels. Antipyretics and cooling methods for fever, along with antibiotics to control infection, are given. Now, Addisonian crisis may occur in the course of treatment of chronic insufficiency or may be the presenting manifestation of adrenal insufficiency. Acute adrenal crisis is more commonly seen in primary adrenal insufficiency than secondary to disorders of pituitary gland. Precipitating factors include severe infection, trauma, hyperthyroidism, and surgery in a patient with latent or treated adrenal insufficiency. Clinical features and management. Patients present with lassitude, nausea and vomiting, abdominal pain, diarrhea, recurrent hypoglycemia, and dehydration. Purpura and hyperpigmentation may be seen. Hyponatremia and hyperkalemia are usually present. Eosinophil count may be high. Low blood sugars are common. Random plasma cortisol is usually low and ACTH high in primary adrenal failure. Cortisol fails to increase after short ACTH stimulation test. Adrenal imaging and pituitary imaging can be done to recognize adrenal calcification, example tuberculosis, or neoplastic lesions. Hydrocortisone is the drug of choice for treatment and given IV at 100 milligrams as bolus and repeated 3 to 4 times until patient stabilized. Fludrocortisone is administered in a dose of 0.1 milligram daily as mineralocorticoid. Normal saline and 10% dextrose are given for hypotension and hypoglycemia. Emergency supportive measures are undertaken as required for critically ill patients. Now, finally, pituitary apoplexy is a condition resulting from acute hemorrhage in large pituitary tumors. Manifestations include rapid loss of vision, headache, altered sensorium, and circulatory disturbance. Treatment requires emergency decompression of the cella. Hydrocortisone is often required along with the fluid management. So, as far as possible, I have covered the endocrine emergencies. In a nutshell, each one of the topics can be a lecture. But given the time, I thought I would present the basic and treatment, how they present, how they are treated, even before investigations are pending, keeping in mind a high index of suspicion for each one of them. There are some miscellaneous conditions, but I have not helped them in this lecture. I thank one and all once again for giving me this opportunity to deliver this oration today. Thank you once again.
I thank the speaker for his excellent talk on the emergencies in endocrine practice. As this is an oration, there will not be any questions. And I close the oration lecture henceforth. Thank you.
Thank you very much, Dr. Ramchandra Reddy Garu, for being the chairperson and conducting it very well. And now for the second oration, Dr. Koppachi Krishnamurthy Memorial Oration, issued in memory of his venerable teacher, Dr. Gopal Raju Garu, Senior Physician and Managing Director of P1 Hospitals. The oration will be delivered by Dr. K.V.G.K. Tilak Garu, our teacher's teacher. Now it's over to Dr. Gopal Raju Garu to be the chairperson and to conduct the proceedings. Dr. Gopal Raju Garu. Dr. Gopal Raju Garu, kindly log in.
Please unmute.
Sir, please unmute your system, sir. Dr. Gopal Raju Garu. Small delay, sir. We are waiting for Dr. Gopal Raju Garu to log in.
They already log in on the only unmute channel.
Hello?
Yes.
Are you hearing?
Dr. Gopal Raju Garu.
Hello?
Yes, sir. Dr. Gopal Raju Garu, you are audible to all of us.
Are you hearing?
Yes, sir.
So, dear members of the eAPAPICON, good morning to all of you. First of all, I thank Dr. I.V. Rao and MBR Sharma Garu and Jawahar and PGs for giving me this opportunity to chair the session. I am happy to invite Dr. KVG Tilak to don the medal. And before that, are you hearing, please? Hello? Are you hearing?
Yes, sir. Please proceed, sir.
Dr. Koppachi Krishnamurthy is an eminent physician, renowned academician, and an outstanding student, born on 13th November 1926. He passed MBBS in 1950 from Andhra Medical College and was the best outgoing student, having bagged 6 gold medals. After completing MD General Medicine in 1955 from the same college, he became a professor in 1960. He worked as professor in various medical colleges, including JIPMER, and as Dean of Nizam Institute of Medical Sciences. Dr. Krishnamurthy has advanced training in medicine, cardiology for 1 year during 1960-61 at Columbia University, and worked with Dr. S.C. Bradley, Director, Department of Medicine, and Dr. Henry Cornard, Nobel laureate in cardiology. He was awarded Certificate of Achievement by International Cooperation, Administration of Government of USA in the field of medicine. He has done extensive research and unraveled the presence of sickle cell disease in the relief community of the Visakhapatnam for the first time, which study he presented in various academic fora. And also, Dr. Krishnamurthy was the advisor to the Union Public Commission. He was appointed as honorary physician to the President of India and honorary physician to the Governor of Andhra Pradesh. He was also a member of Andhra Pradesh Medical Council and a member of the Board of Management of Dr. B.R. Ambedkar Open University of Andhra Pradesh. To his credit, he has published 24 publications in various fields like sickle cell, dengue, cardiology, thyroid acropathy, and he has addressed several IMAs in Tenali, Kakinada, Bhimavaram, Kadapa, Vizag, Vijayanagaram, Srikakulam, Chodavaram, in Tamil Nadu, Kadalur, and this Jipmara. And he has examined for Andhra University, Sambalpur University, Berhampur University, SV University, Bangalore University, and Mysore. And you know, fortunately, our speaker, Dr. KVJ Tilak, now he is talking on dengue, which our professor used to be very closely associated with the dengue fevers. Now, I invite Dr. KVJ Tilak to don the medal, and before proceeding for the oration, now I read the biodata of Dr. KVJ Tilak. He was born on 11th July 1943. MBBS he did in 1966, MD in 1970 from Andhra Medical College, Visakhapatnam. After 7 years as assistant professor of medicine at Rangaraya Medical College, he had long experience in Department of Cardiology in Rangaraya Medical College and Visakhapatnam AMC. He was professor of medicine, Andhra Medical College, Visakhapatnam from 1995 and retired as HOD of medicine in Visakhapatnam. He was a recipient of Agri Gold Medal by IMA Visakhapatnam. Elected as Best Teacher by students of AMC, recipient of Best Teacher Award, examiner for postgraduate examinations for AP and other states, is Fellow College of Chest Physicians of India, and he was speaker on air, television, and voluntary organizations. And before going for the oration, we have been seeing dengue fevers for the last almost 7 to 10 years, and every year we are getting mutations. To my experience in the present season, I have come across very low platelet and dengue hemorrhagic shock syndromes. So now I request Dr. KVJ Tilak to proceed with his oration, and before that I request him to don the medal. Thank you, Dr. Subbarao garu.
Thank you, sir. Sir, please.
Beloved
Sir,
honorary patron, Dr. A.V. Rao, distinguished members of the Executive Committee of API AP State Branch, learned delegates, and young friends. I deem it an honor to be asked to deliver Dr. Krishnamurthy Memorial Oration today. He was one of my beloved teachers who taught me medicine during my undergraduate. He worked on two very important topics, namely that of dengue fever and sickle cell disease. Since dengue is rearing its head again, I chose dengue fever as my topic today. Now, if you go into the incidence of dengue fever, more than 110 countries are found to have been affected, involving 40% of the world population. Over 100 million cases have been reported, mainly from tropical and subtropical regions. It is second only to malaria, and in those persons who are returning from tropics, not reported so far from Europe and Antarctica. Now the name dengue as such is derived from Swahili phrase ki denga pepo, meaning cramp-like seizures caused by an evil spirit. Dengue may probably has origin in Spanish word dengue, meaning careful or fastidious, which would describe the gait of a person suffering from dengue. It needs to be pronounced as dengue. If you go into the history, the probable case in Chinese encyclopedia during Qing dynasty between the era of 265 to 400 AD was referred to as water poisoning and flying insects. Dengue hemorrhagic fever reported in Chinese literature, medical encyclopedia in 992 AD. Rigorously documented epidemics occurred in Cairo, Alexandria, and Jakarta in 1799, but earlier to that in Philadelphia and Madras in our country in 1780. Transmission by Aedes was confirmed in 1906. And this is the beauty, the Aedes mosquito, which causes all the misery to us. Now, if you go to the epidemiological circle, the triangle, India is endemo-epidemic since 1963. That is the time I was doing my third year MBBS in Andhra Medical College. Now, the classical triangle is that of host, parasite, and environment. We'll see now. The environment, if you take it up, is tropical or subtropical. It is at 30 degrees latitude, north and south of equator. Below 1,000 meters elevation, only dengue fever occurs. That is the malaria. The Aedes aegypti survives. The stagnant pools of water are the breeding grounds for mosquitoes, which abound everywhere and around us all through. The parasite belongs to the family of Flaviviridae, genus Flavivirus, single-stranded, non-segmented RNA virus, icosahedral in shape, 50 nanometers in size. The origin is in jungles, evolving probably from a mosquito virus to one capable of causing disease in primates and humans. The viral genome consists of 11,000 bases, 3 structural proteins, C protein M, and structural proteins, the NS1, NS2A, 2B, NS3, NS4A, 4B, and NS5. 4 common strains have been detected earlier. The 5th was detected recently, that's about 11 years ago in 2010. Dengue 1 was detected first in 1943 in Hawaii. The same year, dengue 2 was recognized in New Guinea. 1956, two other, dengue 3 and 4, were recognized in Philippines. Dengue 1 has 3 to 5 genotypes, dengue 2, 5 to 6 genotypes, dengue 3, 4 genotypes, and dengue 4, only 2 genotypes. Dengue 1 is common in Southeast Asia, China, and East Africa. Dengue 2 in Thailand, dengue 3 in Malaysia, dengue 4 in South Pacific, dengue 5 in America and Africa. Some types have restricted distribution, while others are more cosmopolitan. 4 subtypes of the virus have 60 to 80% homology between them and each other. Infection induces lifelong immunity against the same serotype, partial and transient against others. Particular genotypes are associated with disease severity, and any change in the circulating type may influence the severity of the outbreak. Dengue 2 genotype 4, having potential to cause hemorrhagic fever, was in circulation since 1996 in Delhi, when dengue 3, an epidemic strain, emerged as a co-circulating type with dengue 2 in 2003, whereas by 2006, dengue 3 replaced dengue 2 and co-circulated with dengue 1. This variation might increase the severity of the disease in population already exposed to other types previously. The life cycle, if we now go into, it occurs between the human being and the mosquito. The mosquito, we have the Aedes species, the Egypti, Albopictus, Polynesians, and Spetilaris. In the mosquito, we have a need to, and it becomes infective for life. The lifespan is between 15 to 65 days. But the beauty is there is a vertical transmission to eggs, and eggs can remain in desiccated form for 1 year. That is the danger. A peridomestic mosquito, daytime feeder, and this can fly up to 100 meters. In the take the host, it is more common in children and women, though no age and sex is exempt. More severe in those underlying diseases like asthma, diabetes, G6PD deficiency. Polymorphism in genes for vitamin D receptor and FCYR seem to offer resistance. Some Haitian and African races enjoy protection. Now the classification, 1997, it was classified as undifferentiated fever, dengue hemorrhagic fever. This dengue hemorrhagic fever was further classified into 4 grades. Grade 1 is easy bruising, or that which we can recognize by the tourniquet test. Grade 2, where there is spontaneous bleeding into the skin and elsewhere. Grade 3, there is clinical evidence of shock. Grade 4, severe shock, where pulse and blood pressure cannot be recorded. Grade 3 and 4 are designated as dengue shock syndrome. WHO in 2009 reclassified dengue as uncomplicated and severe dengue. Now, if you go into the pathology and pathogenesis, the infected mosquito, once it bites us, the virus enters into the dendritic cells under the skin, and they travel to the nearest lymph node, where in the endoplasmic reticulum of the cell, a new viral proteins start forming Mostly in the Golgi apparatus, the viral glycoprotein gets modified and mature viral protein is released by exocytosis. And this protein, viral protein, is taken up by monocytes and macrophages. Severe disease, the exact mechanism still unclear. However, we have two components of this. One is vasculopathy, where we have increased permeability of the vasculature, which leads to edema and fluid accumulation in the cavities like peritoneum, pleural cavity, like that. And there is a disordered coagulation because the platelet comes down. Is it because there is a strain variation which infects an earlier infected individual? Or is it because, as Halstead said, an antibody-dependent enhancement that is called the immune enhancement disorder? Low levels of neutralizing and non-neutralizing antibodies to one serotype bound to Fc receptors of macrophage or monocyte enhance the viral entry and replication, leading to increased cytokine production and complement activation. And this is the ADE, antibody-dependent enhancement, which results in increased T cell activation, apoptosis, and interferon production. Now, if you take the clinical profile of dengue fever, 50 to 90% of people are totally asymptomatic. That is the dangerous thing. And the remaining have non-specific febrile illness, which can mimic any viral fever. Very few patients develop classical dengue fever, and small percent of this would develop dengue hemorrhagic fever or dengue shock syndrome. This occurs in previously infected people with dengue virus upon reinfection with another dengue virus serotype. For every one diagnosed case of dengue fever, do remember, nearly 19 cases go unrecognized. The incubation period once the mosquito bites is between 3 to 14 days. Average is 4 to 7 days. There is fever with chills and dryness, facial flushing, erythematous mottling, myalgias, arthalgias, headache. A typical feature is the retroorbital pain, severe backache that lasts for 3 to 5 days with periods of normalcy for 1 to 2 days. And this is the classical saddleback fever. And then the fever returns. There could be severe abdominal pain, nausea, vomiting, maculopapular rash, bleeding manifestations, generalized lymphadenopathy, peripheral edema, severe prostration, and shock. The complications are bleeding into either gastrointestinal tract, menorrhagia, intracranial hemorrhage, fulminant hepatitis, cardiomyopathy, which could be due to leading to myocarditis, or the same way the encephalitis, which could manifest as encephalopathy. There could be bacterial superinfection. Rarely there is arthritis, ophiritis, Guillain-Barré syndrome, and transverse myelitis. And once we look into the diagnosis, the classical is viral detection by RT-PCR, which is not very easy. The IgG, IgM usually appear after the 5th day. The IgM lasts for 30 to 90 days. The IgG remains for 60 years. But remember here, the NS1 antigen appears very early. If you look at the blood picture, there is leukopenia, thrombocytopenia, elevated hematocrit, and elevated transaminases. This fever has to be borne in mind along with the conditions like chikungunya, leptospirosis, malaria, typhoid, meningococcal disease, and yellow fever. Most cases in normal course of events, they recover on their own. It means it is a self-limited disease, unlike the media which now shows lot of overactivity. Only 1 to 5% develop dengue hemorrhagic fever. Some of the dengue hemorrhagic fever progress to shock syndrome with mortality ranging up to 40%. Now, if you take the cycle, most of them are asymptomatic. Some develop fever. Of the few, quite a few become critical, and even then they could recover again to normalcy. Now, in the treatment, please avoid aspirin, NSAIDs, or steroids. The treatment is by paracetamol, rehydration by either oral or IV fluids, platelet transfusion if the count falls below 10,000 per cubic millimeter. This is WHO recommendation. But do remember, by and large, we take 30,000 count as the level at which we start platelets. And also remember, if you have a pregnant woman who is about to deliver, now we take a count little higher up at 50,000. And also if any patient needs a sudden emergency surgery, we take 50,000 minimum and then transfuse them with platelets. This is what we have to do. Antibiotic usage is only if there is bacterial superinfection. Now, how do we prevent? There is a tetravalent vaccine under trial. Now, this again, we still have no full data that is available because now we have already known if there is one variant which has already affected an individual and the individual strain, they might develop complication. So taking all the common four, they have formed a tetravalent vaccine, which is under trial. We might hear about it shortly. Before that, there needs to be an integrated approach in housing, water, sewage and waste management, anti-mosquito measures using insecticides, repellents, mosquito nets, and anti-larval measures. Introduction of mutant mosquitoes in Malaysia and Cayman lands has been on the experimental stage. They have introduced Wolbachia species bacteria into mosquitoes, which would prevent the mosquito to develop or get infected by the virus. Now they have been doing it in Malaysia and in Cayman Islands. Probably we might get it in future. Now in conclusion, remember, dengue fever is rapidly spreading arbovirus, second only to malaria, nearly 100 million cases with 0.5 to 1% mortality. That means, in essence, it is less than 1% mortality. 0 to 5 million serious cases needing hospitalization. This number is all over the world. Till today, there is no definite vaccine or specific antiviral drug. Treatment is purely symptomatic. Preventive measures against the transmission from mosquitoes are the only ones that we should always remember. Now, the worrisome factors are the incidence increased nearly 30-fold from 1960 to 2010. 1980s saw a second expansion. Rapidity of travel and global warming increased the incidence of infectious diseases all over. Deforestation or total afforestation, unplanned urbanization, deteriorating public health measures are another cause. Dengue appears to be running against stream by becoming a greater public hazard by changing serotypes faster, increasing the virulence. Increase in the frequency of dengue hemorrhagic fever syndrome, a severe complication normally arising upon, do remember, only on reinfection by another virus. According to Thomas Decker, friends, remember, this world we live in, after all our science and sciences, is still a miracle. It is still wonderful. It is inscrutable. It is magical and more to whosoever will think of it. Thank you very much for a very patient hearing. Thank you.
Gopal Raju garu, sir. Kindly unmute your phone, sir. Dr. Gopal Raju garu. Dr. Gopal Raju garu, kindly unmute your phone. Kindly unmute your computer, sir. Laptop. You are not audible to us. Unmute, sir. Unmute చేయటం.
సార్ ఇక్కడ బాటమ్ లో ఉంటుంది సార్, బాటమ్ లో లెఫ్ట్ సైడ్ లో ఒక మైక్ ఉంటుంది, అది మైక్ ఉంటుంది, దానిలో మ్యూట్ అని ఒకటి క్రాస్ మార్క్ ఉంది, దానికి ఓపెన్ చేయండి.
Can I say a few words, Dr. Subbarao and Dr. Gopal Raju?
Sir, Dr. Gopal Raju garu has not unmuted his instruments.
I can add few things.
Sir, go ahead, sir. Please, sir. Kindly, sir. Kindly go ahead, sir.
Right. Now, this I just wanted to do it for completion's sake, which I have avoided. That is the treatment with the carica papaya leaf extracts that we have been using as the pills now. This I have avoided because though the company sent me slides, they were little late in sending, but then I thought it is okay. When I went into the details and literature and checked it up on net, I found this was first being used, experimented in Sri Lanka, mainly on mice and rats, and found improvement in platelet count and also in RBC. But the snag is these were normal mice and normal rats. They are infected mice or rabbits. So this belongs to an alternate medicine. Though this is on the bioethical way, I have not included it, but there are a lot still use this drug.
Sir. Yes, sir. Yes, sir.
This is what I have found it. So
this is the era of evidence-based medicine, sir. Yeah.
That's what
So
I'm saying.
actually, we can't. Sir, picture should be used.
So they have also tried in one case in Pakistan, according to the literature that is available. And the beauty of it is these mice are rats where it was tried in Sri Lanka. They are normal mice and normal rats. None of them are infected mice or rats.
They are not dengue infected rats or mice.
Right. So whether the improvement that we get in us by using, is it as the disease comes down, the body takes over with the supplementary medicine, or is it because the drug acts by itself? There is no data available in human beings to the best of my knowledge. So that's why I did not talk about it. Thank you, Dr. Subbarao.
Thank you, sir. Just like Anandaya medicine for corona, now being very popular, we can say the same thing for Tegoda Karika Papaya. Sir, thank you very much, sir, Dr. Telagaru and Dr. Gopal Lasgar for sharing this session. Now I have got 3 guest lectures lined up simultaneously, Hall 1 and Hall 2, 3 guest lectures. Right? The Hall 1, the 3 lectures, let's start with the history of medicine by Dr. Srinivas, Professor and head of the Department of Medicine, Andhra Medical College, Visakhapatnam. Dr. Srinivas Sambhaktula is the
Sir, is my screen visible?
Yes, sir. Let me give you a small introduction of yourself, sir. Is Srinivas Sambhaktula is a professor in the Department of Medicine, Andhra Medical College, Visakhapatnam. He did his MBBS from Andhra Medical College, 79 to 83. His MD General Medicine from Guttur Medical College from 86 to 89. He was the best outgoing postgraduate student in MD and University first postgraduate final examination. He is awarded the Best Doctor Award for twice from Superintendent King George Hospital and also received District Collector Award. He is also the Vice President of Andhra Medical College Library and Chairman of Association of Physicians of India, Visakha chapter. He is a co-investigator for Covishield vaccine, the corona vaccine in KGH. He has got multiple publications to his name on cerebrovascular accidents, hyperthyroidism, familial hyperlipidemia, lymphohistiocytosis, to name a few of them. Such an illustrious career, Dr. Srinivas Sambhaktula, to deliver his lectures. Sir, please come online, sir.
Thank you very much, sir, for the nice introduction. At the outset, I'd like to congratulate Kim Samalapuram, sir, for taking a lot of pains in organizing this eAPAPICON at this particular juncture of the year. And my thanks are due to Dr. Jawahar, my friend, and Dr. P. Subbarao and his team for organizing this and selecting me as one of the speakers. And I'm fortunate enough to speak in front of my 2 teachers, Dr. Tilak and Dr. K.V. Raman Rao, sir. So it is said that, sir, all work and no play makes Jack a dull boy. So whenever a CAB program is conducted, we speak of subject, and subject. So this time I have selected a topic, history of medicine, which would be useful for the postgraduates. We read a lot of subject, but we don't go into the medicine, especially the history, how the medicine has evolved as a science. So this is my topic, sir, and the history of medicine. So the 3 words which often throughout our life, the 3 words which you should often have in your face. Sir, already shared, sir. Doctor, patient, and disease. So that the 3 words which often speak of, and the meaning of these 3 words. The docos means to teach. I often teach my students. We are a blend of both. Docos is a teacher, the 2 noblest professions in the world, teacher and a doctor, and we are a blend of both. Pati means suffering. and ease means comfort. So they're the three words which often we use. So anything which causes discomfort to the person, whether physical, mental, or social.
Srinivas sir.
Sir. Sir.
Sir, can you share screen your slides? Not sir, not sir.
Just a minute. Able to see, sir?
No sir, no. Please close the slides and then once again you open, sir.
Slide sharing.
Sir? Just a minute, sir.
Madan, can you set it right?
See, sir?
Not
Is
yet,
it okay,
not-
sir?
Not yet.
Still not. Not yet.
No, not visible. Srinivas.
Just a minute. Just a minute, sir.
Go for screen sharing mode with video technology.
Okay. ఒకసారి తొందరగా రండి ఇది స్కేర్ అవ్వట్లేదట స్క్రీన్ సార్ జస్ట్ మినిట్ సార్ దిస్ టైం
Fine.
Okay, sir. Okay, sir. Technology is still something a little bit difficult for people like us.
మధ్యలో ఆగిపోయిందండి టాప్ జస్ట్ 1 or 2 minutes సార్
Sir, can I share the recording?
Just a minute.
No, sir. Okay, sir.
It's over?
Yes, sir.
Are you
Yes,
able
sir.
to see now, sir?
Full screen.
Yes, Srinivas, we are able to see.
Yes, sir. Yes, sir.
Okay, yes, sir. Thank you, sir. So these are the three words which you often come across throughout our lives. Dokos means to teach, pati means suffering, and ease is comfort. Now, it is said that those who fail to read history are destined to suffer the repetition of mistakes. And human races and racial customs have changed in the sense of becoming more highly specialized. But the heart of man remains the same. And Dr. John Burroughs says, man has climbed up from slower animal, but as he has, as it were, pulled the ladder up after him. Sir, we human beings are usually often compared to crabs. And it is said that live crabs, when they're exported in large drums or tins to the other countries, and they travel miles and miles in drums without lids, live crabs. And the thing is, miraculous thing is, not even a single crab escapes, even if it goes to the destination. It is said that if one crab goes up, other crabs tries to pull it down. The same is the human being. He has climbed up from slower animal, but he has, as it were, pulled the ladder up after him. And Italians rightly compared primitive man to civilized man by the saying, "Perche pensha, persando es invetia," meaning with knowledge increases sorrow. The more knowledgeable we are, the more sorrowful we'll be. And the primitive medicine stands between magic and religion. So this is the magic. They used to think that evil spirits might have fought these people who are suffering from the disease. And the actual medicinal knowledge was a primitive man was far from contemptible, it is said that. The function of the medicine man was a limited one, and the art of healing never progressed as long as it was under the sway of belief in the supernatural. So they used to think of evil spirits and supernaturals only. And the savage experienced by herb doctoring, bone setting, and root surgery. And later on, as the savage got more and more experience, so three types of people have evolved: herb doctors, bone setters, and root surgeons. Along with these natural healers, wise women also started midwifery. So herb therapy became a natural healing, and wise women took up midwifery. And Indo-Germanic medicine became the foster mother of many sciences. So this is the herb therapy, this is the bone setting, and this is the root surgery they used to perform during those olden days. And primitive man used a lot of herbs, and he knows the medicinal values similar to the drug phase of our modern therapeutics. Now we use a lot of drugs. We know which drug is derived from what plants, and primitive man knew the most fatal arrow poisons like curare, obain, varatrin, boundu, and virtues of drugs like opium, hashish, hemp, coca, cinchona, eucalyptus, acacia, tobacco, podophyllin, etc. So this is what I have depicted. And many of you might have seen the movie Gods Must Be Crazy, where tribal people from Africa, usually they used to have a language which is like a clicking sound, and they used to use this arrow poisons to hunt animals. And Indians were aware that arbutus was good for rheumatism, lobelia for cough and cold, and wild ginger and ginseng for digestive disorders, sassafras and violet leaves for wounds. This is ginger, ginseng, and these are the violet leaves. And he is Dhanvantri. I'm coming on to the Indian medicine, a few words of the Indian medicine. The medical systems that have the deep roots in India are said to be Ayurveda and Siddha. And Ayurveda by definition is known as the knowledge of the life and dates back to 5000 BC. And the father of Indian medicine was none other than Dhanvantri, is born out by the churning of the oceans during the tug of war between the angels and demons. You can see the picture, the angels and demons. And these celebrities of this system of medicine were Atreya, Charaka, Shushruta, and Vagbhat. And Ayurveda flourished during the tenure of the Buddhist rulers, especially King Asoka. And Charaka, the court physician of King Kanishka, was the author of Charaka Samhita. And Shushruta, the father of Indian surgery, he authored Shushruta Samhita, the compilation of his surgical works, which gave place to medicine, pathology, anatomy, midwifery, hygiene, ophthalmology, and bedside manners. This is the picture of Shushruta Samhita. And Ayurveda started to fade away during the period of Mughal Empire. So once the Mughals invaded India, Ayurveda usually stood as a backstage, and Unani and Tib have come into the forefront. So I mentioned about Unani, Tib, and homeopathy, which were from Greek and German medicine respectively. And at the same time, Samuel Hahnemann was the propounder of homeopathy, and it means like cures like. And India is said to have the highest number of homeopaths. In spite of all our allopathic doctors, India is said to be the highest number of homeopaths, even though Samuel Hahnemann was a German. And the drawback of this medicine, homeopathy, is the lack of emergency. Emergency medicine is lacking there. And all the three systems, Unani, Tib, and homeopathy, are still alive in India. And most often it is said that people usually deceive the patients by displaying their boards as MD USA, Unani, Siddhi, and Ayurveda. Now, coming on to the Chinese medicine. And the Chinese medicine is said to be the best organized system of medicine, and it dates back to 2700 BC, and it is based on two principles, yin and yang. Yin is an active masculine principle, and yang is a negative feminine principle, and the balance between the two is being good health. And it is said that Chinese doctors were the pioneers of immunization. And the mythology says the greatest doctor is one who treats not someone who is already ill, but someone who is not ill. And Chinese have two important types of doctors previously, the barefoot doctors and the acupuncture. And one important thing is, true to say that facts are stranger than fiction. Chinese used to believe that a nerve used to pass right from the ring finger to the heart. And it is said that if at all a needle is pricked to the ring finger, it usually cures the heart ailments. And even now, the wedding ring is worn on the left ring finger only, because it is said that a direct nerve goes towards the heart, and the bond between the wife and husband usually goes on. Now, coming on to the Egyptian medicine. Egypt boasts that it has one of the oldest civilizations in the world, and the Egyptian medicine mingled with religion. And here we have to keep in mind that anatomy was a distant dream, because the religion strictly believed in preserving the bodies. The so-called mummies, right now we know that Egyptian mummies are kept in the pyramids. Similarly, anatomy is a distant dream because they used to preserve the bodies after the death. The best known Egyptian manuscripts were the Edwin Smith papyrus, which date back to 3500 BC to 1150 BC. And diseases were treated with cathartics, bloodletting, and enemas. This is Edwin Smith papyrus, the cathartics, bloodletting, and enemas. This is how they used to perform an enema. And the god of medicine of Egypt is Horus. Mesopotamian medicine. The Mesopotamian medicine, that is the Mesopotamia, now part of Iran, is known as the cradle of civilization 6,000 years ago. And medicine was practiced by three types of doctors: herb doctors, knife doctors, and spell doctors, similar to the present day internists, surgeons, and psychiatrists. So these are the types of doctors, and you can see in the picture, in the middle picture, where circumcision is being performed, and the patient is standing or unfolding over the back of the patient, and a sharp rock is taken, and the foreskin of the penis was cut. This is how the circumcision was performed during those days. Now, Greek medicine. The period of Greek medicine between 460 to 130 BC is said to be the golden period, and Greeks taught men to think why and how. Asclepius was the teacher, and he has to have two daughters, Hysia and Panacea, worshipped as goddess of health and goddess of medicine, respectively. Asclepius is still cherished in medical circles. His staff entwined with the serpent continue the symbol of medicine. Is Asclepius, Hysia, and Panacea, and this is staff. This is a staff entwined with a single serpent. It's not two serpents, it's only one serpent. He is cherished as the symbol of medicine. And the greatest physician in Greek medicine was none other than the father of medicine, Hippocrates. And his lectures and writings were compiled by Alexandrian scholars as Corpus Hippocraticum. And Hippocratic oath has become the keystone of medical ethics. And Hippocratic thought has changed the destiny of medicine by dislodging it from the state of magic and elevating it to as the study of science. And the glory of this Greek medicine was decayed by the Roman civilization. So he is our great Hippocrates, and the tablet on which the Hippocratic oath was inscribed. Roman medicine. Well, Romans borrowed medicine from Greeks. Public health was born and hospitals were established during this period, and the outstanding teacher was said to be Galen. Galen was known as the medical dictator, as his views of medicine were held good for nearly 14 centuries, because nobody used to question Galen, because whatever he said during those periods is said to be because he is said to be the medical dictator, and everybody used to just believe what he said. And his views were not challenged for nearly 1400 years. The other two persons who came after 200 years, or born 1500 years after his death, were Vesalius, the anatomist, and William Harvey, the physiologist. So these Galen, Vesalius, and our William Harvey, the father of circulation. Now coming on to the modern medicine. So we are in an era where everything is tailor-made for us. Only thing is we have to pull out the strings and we have to tie a knot, and everything is so tailor-made that we have to go for a single diagnosis in the right direction. And the modern medicine is said it was born after a gestation of periods of millions of years. So modern medicine had a gestation of millions of years, but the milestones are said to be rapid, because once it is born, the milestones have to be rapid. For the past few decades, we have seen a lot of technology being improved, and most of the people are being cured by their long-standing diseases. Truly, it is an evidence-based one. And more stress is laid on prevention rather than cure. And the smallpox was conquered thanks to Edward Jenner. Poliomyelitis is on the brink of defeat thanks to Sabin and Sag. So this is how smallpox used to be. And these Edward Jenner, poliomyelitis, Sabin and Sag. So these are the pioneers of medicine. Not only these people, a lot of people who toil their midnight oil to give a safe life to the human kind. And medicine progressed from a glass piece to microscope, and later on to MRI, PET scans, internet, cloning, genetic engineering, gene therapy, human-computer interfaces, nanotechnology, and designer drugs. And intensive care units, you can see the intensive care we are giving right now to these patients. And imagine yourself lying on that bed. They have become intensive care units. And this is how a patient who is on the operating table looks like, just like a skull, and the surgeon's peeping at him. And medical science is growing leaps and bounds. Newer challenges stare at the physician now. Diseases like cancer, diabetes, mental illness, cardiovascular disease, retroviral disease, and accidents have come to the prominence, and they cannot be explained to the germ theory. And physicians are faced with the prospect of dealing with patients who arrive with sophisticated knowledge and information regarding their illness. So it is very easy to treat them, but it's very difficult to pacify them. And mankind has seen many a disaster like smallpox, Hansen's, plague, poliomyelitis, tuberculosis, swine flu, Ebola, and Zika. And the latest challenge, coronavirus, the COVID-19, which has killed millions of people. So in spite of all these revolutions, what makes a physician stand tall? Because we should be proud of physicians. The clinical skill and the humanitarian approach, which keeps us on the throne of success. The investigative procedures, which often I teach to the students, should only supplement but not supplant the physician's approach in making a diagnosis. So clinical knowledge is more and more important. And here I want to recapitulate a great saying: no greater opportunity, responsibility, or obligation can fall to the lot of human being than to become a physician. In the care of the suffering, it needs technical skill, scientific knowledge, and human understanding. Tact, sympathy, and understanding are expected of a physician, for the patient is not merely a collection of symptoms, disorders, damaged organs, and disturbed invention. He is human, fearful, hopeful, seeking relief, help, and reassurance. This is said by none other than our great Kinsley Harrison. And from inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. This is done none other than our great Hutchison. And no medicine is complete without a mention about this great man, Sir William Osler. He said, even after teaching 25 years of medicine, what I came to know is 50% of what I teach is wrong, and I don't know which 50% it is. And he said the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. Sir William Osler. Thank you very much. Thank you, Ramut, sir.
Thank you, sir. Thank you, Dr. Srinivas Garu, for giving us a glimpse of the history of medicine. It's but true that we should know our roots. It's always enlightens us, makes us more wise, and let the wisdom pass, allows us to pass on the wisdom to the next generation. Thank you, sir. Thanks
Thank
for
you very much, sir.
picking up this topic and enlightening us, sir. Thank you, sir. Now for the second lecture in the prelim session by Dr. C.H. Manoj Kumar, physician, Manipal Hospital, Vijayawada, and Vice Chairman of eAPAPICON. It's about the end of life care, the role of a physician. And now a few words about Dr. Manoj Kumar. He MD, FICP, FIMSA, FISCM, FRSSDI, and FRCP. Is a consultant physician at Manipal Hospital, Vijayawada. Presently, is a vice chairman of eAPAPICON. He is the vice president of IMA Vijayawada also. He is a member of ethics committee of HCG Cancer Center and is a life member of API, RSSDI, CIDS, ACP, and ADA. Now over to Dr. Manoj Kumar. Sir, are you logged in? Dr. Manoj Kumar. Right. We'll
be told by the moderator. You can start, sir. Okay. Yeah. Good morning, everybody. Thank you, Chairperson, for the kind introduction. First of all, I thank the organizers for giving me this opportunity to talk about this topic of end-of-life care. So, I took this topic, end-of-life care, because as a physician, we're all well trained with how to manage most of the medical conditions, treatment and diagnosis. But when we come to the topic of end-of-life care, we are not well trained. Even though this end-of-life care is a part of many textbooks, it has been neglected both in undergraduate as postgraduate courses. And we are not trained in managing patients with end-of-life care. So in this present era, to avoid especially violence against the doctor, every physician should update himself on how to manage end-of-life care. This is also very important for upcoming undergraduates and postgraduates, because palliative care is one of the specialty nowadays. There is a MD certificate courses also available. So, and it is a lot of scope in the future. And when we think a patient is in terminal care and we think he can't make out, you prognosticate the attenders. Three things can happen. Either they accept it and ask us to continue the same treatment, or they want to take to some other center, or they will go against medical advice. If they have some financial problem, take the patient away to home. So today we'll discuss about end-of-life care. So why end-of-life care? See, life expectancy is increasing. Especially in the United Kingdom, it is 81 years. In the United States, it is 78 years. In India, at present, it is 69 years. Non-communicable diseases also increasing, causing 5.2 million deaths per year. And trauma and road traffic accidents, 1.2 million per year. Cancer patients with advanced stage are also increasing day by day. HIV and other infectious diseases. All this population they form a major chunk for your palliative care or end of life care, which is a large burden. But when coming to the reality, the patients receiving palliative care in India is less than 1%. And patients having approached the palliative care are far more than who are received. There are no specialists most of the places. So managing end of life care is not a simple thing. It requires a holistic approach. So today we'll talk some of the important topics in end of life care. Even though it is a vast subject and it is a specialty by itself, I just want to briefly mention some of the important things which are very important, because every physician should know some things, because nowadays we're having more and more problem with managing the patient attendance. So we go through these topics like death, what is palliative care, what is terminal care, what is trajectory of dying, end of life care, when to start, what are the options available, what is dying with dignity, what are the ethics involved in end of life care, how to communicate a bad news, how to manage an anger patient is most important, and what are the medical problems, what we see in end of life care. So we all know that death is inevitable in reality. Neither you can hasten it nor postpone it at the cost of quality of life. So the end of scary last days or hours of the life, or managing the patient the last few days or weeks, when it is clear that the patient is in a progressive state of decline. So in a death, we should know when death is imminent, like in the terminal care when he is going to die. This we are supposed to know. So whenever a patient is very weak, tired, most of the time spent in the bed, either sleeping or is not getting what we tell is bedridden patients. There is reduced oral intake, and there is some difficulty in swallowing. Altered level of consciousness, sometimes he drowsy, sometimes he talks. There is decreased urine output and constipation, and there will be changes in pulse, blood pressure, and respiratory rate. When all these things occurring in a terminal care patient, we know death is going to, it is imminent. It is going to happen like fewer days or hours. The next important thing is predicting the death. So we know even the patient is bad, roughly you should know when he is going to die. So the above parameters, imminent death, imminent above parameters, if they are occurring in hours, for example, morning his blood pressure is different, pulse is different, by afternoon it is changing, gradually it is worsening. So we know by next few hours or by next day morning he may be dying. So when the parameter changes in the days, hours or weeks, depending on that, we can roughly predict when he's going to die. And there are a lot of scores available to predict the death. But ultimately, all these things are different. Your sixth sense or the gut feeling. Sometimes most of the senior physicians tell, oh no, he's not going to make out, he may die. So these are also very helpful for predicting the death. So once you know death is imminent and you predicted a death, then comes the end of life care. Is the approach of terminally ill patient that shift your focus from care of symptom and control of the symptom, the comfort of the patient, the dignity and quality of life, and quality of death with support of the family members, rather the treatments which cure or prolong life. See here, we are not trying to deal whatever condition he is having, medical condition. We are trying to deal the terminal care, what are symptoms which are more bother to the patient or more troublesome to the patient. It's symptomatic approach. It's only like breathlessness, how to calm down the patient when he's breathless, patient having some pain, how to treat that pain. So this should be done not only ourselves, all the family members are involved, and it should have important thing is quality of life and quality of death. So these are very important when you are retaining at the end of life care. So you can't go on doing things which cause more harm to the patient or more worry to the patient, more trouble to the patient. Comfort and dignity is also very, very important. So we should know some difference between palliative care and terminal care, all these terminologies. The palliative care improves the quality of the patient quality of life of the patient with the life-threatening illness and their families. Not only the patient, we have to take care of the families also. So for suffering by means of early identification, implicable assessment, and treatment of pain, physical, psychosocial, and spiritual problems. So this is a holistic approach. We have to take care of the patient, with the family members, everybody. Not only is physical symptom, psychosocial, spiritual, all the problems. It is a holistic. This is called holistic approach. So this includes. It's not a simple thing. It is a team approach. And palliative care is it's very important in the end of life care. The difference between palliative care and terminal care is palliative care begins from the day one of diagnosis. For example, patient is diagnosed with cancer. From that day, the palliative care starts until he reaches the terminal phases of terminal care. Terminal care is what we are having in the last few days or few weeks or before a death. So terminal care is a part of a palliative care. Even though end of life care, terminal care, palliative care, everything is a spectrum. It's not like you can't separate them. But to say roughly, all these things are one and all. But practical wise, terminal care is just before death. So here this is shown the palliative care, end of life care, terminal care, acute. Acute some patients, even though terminal care, some patients, some differentiate with few hours or a day or before the death. Whereas end of life care is maybe a week or days before death. So trajectory of dying, how a patient dies is a map. Trajectory is a map. Course decline in terms of shape and duration. A particular path illness take towards the death. So, how a patient dies, there are certain ways of sudden death. Suddenly can die. Terminal illness, cancer, where gradually the organ failures, short failure. Real thing, it's only some advanced age, catastrophic events, stroke. So all these 5 types of death I've shown you in the graphic manner. So here the sudden death is the center where patient is totally fine, high function, suddenly he dies. So here most of the time the terminal care, palliative care does not apply because we have not anticipated this death. This is a sudden death. So other 4 ways, the sudden death actually in younger patients most of the time is occurs because of road traffic accidents or some illnesses like this. All these sudden death. Whereas the other 4 things we can see more number of patients. Sudden death is the percentage of patients who are having sudden death are very less when compared to other 4 ways. See, in organ failure, there are a lot of ups and downs, but with each up time, you will not record the complete function as if is before. So subsequent gradually it is a declining course, but every time it comes on course of every decline, we will have some hospital admission and again discharge, again we come back after a certain time for one more admission. This is one way of for death. The debility of failure is advanced days, some dementia, some sort of some neurological illness where is totally bedridden, is on the bed and gradual decline. And in the terminal care of the cancer, so here gradually it goes down and it comes down until the death. Whereas catastrophic event, it totally normal functioning. One day you have a stroke, massive stroke, suddenly your function come down. From there gradually decline until death, where you may have some, for example, bedridden and they have some sepsis and some other event like even hip fracture patients can develop DVT and pulmonary thromboembolism, can die. All these things, the ways the patient die. So when you should start discussing about end of life care is any advanced age with multiple comorbidity states. There is a catastrophic illness with organ dysfunction unresponsive to aggressive treatment. Prolonged coma and vegetative state, incurable chronic severe neurological state with unlikely meaningful life, like for example, quadriplegia, bedridden, not can't get up from the bed, and it is some traumatic heart injury. Progressive metastatic cancer with failed, all treatments failed, and post CPR. non-restoration. See, after CPR, you can have pulse and BP, but patient had brain dead or something like that. And finally, if the patient or family prefer to end of life care, there's also a point where we could start thinking about end of life care. So all these situations, end of life care discussion should start at that point. So once you know that it is end of life care, what are the options available now? So there are 5 ways. Either you have full support. Some patients tell, no, we don't want to take any risk. The financial problem is not there. You continue the treatment, whatever is problem, do whatever you want, go aggressively and do it until he dies. So this is a full support where you can go for ventilatory supports, your inotropic supports and all, if needed ECMO and all those things. Some people, they tell, do not. So this, if a patient gives DNR and DNA, there is no point in intubating and doing on CPR and everything. Withholding of life support, withdrawal of life support. So there are two things. Withholding of life support is different from withdrawal of life support. Withdrawal of life support is stopping whatever treatment is going on, is withdrawal of the support. If patient is on nine ropes or patient is on ventilator support, stopping that is a withdrawal. Whereas withholding is whatever treatment you are doing, not escalating the treatment, not increasing the new, not introducing new treatments, not increasing the more aggressive treatments, not putting some more new drugs, some more antibiotics, some more antibiotics. So you no need to escalate whatever it is going on. That is withholding. Withholding is different from withdrawal of support. Finally, if the patient don't want all these things, so whenever even withholding or withdrawal also, we should have palliative care. You can't just leave the patient and tell this is the end of it. So we should have an alternative pathway, alternative care for the patient. You can't see him just dying before your eyes. So what is dying with dignity? A terminally ill patient should be allowed to have peaceful, natural, and comfortable death rather than aggressive, isolating, distressful, and invasive interventions. So dignified dying is natural death, free from avoidable distress, not only for the patient, for the family and caregivers also, in according to wish of the patient and family, and it should be consistent with clinical, cultural, ethical standards. So dying with dignity, to see that patient is not suffering in his terminal state, you should have a dignified death. You should not be bothered more, worried more, or you should not be going aggressive, go on doing tests and taking blood, drawing, putting some tubes and all. You should not be there. So not only this, you should also think of cultural aspects also. And all these things are very important in dying with dignity. So what are the ethical problems in this end of life care? So here some things are very important. Autonomy of the patient. Each individual has right to make decision with his or own life. So that is very important. If a patient is well educated, patient can understand the things. So it is better you give the option to the patient what is the present situation, what he want in life. And beneficiency is choosing the best action for the patient. For example, referring the patient to appropriate care or referring to some other center where he can do whatever possible for. Non-conficiency is do not do anything which harm the patient. And justice is we should ensure equity and equality of care for all. All patients are equal. So when you are treating the patient, you can't tell VIP, non-VIP, good, bad, all those things. Respect for the patient. Every human being is superior to each one of us in some way and deserves of respect. Even though patient may be in a very poor state, poor condition, he may be worthful in other way. So you should respect the patient as a human being, fellow human being, and he deserves utmost respect. Confidentiality, don't disclose any information of the patient except if you are legally bound. So if you are disclosing, you should know whom you are disclosing, why you are disclosing. And non-judgmental approach, duty to the best. See, patient sometimes attendance or patient will be very bothersome. You can't tell he's a very bad patient, he's not listening to me. So our as a doctor, we should do whatever best possible for the given patient. Informal consent, to take consent to all procedures, whatever doing in the terminal care, for example, putting a line or taking something else, everything should be taken from the information. So living will or advance directive, it is a legal document that expresses the patient wishes and desires for one's own health care and treatment. In case if she cannot she become terminally ill, unable to speak for oneself. See, for example, we all are accustomed in writing for our properties will anywhere before death. Like that, how you want to die, how where you want to die, whether things should be done, what should not be done, everything you can make it as a legal document. So these legal documents ensure that patient end of life decision is honored. So this can be made, and most of the time it is quite in our country. Most of the people don't do this. In out of our country, states and all, advanced directive or living will is most commonly practiced. And other way of doing it is, if, for example, you have very close friend or a family member who knows you very well and who understand you very well. It is a making some surrogate. You that fellow will represent on behalf of you, because at that point not be in a talk for himself, or patient may not be in a composed state. So what he wanted, how he wanted to die, is how he wanted to be in the terminal phase can be represented by a surrogate person. So two ways you can think how peacefully you want to, you can make how peacefully you want to die. So reconsidering for cardiopulmonary resuscitation. So whenever you are admitting a patient who is critically ill and you know his patient going to die, it is better to discuss with the family members about cardiopulmonary resuscitation, because most of the hospitals, as soon as the patient have a cardiac arrest, immediately either the duty doctor or the sister will start cardiopulmonary resuscitation, and they initially sometimes intubate the patients and try to connect with the ventilators, everything they do, and only patient will be dying next 1 hour or 2 hours or next by that same night. So can we know certain conditions like it is a cancer, advanced cancer, it is vegetative state, or it is a multi-organ failure? It is better not to do all the CPR. You explain the patient attenders. So there is no point in, see, anyhow, you know, he's going to die. There is no point again to do a CPR and pulling for some more days. But some cases like trauma, drowning, or poisoning, or shock, still you can consider for CPR. You can give one chance, because these are the situations where sometimes patient can be revived. So you should know when you can do the CPR or when you should not do the CPR, because CPR is a really it's a process like where again not only you are trying to hurt the patient, you are trying to pull the patient, those who are going to die for some more time, or and you are even increase the bill of the patient. So communication, bad news, how to communicate all this. So communication is acknowledging and understanding the concern of the patient, the concern of the family, and responding in the most appropriate manner, trying to bring clarity in the current situation. It is exchange of ideas and feelings between two or more persons. So a bad news is any news that adversely affects the patient view of his or her future. Say suddenly you tell you have a cancer, definitely patient may have some ideas about the future, and it is definitely a bad news for him. And it is a gap between the patient expectation of the future and medical. Definitely, patient have all this physical, spiritual. Patient will ask you one question and you can't tell them, and personal the relatives don't tell the exact name. Always it is there are ways to manage this position. It is better the patient knows his diagnosis and his end of life and terminal case, because at one or the other point, if you know that we are against, like for example, we are hiding things with the patient, and patient came to know, definitely the trust and the belief with the doctor goes, and patient sometimes become non-manageable, and they go against whatever you tell. they don't follow your advice, all these things will happen. So how to manage the pollution, even though initially you tell us to the patient attenders, sometimes the patient attenders will force you so much. You have to gradually explain to the patient attenders. It's better to explain to the patient, and if needed, you can tell, no, if you are unable to tell, we can tell, or you can take somebody's help to see that he knows his prognosis. So pollution should be as far as possible avoided. And finally, spiritual care is a big aspect in the terminal care. The spiritual care, most of the patient, when he know he's going to die, definitely patient have all these physical, spiritual issues. So if some patients want to have some prayer, say they come and do prayers. Some patients want to put one you can arrange. They want to put some tie to all these things. You have to allow, because sometimes even though nothing can be done, but definitely that makes some impact on the patient. Patient attendants don't go against you. Tell no, all these things we don't believe. It's better whatever patient want, let them try in the last moment, because they have their own ideas. And bereavement is managing the patient attendance after patient death or around the patient death. And this is a bereavement management is very different, and it goes not only a day or two, it may go up to 6 months or even a year in this one. But most of the time in our setup, we don't do once the patient goes out, and definitely we are into our business the next day. Either patient attendance turns back, or neither we go and find out what is happening to the patient. So these are all the problems with end of life care. And so finally, any patient, if in the situations seen in both these pictures, it's better to have a situation.
We are having a technical problem. Dr. Manoj, are you online?
Yes, sir. Yeah.
Oh, Dr.
I'm online,
Manoj. Hello, how are you, Manoj?
Fine, sir.
Fine. Okay. No, actually, I was thinking that you'll talk about euthanasia and all those things, but I think the technical problem has come with your recording. So I think our people are trying to restore it back. Just a minute. Try fast forwarding it.
లిటిల్ కమ్యూనికేషన్ దగ్గర ఒక 2 స్లైడ్స్ ఉన్నాయి సార్. అంటే అక్కడ మెయిన్ బ్యాడ్ కమ్యూనికేషన్ ఎట్లాగా డీల్ చేయాలనేది.
Yes, Manoj, because most of the times we see people assaulting patients, relatives assaulting the doctors, damaging the hospitals. So there is some sort of a communication gap between them and us. So that should be addressed. I think you got that in your slides.
Yeah, communication తర్వాత కొద్దిగా 2 స్లైడ్స్ పెడితే సరిపోతుంది. Care and communication slide. Back. దీని తర్వాత నెక్స్ట్ స్లైడ్.
Yes. Okay.
Yeah, this is
go ahead.
Trust between the patient and the doctor. These two things, unless are not, you can't communicate well with your patient. Empathy is understanding of other person's feeling. For example, place ourselves in other person's shoes. Empathy is more important in all patients, not only in eternal care, even normal patients also. And the last one is unconditional positive regard. Don't judge a patient. See, sometimes patient may be anxious, or patient may be anxious, or patient may be shouting, or he may be scolding you, all those things. Ultimately, you should not classify patient is good patient, is a bad patient, is a VIP patient. Those sort of things should not be there in a terminal care. So when you want to communicate, unless you have very good trust, it's very difficult to communicate bad news. So we can make next slide. We can make it next. This is approach called spikes. Most of us we do after seeing the patient, no, he's not going to make it. Unless you have very good next trust, it's very difficult to communicate bad news. Invitation, knowledge, emotion, and summary. Setting is provide listening skills. Hearing and listening are both are different. Listening is an art. Hearing is what we do regularly. Unless you have a very good listening skill, you cannot become a good communicator. Listening is what, when you listen properly, you can communicate properly. And the perception is assess how patient perceive the situation. See, patient may be coming from different backgrounds, or patient may be different financial backgrounds, from education backgrounds, social backgrounds. What he is thinking about the current situation, you should know what he is thinking and what he knows about it. Unless you see, for example, if you are sometimes there may be a medical man in that group, so you should know who is a medical man, who is a non-medical man. There may be a IT professional who goes through Google and get all the knowledge. So unless you know all these things, you can't communicate. Communicating with a medical person different, communicating with an IT person is different, communicating with a layman is different. So final next one is invitation. Ask the patient how much information he wants. See, some patients want, see, you tell us whether he's going to make out or not. We just want to know if he's going to live or die. So that they sometimes they may have to take certain decisions, like financial aspects, all those things. Some patients they don't want to know the bad news. They want to somehow need some more preparation. So you should know how much the patient is expecting from us. So what they want. See, if a patient who want whether it is death or life, there is different issues. Some patients who don't want that news, you should be preparing them and telling news carefully. Knowledge. See, when you are explaining things to the patient, you should explain in non-medical technology as far as possible. For example, you can tell there is a problem in your head, or a problem in the stomach, or problem in the kidney. You can't tell it is a pyelonephritis. You can't tell something medical terminologies. Try to use non-medical terminologies, because some people think by explaining more medical terminologies, they feel that they had communicated very well. It should be tailored to the patient, who is the opposite person. If he's a medical man, okay. If it's a non-lay person, there is no point in telling ischemic to hypoxic encephalopathy. So emotion, ultimately, with empathy, how they are feeling, how you are talking. The emotions are very important communication of a bad news, the skills, and summary. Summary is most important. Doing everything, whatever main points are there, what is the current situation, when is going to die, what are the options available, what you are planning for next. Everything should be again repeated briefly, and see whether this fellow had understood or not, and ask him to ask questions, or ask them to explain whatever is happening. Otherwise, most of the time, we think we had explained the patient, but ultimately, after coming out, patient tells nothing is told to us, because the main problem is the communication skill is very important. See, you may be spending half an hour explaining the whole situation to the patient, and finally, patient tells nothing is controlled, and we don't understand anything, and we don't know anything. So this is most commonly what we see in our practice. And what is not communication? Conversation one sided. When patient is sitting and listening, you want telling whatever you want, and that's not conversation. It is not communication, it's conversation. And try to convince the patient to follow your advice. See, you are not telling what is the present situation, what are the things available. You tell no, patient is bad, you take him, or no, patient is bad, patient is okay, you can continue. All this. You start give a simple advice, and you convince your patient. No hierarchy is like you tell I am so and so experienced, I know everything. What you know, it is whatever I tell, it is right. So this is not a situation, it is not a communication skill. We should try to avoid this hierarchy. All these things will lead to misunderstanding, wrong interpretation, confrontation by the patient, inappropriate decisions, and lawsuits. This is very important in communication, bad news. Once we communicate bad news, the next thing is during communication.
టైం పడుతుంది గంటన్నర పక్కన
Communicating. 70% is non-verbal. Non-verbal is the body position, the body language. You have to maintain the eye contact, the posture, how we are sitting, the facial expression. See, patient knows whether we are with him, or we are trying to see our laptop, or we are trying to see our mobile phone, and we want to run out of the issue. So on our face it is shown. The tone of the voice, how you are coming, how slowly or how harshly you are talking. Depending on that, even though you tell truth, but the way you tell it makes a lot of difference. You have to ask the question to the patient, and reassuring touch is one of the most important when you are doing with your patient, not the attendant. and encourage for the patients to talk or the attenders to talk. So this non-verbal communication makes so much. Even though verbally you tell everything right, but the way you presented it, the way you sit, the way you are talking, the way your face is showing that you are in a hurry to go out, the way your tone explains that you are not interested in the patient. So non-verbal communication clues or body language is very, very important in communicating bad news with the patient. Once you communicated well, most of the time things will be okay. But still there are certain persons who get anger. So what is anger? It is high energy consuming negative emotion. It happens after one or two stressful triggers, but directed to the nearest person available, not at the source. For example, you are a doctor, you made a mistake, but the fellow first don't shout on you. You shout on the next to you, that is a sister or a ward boy or who are available or a billing person. So, and often person who is non-threatening, less threatening. For example, patient may not shout to the doctor very directly, but they shout at the sisters or the nearby persons more. So who are less threatening or non-threatening. So this is anger. So how to manage this anger patient is very, very important in communicating bad news, because even though 90% you can communicate well and most of the patients are well, there are 1 or 2% who definitely will get angry or sometimes he go against you, whatever you're thinking. And this is the trouble situation. So how to manage anger? First and foremost, allow the anger to go without confrontation or ignoring. If a patient is shouting and talking, just let him shout or talk. Don't go on objecting him or don't go on. If he's shouting, you are looking after your own work. These things will really upset the patient attenders. Anger may ignite anger within you towards angry person. So this is very common. When somebody is shouting, it's definitely we get angry on the person. So this is very an issue. For that, we should accept that we are getting angry and acknowledge it. Yes, we got it, and we have to first control our anger. Unless you control yourself, otherwise you go on shouting, other fellow go on shouting. It is not a communication. It became a big mob and ultimately violence against the doctors. So unless you accept and acknowledge and try to see you calm down first, then you can make the person to calm down. If you are angry with him, you can't argue with the patient. And you have to adopt the same body position. The patient is standing, you also stand up. If patient is sitting, okay, you can sleep. So patients both should be at the same position. Try to make eye contact with the patient. See, where eye contact is most important. If you're not looking at the patient face, they think you have made a mistake. And never smile in these conversations. And listening, active listening. Just let him talk, let him show for some time, active listen. And look factors, what the situation, why he become angry, and what point. Sometimes everything may be going up to payment of bill. If that is the situation, you can feel it. If something like some sister did some mistake, okay, that's different. So what factor exactly triggered this anger, you have to look up. And only after patient calm down, then you can suggest what to do next, and then you can apology, give apology at the end. So all these things should be done in a sequential manner. So managing anger patient is really not, unless you know that most of the time it is going to be a violence against doctor.
Manoj,
So
can
all
I
these
take
principles, all these situations are all when having one or two
Manoj, can I
in
take
a
the liberty of
separate
cutting
space,
short?
everything, not in these situations when the mob is coming and destroying everything.
Manoj, are you logged in? Dr. Manoj, are you logged in? Yes, I'm taking the liberty of cutting short Dr. Manoj Kumar's lecture because already he has been on screen for about 30 minutes already. So I think I'll have to apologize to him later on. But still, in the interest of the larger audience, I'll take the risk of cutting short Dr. Manoj's lecture. Now let's go on with the next one. That's by an approach to myelopathy by Dr. Sudhakar. Dr. Sudhakar, he did his undergraduation and postgraduation from Kannur Medical College, Kannur. He is a committed teacher ever since his postgraduation. He is now serving as head of the Department of General Medicine, Colonel Medical College, and is also the vice principal of Colonel Medical College now. He is distinguished in giving many orations. He has published many papers in reputed journals and guest lectures across the state, and recently a guest lecture on refractory in Kerala Epicon. That's good, sir. Nice, sir. Our people going to some other state and giving a nice lecture. Sir, now Dr. Sudhakar, sir, please log in and we'll have a lecture on my approach to myelopathy.
Good afternoon, sir. I'm Dr. Sudhakar, Professor and HOD of Medicine. I profusely thank the organizers for giving me this opportunity to present an important topic, a complex topic which more interests the postgraduates than the regular audience. Thank you, Subbarao Garu, Sharma Garu, Ivy Rao Garu, and Tilak Garu for giving me this opportunity. We'll start off with the lecture. Today I'm here to discuss about a very complex and intricate subject, approach to myelopathies. It's a very important topic in the sense that this is one subject which requires our basics to be strong. From anatomy to general medicine, we require all the knowledge we have acquired to analyze the disorders of spinal cord. First, the basics of the spinal cord, just a brief introduction. You know, spinal cord is a long, thin tubular structure which extends from medulla, and it comes down to conus medullaris at the level of L1 lumbar level, and then terminates at the coccyx. Okay, and it has got two enlargements at the cervical and lumbar regions to allow the cluster of nerves to leave the spinal cord. The white matter, it contains the ascending sensory tracts and the descending motor pathways. They are peripherally located in the spinal cord, and the central portion is the gray matter, where all the anterior horn cells and the dorsal and ventral roots are arranged. The spinal cord is covered in three layers: the pia, arachnoid, and the dura mater, which are continuous with those of the brain. The spinal cord, as you all know, contains 31 segments, each defined by an exiting ventral motor route and an entering dorsal sensory route. The peculiarity of development of spinal cord is it lags behind the growth of the vertebral column, with the result the spinal cord ends up shorter than the vertebral column. So the nerves which leave the spinal cord cannot immediately leave the vertebral body, sometimes have to travel down and leave in the corresponding vertebral column. That is the reason why you have these upper cervical leaving at the same as the cord level. The lower cervical from C5 to C7, they will leave one level higher. The upper thoracic from T3 to T4, they will leave two level higher. Lower thoracic from T7 to T9 leave at 3 level higher. The lumbar cord lies opposite the T10 and T12 vertebrae, and the sacral cord lies opposite T12 to L1. At L1, the spinal cord ends. These are the important sensory levels, because these are of they come into play when we are localizing the lesion. As you all know, C1 has no skin supply, and the C2 supplies the occiput. We have got some important landmarks. C5, the outer aspect of the shoulder. C7, the middle finger. Axilla is represented by T3. The lower rib margin by T8. The umbilicus by T10. The pubic symphysis by T12. Knee is represented by L3 segment. The S1 by the little toe, and the perianal region with concentric rings by S3, S4, and S5. This is the most important slide of our lecture, because this is a cross section of the spinal cord, the lamination of the fibers, as you can see, the corticospinal tract, the spinothalamic tract, and the posterior columns, they have the laminations arranged with the cervical being medial most for both spinothalamic and corticospinal, and sacral being the outermost for these two, whereas it is reverse, the medial most being sacral in posterior columns, and the cervical being the lateral most. And the distal limb movements are generally taken care of by the corticospinal and the rubrospinal tract. The axial proximal limb movements are taken care of by the reticulospinal, vestibulospinal, tectospinal tracts. And the pain and temperature by the lateral spinothalamic, and the pressure and touch by the ventral spinothalamic. And as you know, the posterior columns take care of the joint position, vibration, and sensory. These are just basics which all of you are aware of. Now we move on to the topic of our interest. How do we make a diagnosis of a spinal cord involvement, and how do we localize these? So what is myelopathy? It's actually a spinal cord dysfunction where a lesion arising within the spinal cord or a compression from outside can impact the spinal cord and disrupt the functioning of the spinal cord, and that is what is called as myelopathy. Myelopathy can be acute or chronic, and usually the acute myelopathies, they produce devastating results in the form of quadriplegia, paraplegia, and sensory deficits. The most important thing is why we are bothered about this localization and the diagnosis of acute myelopathy happens to be because if you start the treatment early, you're going to get them reversed in most cases. But the more you delay, and that is where the problem lies. The people who attend with these problems generally do not come to us. They resort to the local medicines or quack therapies, generally delay all this, and then when they come to us, the damage would have been done. So how do we localize a lesion in myelopathy stepwise? And so the first step happens to be, is it a spinal cord lesion? What are those symptoms and signs which suggest to us that there is a lesion in the spinal cord? So the signs that strongly suggest the involvement of spinal cord, the first thing is the crossed spinal tract involvement, unilateral pyramidal tract involvement, contralateral spinothalamic. You know, pyramidal tract, once they enter the spinal cord, they ascend up and cross at the highest point in the, they descend from the cervical and cross at the just after medulla, descend down to the anterior horn cells. So they cross above the cervical spinal cord, whereas the spinothalamic, they ascend up and they take a couple of segments at the point of their entry and then cross over to the opposite side. So they represent in the spinal cord ipsilateral and contralateral representation they have. So whenever there is a unilateral pyramidal tract sign and contralateral spinal tract involvement, that indicates a definitive spinal cord lesion. Then dissociated sensory loss. Suppose there is an involvement of the pyramidal tract and the spinothalamic tract with sparing of the posterior columns. That again localizes the lesion to a spinal cord. A root pain, the ventral and dorsal roots, which I have shown you earlier. See, this is the dorsal root, this is the ventral root, and these are the fibers on the outer side, and this is the gray matter, this is the white matter. Okay, these roots. Okay, so once these roots are involved, along with long tract signs, that again indicates a spinal cord involvement, as usually seen in spondylosis or sarcoidosis. The other signs which strongly favor involvement of spinal cord happen to be isolated tractopathies. See, for example, an isolated anterior horn cell involvement, isolated posterior column involvement, isolated spinothalamic cord involvement, tract involvement indicates a definitive spinal cord involvement. Lermite sign, a electric shock-like sensation traveling down the neck, back, or the extremities is usually due to spondylitic changes in the neck, and when this is precipitated by bending of the neck. Then if you have a sensory level on the trunk, on the torso, that again is indicative of a spinal cord involvement. And urinary retention is another pointer towards a strong involvement of the spinal cord. Then there are some signs which suggest to us that there is a myelopathy, but you have to consider the alternative diagnostic things. See, for example, you have got bilateral symmetrical sensory loss with normal reflexes or decreased reflexes. So one is bound to think with this sensory loss, there could be a spinal cord involvement, but we need to consider a polyneuropathy in this case, outside the cord. A paraparesis without any sensory signs, please consider a parasagittal lesion, because that can be an intracranial lesion. A parasagittal meningioma can produce a paraparesis. So it is a false localizing sign. Whenever you get a patient with hyporeflexia, hypotonia, we tend to think, okay, there's something seems to be wrong with the spinal cord. But again, there you need to consider a peripheral polyneuropathy. The unilateral or bilateral upper motor neuron lesions, you have to consider the lesion in the brain or brainstem. Ascending sensory loss, okay, makes us sometimes think the lesion could be localized in the spinal cord. But please consider AIDP or CIDP as differential diagnosis. There are some signs which appear to originate from the spinal cord, but which get worsened with exertion. So please consider the vascular lesions, multiple sclerosis, or a lumbar canal stenosis. What are the signs which are not in favor of a spinal cord involvement? A monoparesis of arm. All the cranial nerve deficits except the fifth cranial nerve, where you have got spinal, it has got the descending root of fifth nerve, which can come in and enter the upper cervical cord. So except for the fifth nerve, if there are other cranial nerve deficits, please consider either a brainstem involvement. Okay. Then pure lower motor neuron signs are usually not indicative of spinal cord involvement. A paratonia, that is where a passive movement elicits variable tone, that also can be a disorder of frontal lobe rather than a spinal cord involvement. Then you have got stiff person syndrome, where their spasms occur, and even the Parkinson's disease, there is less of spasticity, more of spasms. So we have to think of the other differential diagnosis rather than a spinal cord involvement. The dysarthria, dysphasia, brisk jaw reflex usually point the lesion to be either in a brainstem or a amyotropic lateral sclerosis. Weakness with normal sensation and reflexes, which has got the variability, usually points a diagnosis of myasthenia gravis. Is it a problem of compressive myelopathy or non-compressive myelopathy? This is the step 2. Having diagnosed a condition, all the signs and symptoms which are pointers of a spinal cord involvement, then we come to the next stage. Is it a compressive myelopathy or a non-compressive myelopathy? If it is a compressive myelopathy, what are the suggestions? What are the pointers to say it is a compressive myelopathy? The involvement of roots, okay, and the vertebral body, the radicular and vertebral plane, almost clinches the diagnosis to be a compressive myelopathy. Early upper motor neuron lesion signs, because the compression is from outside. Okay, so once the compression is from outside, there is pressure on the lateral corticospinal tract involvement, and the early upper motor neuron type of signs indicate a compressive myelopathy. Ascending paresthesias, I told you about the lamination. So if there is a compression from outside, it is the sacral fibers that are involved first, then the lumbar, then the thoracic, then last is cervical. If it's an intramedullary region, the reverse is the order: cervical, thoracic, lumbar, and sacral. So this pattern of involvement in laminated spine tracts usually indicates a compressive myelopathy. And Brown-Séquard syndrome, the hemisection of the spinal cord, is almost very classically involved by a compressive myelopathy. What are the features of compressive myelopathy? The root pains. These are the ones which are generally asked in postgraduate examinations. A lot of confusion is there while giving answers, and I'm sure these pointers will help you to definitely come to a conclusion that with presence of root pains, asymmetry of involvement, and bony deformity, bony tenderness, a girdle-like sensation at the level then a gradual onset and progressive onset, and early involvement of bowel and bladder. All these are pointers to say that there is compressive myelopathy. Then under compression, you have got extradural, intradural, intramedullary. The spondylosis, disc prolapse, the CVJ anomalies, fluorosis, tuberculosis of spine, epidural abscess. These are some of the important causes of extradural compression. Then the intradural happen to be the meningioma, neurofibroma, lipoma, sarcoma, metastasis, arachnoiditis, and AV malformations. So these are the intradural causes of the compressive myelopathy. And the intramedullary causes, the syringomyelia, ependymoma, astrocytoma, hemangioblastoma, and hematomyelia. These are the important causes based on the involvement. So what exactly, where exactly do these lesions happen? See, this is the cross section of the vertebral column. See, this is the vertebral body. This is a spinal process. This is a spinal cord. This is the dura mater. This is the dura. So extradural, this outside the dura, it can occur, it can involve the vertebral body or the spinous process. So these are the extradural tumors. Then we were talking about the intradural. Usually these are in the dorsal side, at the level of the dorsal root, at the inside the dura mater, compressing the posterior columns. This is where the dorsal columns are there, the dorsal root are there. So this is where the majority of lesions occur in intradural, but extramedullary. This is intramedullary. Both these are extramedullary. One is the extradural, outside the dura. One is intradural. So the location is very, very important for you to understand. And this is the intradural. This is the intramedullary tumor. This intramedullary tumor, as you can classically see, abuts the anterior horn cells, the dorsal root, the ventral root, and so the effects of these tumors by location will manifest clinically. So we have seen this is the extradural, this is the intradural, this is the intramedullary. So the extradural, you have local vertebral pain, tenderness with or without radicular pains. Then the mode of onset is usually symmetrical because it engulfs the spinal cord. The corticospinal tract is very early, and the myelopathy or the bladder involvement, which usually is a feature of intramedullary lesions. So late involvement of bladder and bowel. These are the characteristic features of extradural lesions. Then intradural, I told you the intradural by location is in the vicinity of dorsal roots. So when they are there at the level of dorsal roots, the radicular pain and paresthesias are very, very important feature of these lesions, intradural, extramedullary. The posterior column, I told you by location, they are situated just abutting the posterior column. The posterior column and just by the side of it, the pyramidal tract are involved early involved early. So you will get the spastic paresis with sensory disturbances in the lower limb, which ascends up. The spinal tenderness is not common because it is not involving the vertebral body or the spinal process, and the mode of onset is asymmetrical. It is not like extradural where the involvement is symmetry, and it's a slow growing tumors. You have seen neurofibroma, things like that, which are very slow growing tumors, and the duration of symptoms are there for long. The next is intramedullary. By location, they are away from the radicals. That's why the radicular pains are rare. But the funicular pain is characteristic feature of dull aching funicular pain is characteristic feature of intramedullary lesion. Trophic changes occur, and the lower motor neuron, because the anterior horn cells are affected there. Marked and widespread atrophy and fasciculations are seen. Dissociated anesthesia, because what happens here, it is the posterior columns are spared, and the spinothalamic and the pyramidal tract are involved, and that's why you get dissociated sensory loss. And autonomic involvement is very, very early. The trophic changes are common. The sacral sparing in the lower spinal cord is because the lamination is sacral fibers are outermost. They are more involved in the extradural compressions, whereas in intradural, it is the cervical that is more involved because of the lamination. Sacral sparing is the pathognomonic feature of the intramedullary lesion, and UMN is rare. And because of the involvement of the corticospinal, it can be less brisky and usually a late feature. So these are the things which we have already discussed. The UMN features are more common with extramedullary, late with intramedullary. The element signs are very widespreadly involved in intramedullary, predominant anterior horn cell involvement, whereas at the level of lesion for one or two segments, because of the root compression, it can be there in extramedullary. Root pains are a feature of extramedullary. Funicular pain is feature of intramedullary. Dissociated sensory loss more predominant in intramedullary. Sacral sensation is preserved in intramedullary, lost in extramedullary because of, I told you, the lamination pattern. The posterior columns are spared in the extramedullary, whereas they are early involved because of the this thing. And Lermit's sign is present in extramedullary, absent in intramedullary. Autonomic involvement is early in intramedullary. The non-compressive lesions are usually vascular, inflammatory, infectious, and metabolic. The list is long, and all of you are aware of it. Just for completion's sake, I had to go through this. And how do they produce? So what are the features of non-compressive myelopathy? Generally, the acute is very onset. I told you it's a devastating acute onset, and it evolves in acute or subacute pattern, and the involvement is symmetrical. It's not like the compressive myelopathy. It's symmetrical. The bladder and bowel are very late, and all the negative points which more indicate a compressive myelopathy: absent bony deformity, absent bony tenderness, no root pains, girdle sensation absent, hyperesthesia absent. So having come to know whether it's compressive myelopathy or the non-compressive myelopathy, we need to localize the lesion longitudinally, for which we need to make use of the dermatological level. Okay. And I told you already, this slide I have already told you, occiput C1 has no supply, C2 is occiput, the middle finger is C7, axilla is T3, umbilicus is T10, knee is L3, and the little toe is S1, perianal is S3, S4, S5. So starting from the above downwards, it's a longitudinal localization. We have got the uppermost involvement, that is the foramen magnum syndrome, where it is characteristically present the downbeat nystagmus. If downbeat nystagmus is there, cervical involvement is there, you can clinically conclude that we are dealing with a case of foramen magnum syndrome. The suboccipital pain because of the C2 involvement, Lermit's sign, bending, and the electric shock-like sensation. Lower cranial nerves, because you got, it's just abutting the lower medulla, So the lower cranial nerves can be involved. Then even the cerebellar fibers, they can get involved because of the proximity to the pathways. Now, this is the uppermost, the foramen magnum is the uppermost part where the cord begins. So cerebellar fibers can be involved, can produce cerebellar ataxia. And around the clock, progressive motor weakness, the much talked about Ellsberg phenomenon. The weakness of ipsilateral upper limb, ipsilateral lower limb, contralateral lower limb, and finally the contralateral upper limb. There's a clockwise involvement. It can start in any limb. The compressive lesions near the foramen magnum may produce weakness of ipsilateral shoulder, arm, followed by weakness of ipsilateral leg, and then the contralateral leg. Finally, contralateral arm, causing a around-the-clock pattern that may begin in any of the four limbs. It is the hype more than anything else. No clear explanation has been given for this. Venous stasis has been said, and the other happens to be the crossing of the pyramidal tract, the decussation of the pyramidal tract just at the lower end of the medulla or the upper cervical cord, and much talked about, but no clear pathogenesis has been given for this pattern of development. So high cervical cord lesion usually manifest by C2 involvement, spinal accessory nerve involvement, wasting of the small muscles of the hand, quadriparesis with phrenic nerve involvement causing diaphragmatic weakness, and I told you the fifth cranial nerve, the descending tract of trigeminal nerve, can get involved in the high cervical cord lesions with loss of sensation of the face and the corneal reflex being lost. Then the low cervical cord, it goes with the pattern of involvement. If C5, C6 are involved, deltoid supraspinatus, and there is a loss of reflexes in biceps. Then C7 involvement, usually the wrist extensors, triceps are involved. The radial nerve is involved here. The C8, the fingers and wrist flexion is impaired. And the Horner syndrome can occur in any lesion in the cervical cord, Then so thoracic cord is involved with a definitive sensory level in the trunk, and there is once the cervical cord is gone, once you come down, it's all about paraplegia and paraparesis. The beaver sign, the movement of the umbilicus when you try to lift up the legs or the head, indicating the upper or lower recti palsy, and the bladder involvement. These are all the features of thoracic cord. Again, the lumbar cord depends on which part of the cord is involved. If it's L2, L4, the flexion and adduction of the thigh, loss of patellar reflex, which we will discuss in the all these things in the cauda and conus. So what exactly is conus medullaris syndrome? I told you conus is abutting the L1 vertebrae. The lesion at vertebral level of T12 and L1 affects conus medullaris. It gives bilateral saddle anesthesia. Saddle anesthesia is also seen in the cauda equina, but here this is bilateral. The presentation is usually sudden, bilateral, and symmetrical. Please listen carefully, because asymmetry is the feature in the conus, cauda equina. Sudden, bilateral, and symmetrical. There is loss of anal reflexes. There is loss of ankle reflex, but knee jerk is preserved. There is loss of ankle reflex, but knee jerk is preserved. There is back pain, and there is no radicular pain, which is more characteristic of cauda equina. Urinary retention can be there, and an atonic anal sphincter, incontinence of feces, is the feature of conus medullaris. There is a preserved motor function in the lower limbs, and impotence is frequent feature of conus medullaris. The cauda equina syndrome usually begins at L2 or below disc space, distal to conus. There is asymmetric involvement. The symmetry is feature of conus medullaris. Asymmetry is feature of cauda equina. Asymmetric areflexic paraplegia is a characteristic feature of cauda equina. Knee and ankle jerks both are absent here, whereas the knee is preserved in the conus medullaris. Severe radicular pain is characteristic feature of cauda equina. Radicular asymmetric sensory loss, saddle anesthesia, but again this is unilateral, whereas bilateral saddle anesthesia is feature of conus medullaris. The loss of bladder and bowel function. Urinary retention is very early feature of conus medullaris. It's late in the cauda equina syndrome. Cauda equina, usually it is due to acute disc herniation or an epidural hematoma or a tumor. These are the causes of cauda equina. So this is what I have already discussed, a tabular column of conus and cauda. So we have already gone through this. Having come to the vertical localization of the lesion, now we have to go for the etiological diagnosis, and usually that depends on the transverse cord localization. Transverse cord localization. The spinal cord syndromes are classified as complete and incomplete. Classified as complete and incomplete. The complete cord syndromes are usually caused by transverse myelitis, post-vaccinal syndrome, including the COVID vaccine. We have seen 2 or 3 cases of post-COVID vaccine cord involvements, trauma, the automobile accidents, then metastatic carcinoma, multiple sclerosis, autoimmune disorders, and the spinal epidural hematoma. These are the causes for complete cord syndromes. Usually what happens, there's a transection at one level of the cord. All the ascending tracts from below and descending tracts from above are interrupted. And so all modalities are involved, the motor, sensory, and the autonomic function is involved. All modalities of sensation are involved below the level of lesion. The sensory level is 2 segments below the level of lesion, and the segmental paresthesia occurs at the level of lesion. These are important. The sensory level is not at the level of lesion. It is 2 segments because the spinothalamic tract takes 2 segments to cross the spinal cord to the opposite side. So that is why the sensory level is spared for 2 segments below the level of lesion, and only segmental paresthesia occurs at the level of lesion. Very important point, usually asked in postgraduate examinations. The motor, the corticospinal tract involvements, the hypertonic, hyperreflexive paraplegia due to corticospinal, loss of abdominal reflexes and cremastic reflex, and usually the element signs are there at the level of lesion. There is catastrophic involvement of autonomic nervous system, urinary retention, absolute constipation, anhidrosis, trophic changes, vasomotor instability, and sexual dysfunction. These are all the features of spinal cord transection. That is complete cord transection. Then you have got incomplete cord syndromes. Postgraduates should be very well versed of these syndromes. It is here where you're caught in the crossfire if you're presenting very well during the examinations, because if you're doing well, you're expected to answer these: the Brown-Sequard syndrome, the central cord syndrome, the anterior cord syndrome, the posterior cord syndrome, the anterior horn cell syndrome, the anterior horn cell and pyramidal tract syndromes. So all of you know, Brown-Sequard syndrome is a hemisection of the spinal cord. It is caused by extramedullary lesions, usually caused by a penetrating tumor or a trauma. As this picture depicts, there is loss of movement on the same side of the cord because of the involvement of the ipsilateral corticospinal tract, because the crossing takes place at the upper part of the cervical cord. Whereas on the opposite side, there is loss of pain, temperature, and sensation because of the crossed spinothalamic tract. So this is very simple to remember, the hemisection of the cord. So as I've already told you, ipsilateral proprioception loss and contralateral pain and temperature, and ipsilateral pyramidal tract involvement, and with element signs at the level of lesion. That is what is Brown-Sequard syndrome. The central cord syndrome affects usually central part of the cord. The peripheral, the white matter is usually spared. So what happens when central part of the cord is, what is there in central part? See, you have got the spinothalamic fibers. They are traversing along through the dorsal root and then enter the gray matter and cross to the opposite side, on both sides. So there is a crossing over in the middle of the spinothalamic tract. So this crossing over is affected in the lesion of the central part of the cord. So that is why you get a shawl-like distribution of pain and temperature loss, usually in the upper part of the chest, involving the shoulders. So this is a characteristic of central cord syndrome. So if you know the anatomy, you can easily explain the lesion in the examination. So the fibers which cross to the opposite side, they occupy central in position the spinothalamic tract, and that is what is involved. That is what is involved in central cord syndrome. So the pain and temperature are affected. Touch and proprioception, because the touch and proprioception are outside. They are not involved, and that is why you get the posterior columns are spared. So you get the dissociated anesthesia. You get a shawl-like distribution of sensory loss. The upper limb weakness is more than the lower limb weakness. So the commonest cause happens to be syringomyelia, but hyperextension injuries in automobile road traffic accidents, hyperextension injuries of the neck, the intramedullary tumors, trauma, and the associated Arnold-Chiari type 1, type 2 dandy walker malformations can all precipitate a central cord, but syringomyelia happens to be the most common cause. Then you have got the posterior cord. The commonest cause happens to be the diabetes and the neurosyphilis. Usually the chronic diseases takes almost 10 to 20 years after the disease onset. There is impairment of the position and vibration sense as the posterior part of the cord is involved. There is sensory ataxia, positive Romberg sign, positive Singh sign, positive Lermite sign, all indicating a posterior column involvement. Then you have got a commonly asked old examiner's favorite sign, the Abadie's sign, which is involved typically in tabes dorsalis. That again indicates absence of pain and compression of Achilles tendon. Okay, that is a sensory involvement in posterior cord syndrome due to tabes dorsalis. Urinary incontinence can be there. Charcot's joints, because the supply to the joint sense is lost. Then you got the characteristic AR people, Agile Robertson people in tabes dorsalis. Of course, these are rare things happening nowadays. But as a postgraduate, you need to know this. Then the other segment of incomplete cord involvement happens to be the posterior lateral column disease, where the posterior columns and the pyramidal tract are involved. You've got paresthesias, you've got sensory ataxias, you've got Romberg sign, you've got bladder atony, plus the corticospinal tract involvement. So the causes happen to be vitamin B12 deficiencies, acquired immunodeficiency syndrome, HTLV associated myelopathy, and cervical spondylosis. So these are the common causes where the posterior columns, you know about this SACD, subacute combined degeneration, where the posterior columns and the pyramidal tract are involved, and B12 deficiency is the crux of the problem there. Then you have got the anterior cord syndrome, where the anterior part of the spinal cord is involved. It can be due to acute disc herniation and more due to ischemia from the anterior spinal artery. It is usually due to hyperflexion injuries, something falling on the back of the head and causing acute hyperflexion, and usually the anterior spinal artery area is affected. So sudden onset of paraplegia below the level of lesion, the pain and temperature are lost, but the dorsal column is preserved because it's the anterior cord, the anterior 2/3 of the cord that is involved. The posterior columns are spared here, and that's why the dissociated sensory loss, and the prognosis is quite poor. See, this is a very common question asked in the examination, the anterior spinal artery syndrome. You know, anterior spinal artery is formed by a branch from the vertebral artery, which is again originating from the subclavian artery. The vertebral artery, before it goes forward to meet the other vertebral artery and form basilar artery, it gives out a branch. These two branches meet and form the anterior spinal artery. Okay, this supplies the anterior 2/3 or the major part of the spinal cord. The posterior spinal artery is a branch of posterior inferior cerebellar artery, pica. Okay, that supplies the posterior portion of the spinal cord. Posterior portion of anatomy is very, very important. Neuroanatomy is very, very important for postgraduates. They need to be abreast with the revise all the anatomical modalities of blood supplies, the pathways, until which you will not understand the critical aspects of myelopathy. Then the anterior spinal artery syndrome, also called as Beck syndrome. This is one of the commonest causes of vascular syndrome. Usually the aortic dissection, the atherosclerosis of aorta. In fact, one of the cricketers, Mr. Chris Keynes, he was a top cricketer in New Zealand. He suffered, he's a young fellow, he suffered aortic dissection with involvement of anterior spinal artery, and he became paraplegic, struggling to life on a ventilator. And these are unfortunate situations where aortic dissection, atherosclerosis, and also the SLE, AV malformations, and AIDS can all affect the anterior spinal artery. And usually the spinal cord is affected between T1 to T4 and at level of L1. Sudden onset of neck pain is one of the common features, which usually takes us to a cardiologist, and he takes an ECG, rules out MI, but very important time is lost in trying to miss the diagnosis of anterior spinal artery syndrome. Treatment has to be initiated urgently. Okay, so I told you there is involvement of the spinothalamic tract and sparing of the posterior columns and involvement of the bladder. Posterior spinal artery, being a branch of pica, is very uncommon in occurrence. Okay, it involves the posterior columns, which we have discussed earlier. The anterior horn cell syndromes, very important things as far as postgraduate discussion is concerned. The spinal muscular atrophy, which involves the anterior horn cells, also called as the Werding-Hoffmann syndrome, Kugelberg-Wielander, anterior horn cell disease, or the spinal muscular atrophy. It's a degenerative disease of the anterior horn cells. There are different types, and it's beyond the time limits of this discussion. Okay, what exactly happens? See, anterior horn cells, once they are involved, it's the starting point of lower motor neuron, and all the classical features of LMN, weakness, atrophy, fasciculations, hypotonia, depressed reflexes, but it's a pure motor involvement where the sensory system is spared. The anterior horn cell, along with pyramidal tract, can involve. This is a very important topic of discussion again for postgraduate. I keep telling everything is important. I don't know what is not important. This is also the other term being amyotrophic lateral sclerosis or Lou Gehrig disease. It's a motor neuron disease due to the degeneration of upper and lower motor neuron, and both UMN and LMN signs are there. The anterior horn cells are involved, the corticospinal tracts are involved. So it's a mixture of both LMN and UMN involvement. The reflexes are exaggerated at one end, the sensory system is not involved. The abdominal reflexes, even though the corticospinal tract is involved, are preserved here. So at one end you have got upper motor neuron type features, at the other end you have got lower motor neuron type of features, and the sensory system is not spared and abdominal reflexes are preserved. So the other important thing which interests us happens to be the acute presentation of myelopathy. Usually the demyelinating disorders like multiple sclerosis, neuromyelitis optica, spinal cord infarction, para-infectious myelitis, and systemic inflammatory disorders like Sjogren's syndrome and lupus. These are all, and the other neuroborreliosis is another very important cause of myelopathy, which we generally do not investigate as a some features which involve an infectious etiology for myelopathy, fever and rash are characteristic pointers towards herpes zoster, enterovirus, the Lyme's disease. Meningism can be part of a recent travel to endemic regions with the tuberculosis, parasitic infections like schistosomiasis, which we generally do not consider in myelopathic disorders, but as rare diseases are coming to us, we need to keep this option as a differential diagnosis. Then the recent history of dog bite and rabies exposure. Immunosuppression usually predisposes individuals with herpes zoster and cytomegalovirus myelopathies. So myelopathies can also be involved in nutritional deficiency. It could be due to B12 deficiency, which can cause a subacute combined degeneration. Copper is a very, very important trace element, deficiency of which can lead to lower limb paresthesias, gait difficulties, and the sensory ataxias. So the characteristic feature happens to be low serum ceruloplasmin, low serum copper levels, and urinary excretion of copper is very important, low urinary excretion. These are to be measured for establishing the diagnosis of copper deficiency. Vitamin E is very important factor for so many myopathies, and folate deficiency can also cause myelopathy. So why we discussed myelopathy in such detail happens to be time is the essence, because if you take too long a time, the recovery becomes slower, and the chances of complete recovery fade, especially after 6 months. The debility persists. There are no effective means to promote the repair of injured spinal cord tissue as of now. A lot of R&D is going on. A lot of claims are made, but to date now, nothing is proven. One point of interest with long bedridden patients with the spinal cord disease in our wards, they tend to have fever, unrelenting fever, which forces us to go on using the high-end antibiotics. Just a point for you, the loss of normal thermoregulation and inability to maintain normal body temperature can produce recurrent fever in a quadriplegic fever, and it is not an infective fever. So, but the fever is usually due to infections in urinary tract or lungs because of the stasis lung infections, skin or bone. If you can exclude these things, please remember there is a non-infectious entity called as quadriplegic fever, which can produce fever and which usually misleads us into using high-end antibiotics and burden to the patient. Thank you for your patient hearing, and I hope I have not I have lived up to the expectations my scientific people have given us. Thank you so much.
Thank you, sir, Dr. Sudhakar Garu, for a very detailed lecture on the myelopathies. Very, very useful for most of the postgraduates, and even for let me be frank, people who are already teachers. Even for us, it's useful, sir. Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you.
And
sir, now,
thank you for giving me this opportunity, sir. Thank you.
Sir, you're welcome, sir. Thank you, sir. Now for the post-lunch session, we've got 10 minutes left. Sir, with the permission of the Dr. Allad Mohan sir, Dr. Sudha Vidyasagar, and Dr. Ravi Garu, who are the panel experts in the next panel discussion. Sir, can we have 10 minutes? Can we be late by 10 minutes?
Yeah, if Professor Sudha and Professor Ravi are okay, I'm good, because they speak before me.
Yes, yes, sir. Yes, sir.
Dr. Sudha, you are muted.
Good afternoon, sir.
Ravi sir, they wanted a 10-minute break.
No problem, sir. Good afternoon, everyone. Good afternoon, sir. No problem from my side.
Wonderful. What, Dr. Sudha?
No, if everyone is
1
okay,
minute
I
break.
think we can meet after 2:15. Okay.
Okay, sir. Thank you,
This
sir.
is Dr. Ramurthy going to be the moderator for you.
Thank you, sir. Dr. Ramurthy, you have done my job very simple. So we'll meet at 2:15.
Okay, we'll be joining at 2:15. Thank you, Dr.
Thank you, sir.
Subramanian. Bye.
Right. Thank you, sir. For lunch. Yes.
Madam.
మోహన్ గారు నమస్కారం. అమలాపురం డాక్టర్ శర్మ సార్.
సార్.
అదే నేను ఐ హ్యాడ్ ది ప్రివిలేజ్ ఆఫ్ మీటింగ్ యూ అట్ తిరుపతి సమ్ టైమ్ బ్యాక్. ఐఎంఏ కాన్ఫరెన్స్ లో తమని కలవడం జరిగింది సార్. అంతకుముందు కాకినాడలో ఏపీఐ కూడా స్టేట్ చాప్టర్ అయినప్పుడు నేను ఒక పోస్టర్ ప్రజెంట్ చేసి మిమ్మల్ని తీసుకొని చూపించాను ఆ పోస్టర్ మీకు. అది సో మీన్ ఆల్వేస్ లవ్ టు హియర్ యూ, లవ్ టు లిసన్ టు యూ, అండ్ యు ఆర్ ఎ రోల్ మోడల్ ఫర్ ఆల్ ఆఫ్ అస్. And we are very happy that you are here with us, sir. Morning వచ్చారు, మళ్ళీ ఇప్పుడు వచ్చారు.
So kind of you, sir, to give me opportunity.
Well, thank you very much, sir. మీకు నమస్కారం చెప్తామని మళ్ళీ మీకు ఉపయోగించాలి. Thank you, sir.
ఎవరు అడగండి, పిక్చర్ ఇస్తున్నా మళ్ళీ మాట్లాడతాను. హలో అమ్మా, గుడ్ ఆఫ్టర్నూన్. చెప్పండి అమ్మా. నువ్వు సుధా విల్ టెల్ ఫస్ట్. ఆ సీక్వెన్స్ అట్లా రాకపోతే బాగోదు. అంటే వాళ్ళది
You want me to speak? Hello?
Still hi to everyone, ma'am. Madam, done, madam. So now, video, can you check the video?
Yes, I will. Fine.
Yeah, now we are audible, ma'am.
Okay, now I'm on. Thank you. Okay.
Ma'am, now relax for 2 minutes, ma'am.
Yeah. So you want me to start?
Log out ಮಾಡಿ madam.
Huh?
Any desk ನಿಂದ log out ಮಾಡಿ.
ಯಾವ್ದರಿಂದ?
Any desk ನಿಂದ. Yes, sir.
I'm not done anything.
Done.
Okay.
Now we are starting.
Okay, 1 minute. I just close the door and take.
Ma'am, Subbarao sir is podcast.
I'm not hearing anybody.
Madam Sudha Vidyasagar, are you ready for the first talk? This
Yeah,
is
yeah.
Dr.
Yeah, I can talk.
Okay. No. Somebody was telling that you have a technical issue.
Yes. Now it's called, I can talk.
Thank you very much for being online on time. I'm Dr. Ramurthy, sir. I think Dr. Subbarao is going to start speaking at 2:15. Is it so, sir?
Now for the post-lunch session on day 1, we have got 2 meet the expert sessions lined up for you. The first one will be controversies in COVID-19. It will be moderated by Dr. K. Ramurthy Garu, is a senior consultant physician from Medicover Hospital, Visakhapatnam. He will be the moderator for this session. I invite Dr. Ramurthy Garu to be the moderator for this session. As experts, we have Dr. Sudha Vidyasagar, Dr. K. Ravi, and Dr. Alladi Mohan Garu. Now about the moderator, he is the chief consultant physician for Medicover Hospital, Visakhapatnam. He and MD General Medicine from Andhra Medical Visakhapatnam. He's a trained echocardiologist and consultant sonologist. Has been a consultant physician at Vizag since a long time. Currently, he's the Vice President of API Visakhapatnam chapter, and he's got a 36 years of clinical practice consultant physician at Vizag. He's a past secretary of API, IMA, and ex-civil consultant to EAC Hospital Medicine. Sir, Dr. Ramurthy, sir, please conduct the meet the experts panel, sir. Thank you, sir.
Thank you, Dr. Subbarao Garu. I think I'm audible. Hope I am audible, sir.
Yes, sir. You're fine, sir. Fine.
Thank you, Dr. Subbarao Garu, for introducing me. Now we are. Good afternoon, everyone. We are in the post-lunch session. I'm sure it's a very difficult task for the speakers to keep us alert and awake after this 15 or 20 minutes of break. And we are going to have 3 topics under this. One is COVID vaccines and unanswered questions by Dr. Sudha Vidyasagar. And the second one is anticoagulants and antiplatelet therapy during and after COVID infection. And third one is going to be post-COVID complications. We are going to listen from 3 experts. This being a meet the expert session on a panel discussion. Each talk will have 15 minutes of time. After 45 minutes, we are going to have 15 minutes of our question and answer session. And as you all know, the COVID vaccine, first topic is the COVID vaccine unanswered questions by Dr. Sudha Vidyasagar, MD. And I'm sure you all know that the COVID vaccine human being developed in no time, practically in no time. It took about less than 1 year after the publication of virus genome. And the fastest developed human vaccine, are you able to listen to me again?
Yes, sir. You are.
Okay. And this vaccination is being done all throughout the world. Almost 30% of the world population has been vaccinated, and 50% of USA, United States of vaccination has been done. Only 12 to 13% completed in India. There are so many doubts and questions as far as the vaccine is concerned about their efficacy, safety, and dosing. We are going to have clear-cut answers from an expert. Sudha Vidyasagar, a few words about her biodata. She is the professor of medicine, Kasturba Medical College, Manipal. She did MBBS from Stanley Medical College from KMC Manipal. Good Teacher Award in KMC 7 times. And research papers published 152. Professor N. Srivastava Award in RSSDA in 2013. ICMR grant for young diabetes since 2010. Chair in pre-diabetes, Manipal University 2014 to 2015. Principal investigator in 15 international clinical trials. With this, I request Dr. Sudha Vidyasagar to answer those unanswered questions of COVID vaccine doubts. Over to Madam.
Thank you, sir, for your very kind introduction. Am I audible?
You are audible, Madam.
Are my slides shared, please?
Yes, please share.
No, is it shared?
No, we are
Oh,
not
ma'am,
seeing
no.
the slides.
Oh, okay. So I'll just share my slide. 1 minute. Okay, now it is shared.
Yes.
Full screen, ma'am.
Full screen, that thing is obstructing. What is the keyboard thing for full screen?
Yes.
1 minute. I'll see. Okay.
You can use the button on the top right.
No, now it is full screen.
No, it is
Yes,
okay,
ma'am.
madam.
Yes, ma'am.
Oh,
it's
Perfect.
okay, madam.
Yeah, okay. As the Honorable Chairperson was telling, there are so many questions in COVID vaccination which are unanswered. I want to thank the scientific committee for giving me this talk because it made me read a lot of things, and the more controversy, I found that it generates more and more controversy. So I'll try to go through the following questions. Do the vaccines work? What is the balance between natural and vaccine-induced immunity, which is better? Do all vaccines have the same efficacy? Do all of them work against all variants? What is the ideal dose gap? Is mixing of vaccines acceptable? Should antibodies be tested before giving vaccination? Do we need boosters? And finally, vaccine concerns, how real are these? These are the questions I've asked myself while preparing this talk, and I hope it will be relevant to the audience listening to us. So just going through the landscape of vaccines, this we all know. We have the RNA vaccines, Pfizer and Moderna, the viral vector vaccines, in which we have the Oxford AstraZeneca Covishield vaccine. We have the protein subunit, which is Novavax, and the whole virus, which is our Bharat Biotech, which is our Covaxin. And we all know that the advantage of mRNA vaccines is the shorter time you need for manufacturing these things, and definitely no chance of getting an infection from them because they are not the viruses at all, and the ability to trigger both humoral and cellular responses. And what we have, the Covishield is an adenovirus vector carrying the genes that code for the spike protein. Again, non-replicating, no harm. And inactivated vaccines, the whole virus, that is Covaxin, which is also available in India, and they all trigger sufficient immune system responses to produce antibodies. No danger again because they're not replicating. Few more vaccines are coming, that is the subunit, protein subunit vaccines, the plasmid DNA vaccine, and the intranasal vaccine from Bharat Biotech. So let's start with the easiest question first. Do they work? Do these vaccines work? Now, this is probably the easiest question because if you look at this very dramatic picture of the rollout from UK, you can see what happened in the second wave, the number of cases in the population and the number of deaths. This is during the second wave. And then you come to the third wave. Between the second wave and the third wave, we managed to vaccinate about 50 to 60% of the population. And you can see the death rate drastically come down. The cases were there, but the death rate came down. So we know that definitely the vaccines are effective against severe illness, hospitalization, and death. There is no doubt about that. Most of us, even I got COVID, I think most of us who got COVID survived only because we were vaccinated. There is no doubt about that. And this is across all vaccines. For example, the Pfizer vaccine, all of them efficacy is around 90-95% like that. And most of them are definitely effective against severe COVID disease. The Moderna, again, mostly 90%. So there is nothing much to choose between the vaccines. The AstraZeneca, again, though it is not as highly rated as the Moderna or the Pfizer, definitely if you increase the dose interval, then definitely it is effective up to 81% in preventing infection. Now, after this also, we find that there are many studies that have come out, and this is a real world study in UK, came out on September 1st, and it compared the vaccination compared with no vaccination was definitely associated with reduced odds of hospitalization, and the number of symptoms that the patient had also came down, especially with the second dose, and almost all symptoms were reported less frequently in vaccinated individuals. So definitely hospitalization was less, number of symptoms that people got was less, also reduces the severity and duration of the long COVID syndrome. This is from Lancet Infectious Disease, and this came out the most recent one in September. So definitely helpful in not only preventing hospitalization and death, but preventing symptoms and preventing the long COVID syndrome, about which I think Dr. Alladi Mohan will talk to you later. Now, that's the easiest question. Now, let's go on to the tougher ones. Natural versus vaccine-induced immunity, which is better? Now, we know that in the natural immunity, we have different types of antibodies coming in. The IgM will always come first in the first 7 days and peak around 20. The IgG comes a little later, peaks around 25. And we know that older age, more severe infection, symptomatic infection, always is associated with higher antibody levels. So yes, natural immunity does give us antibody levels. But let's look at natural versus vaccine, which is better. Now, when we compare that, we find that the vaccine gives a more homogeneous response. And in the natural immunity, the duration of the natural immunity varies compared to vaccination. You can't predict it. In fact, some infections do not produce any immunity at all when you go natural. And of course, you have the big problem that you may have serious morbidity or mortality, which is the biggest downside of trusting the natural infection to give us immunity. Vaccines are predictable immunity, more diverse repertoire of memory cells, B cells, and duration of immunity is more than the natural infection. And because you can give this to a sufficient number in the population, ultimately you may get better herd immunity with vaccination. So this is another easy question. So I'm beginning with the easier ones, going on to the tougher ones. And the rationale for giving a booster dose of a vaccination, even after COVID-19 infection, many people say, why should I take vaccine? Because I already got COVID. That is because vaccine provides broader antibody protection against new variants, and it may persist for a longer time than natural ones. And in fact, if you have a COVID infection and then you give a vaccine, you may have more antibodies. It may be like a booster dose. So it's always good. Now, when we began this pandemic, I remember on TV, we saw a lot of people talking about how we can get herd immunity by natural infection, and then we don't have to vaccinate, etc. But now this theory has been disproved. There's an unclear timeline. We don't know how much of the population needs to get infected, and will natural infections achieve it? We don't know. And the price we pay. The second wave was disastrous for all of us. So much morbidity and mortality. I think almost every family lost somebody in the second wave. So definitely natural infections are not a way of achieving herd immunity. So this is the second easy question. Probably vaccine is better than natural immunity. Now let's get on to the tougher ones. Why do vaccines fail? Though we say so much good things about vaccines, why do they fail? What is their efficacy? Is it going down? And what about the variants? We all know that WHO has identified variants of interest and variants of concern. And we know that variants of interest are identified by the genetic markers and the outbreak clusters, whereas these are ones which cause increased transmissibility and severe disease. Now, if you look at the variants alpha, beta, gamma, delta, and the and the number is growing every day. The tribe is growing, and all these are identified in different parts of India, I mean, in the world. And we know the Delta has created havoc for us in India. Now, let's look at each country when we got the variants. The P1 variant, which happened in Brazil, what happened was people started getting the waning out of the antibodies, and P1 probably evades antibodies, came in quicker than expected, more transmissible, more mutations, and so a lot of hospitalizations happened. Though Brazil did not have a very good vaccine history, even the natural thing finished them off. And the Delta plus variant that we all have been dealing with, the Delta variant, it has got more propensity to involve the lung, and so more ARDS, increased transmissibility, and maybe it wouldn't respond to monoclonal antibodies also, which is becoming very popular in the cities now. And we know that over a period of time, the fast spreading Delta variant, the vaccine's efficacy wanes. So it comes down with time. So this is another problem. The biggest blow came from Israel, because Israel was the first country which went and vaccinated so much of its population that they had excess Pfizer vaccine. They did not know what to do, where to send it, etc. And then they found that the Pfizer vaccine, which was actually 95% efficacious, came down to 39% over a period of 4 or 5 months. So what happened here was it came down after that and then went up in April when the Delta variant was identified. So much so that Pfizer got a bad name, saying that probably doesn't work against the Delta variant. So now we have more and more variants. We recently identified the new variant, B1621, identified in Colombia, and then it's again having so much mutation and so much property to escape the vaccines. Then we have the C12, which came from South Africa very recently, I think last week or so. In the last 2 weeks, it was identified. So that brings us to the question, maybe we are not delivering the vaccine correctly. Maybe we should go through the nose, because through the nose only the COVID-19 comes. And so are nasal vaccines better? Unanswered question. Nobody knows, and we don't have much data on this. And similarly with the DNA vaccines, which are coming up again, and which is similar to the RNA vaccine, you can produce big, low cost, large scale production, and it's similar to the RNA. And our Zydus is also coming out with Zycovid, which is the first plasmid DNA vaccine. And in India, the Cadila Healthcare is doing it. And they said it prevents 66% reduction in the people who are vaccinated, done through a jet injector. Again, not sure whether this will work or not. So that leaves us with the question, efficacy. Is it because it's waning over time, or is it because we got new variants which are not susceptible to this particular vaccine? The next question, what is the ideal dose gap between the vaccinations? Now, when in the last study of 150,000 patients, they found that there were positives again, 845 people again became positive. And initially it was told that probably we should limit this, increasing the dose interval to resource limited populations. So even when the government of India said, okay, we should increase the COVID duration, everybody said the government of India is trying to save money, and that is why they are doing this. But actually, so that's why initially Covishield was, I took Covishield at 1 month, whereas now they say 84 days. So this came in, and it was thought to be more of a economic, socio-economic move rather than science. But it is not right. It is a scientific move, because we know that a longer delay for the second dose of the Covishield leads to an increased antibody titer after the second dose. So this is again published material, and antibody titers were higher when you gave a longer duration. So the government of India was not trying to save money. The government of India went with science. So the dose duration, the dose interval has been changing based upon the data that we got, and not just socioeconomic conditions. Next question, can vaccines be mixed? So there are studies which show that, if you mix up two vaccines, like you mix up the Pfizer and the AstraZeneca vaccine, you found that actually there was a higher dose of antibodies which are present, and that is why This was published in the Lancet again, and that is why the ICMR said it actually elicits better immunity. So I have not found this study there, but it is published in other journals that it can be mixed and maybe it is useful. Again, data is not very perfect, but probably pointing to that direction. The next question, should antibodies be tested before vaccination? Now, here it's a problem of measurement. Logically, right. Okay, why don't we test antibodies, then give those who have antibodies, we need not give, etc., etc. Your measuring scales are not accurate. What are we going to measure? Humoral or cellular immunity, spike protein or nucleocapsid, IgM, IgG or IgA? Which are we going to measure for us to take as the antibodies? Because we know that each one peaks at a different time. The IgA antibody comes here, whereas the IgG comes later. And so we don't know what to measure, and that is where the confusion comes of what we do. We definitely know vaccine efficacy is less in these populations, older age, higher body mass index, immunosuppressed treatments, cancer, end-stage dialysis, etc., variants of concern, etc. So in these people, maybe it may be worth it. So there is a recommendation which says do before ideal. In the ideal world, you would probably do before vaccination, 1 month after vaccination, and 6 months after vaccination. This is for efficacy, this is for waning. But this is again an ideal world and not the real world. So here it doesn't matter. Are boosters justified? Now, when we look at the breakthrough infections, on May 1st, the CDC said so many breakthrough infections and hospitalizations did occur and leading to death also. So how long will immunity last? Humoral immunity, probably 3 months. Cellular, 8 to 9. Vaccine versus natural versus vaccine, definitely vaccine is better, more homogeneous. COVID plus 1 dose of vaccine is actually very good. Reinfection possible, but mild. Transmission is always possible. It's a very good article from the BMJ. I would encourage postgraduates to read it. How long does COVID immunity last? So these are the answers that are given in this article, and probably these are right. And we know that after COVID, if you take a vaccine, then definitely you get much more antibodies than without. So that's the this thing. But let's look at what happened. Why are people talking of the boosters? Israel, immunity fell. India also, it may fall. We don't know. And some of us who took Covishield much earlier, we all got COVID again. So there may be a third dose that may be required 10 months after receiving the second shot of Covishield and 6 months after the second Covaxin dose. The Indian government is mulling over it, but has not come out with any data. And this may be regarding the third booster may come out in November this year from the Covaxin Bharat Biotech desk. So definitely some people need boosters. These are the ones who are immunosuppressed as is given here. And these people probably should consider reduction in immunosuppression around the vaccine schedule so that the vaccine works and you get the antibodies right. And the CDC, yes, went with this recommendation on August 20th and said that you should probably give a booster to the severe immunocompromised people. And Israel said everybody over 60 gets a third booster, and France and Germany have also advised. The Indian government has not yet advised regarding the normal people. And what is the argument against the booster? The data is not very clear. It's a real world situation that we are dealing with. And many people think it is because of the fear of the Delta variant, and the intensity of this fear is unfounded. This is again from the Lancet, and they said that there is no real evidence. This came out on August 12th. When I read for this talk, I found that every day there was new data coming up. I was myself getting confused what to say and what not to say. Today's truth is today's truth. Yesterday's truth is not disproved today. It's that fast the data is coming out. Argument against boosters are most reinfections are causing milder disease. Is it worth giving a booster? How will it benefit? Who will benefit? Because we don't know the antibodies. We can't predict them. Do these levels correlate with infection? Even if you get the antibodies, do you think they will translate into less infection? Not sure. Why waste a dose? When people are struggling to get 1 dose, why are we giving third dose? I'm sure everybody will rush for it if the gate opens for a booster. Then that brings us to the question, do we need a yearly vaccine? Because this virus is going to keep on mutating. We don't know whether we probably need a yearly vaccine like the H1N1. So that's again another question that is unanswered. The last part, vaccine concerns. How real are these? Initially, everybody was concerned about pregnancy, but the MOH circular said pregnant women can take. Initially, everybody is worried about adolescents. Again, adolescents, Pfizer vaccine approved. What really put us, stopped us on the tracks and stopped many people from getting vaccine was this vaccine-induced thrombotic thrombocytopenia, or VIT, which came out in probably June in the NEGM, and they said it came out with the AstraZeneca, lesser extent with other vaccines, and similar to the HIT, where you get platelet factor 4 of antibodies. And AstraZeneca, this is the number of cases. For 34 million, we got 169 cases of CVT, 53 cases flank vein thrombosis. This is a J&J vaccine which also reported this. So this was a concern. They said more with adenoviral viruses, not much with mRNA, more with young women, and all these sites got thrombosis and people got low platelets. So when this was published again in the NEGM, thrombosis and thrombocytopenia, 5 cases, 3 of them was fatal. And this was again in healthcare workers. So it was a problem that high levels of antibodies were seen. The patients were healthcare workers, and 7 to 10 days after vaccination, and it was fatal in 3 people. So they did declare, because of the large denominator that they had, that this was a rare thing. But for these 5 people, it was a disastrous thing. So there is an adapted VITT adapted 4T scoring system like we have for the HIT, which takes into account the thrombocytopenia, the timing, the thrombosis, and ruling out other causes. And there is a grading which has come out in UpToDate and saying that this is how you can predict the clinical probabilities of having a VITT. But there are other articles which question the definition of VITT and saying that maybe we are missing out a lot of people, so we are not getting a big numerator because our criteria for diagnosis are not yet clear. The question is, are these side effects demographically different? For example, myocarditis, more common in mRNA vaccines. So that's a problem. We don't know whether it is like that, and it's more in young adults. And neurological, we had a patient with GBS. I felt very sorry for a healthcare worker, ASHA worker, who got GBS after a vaccine, and she was paralyzed. She was on the ventilator, but she recovered, but it was bad. I had a doctor who developed autoimmune encephalitis and suffered for nearly 3 months, recovered with steroid. Luckily, a month ago, he came back walking to me. So we do get myelitis, ADM, seizures, all these stroke, facial palsy, so many things, neurological effects have been there. The numbers may be small, but for the person to whom it happens, it's a big thing. The next question was, does more immunity cause more VITT? No, that is not there. So that at least that we don't have to worry about, but concerns remaining regarding VIT remain. So let's go back to the questions. Do they work well? Vaccines? Yes. Natural versus vaccine wins. Do all vaccines have the same efficacy? Probably yes. Do all of them work against all variants? Not sure. What is the ideal dose gap? Based on data, each vaccine is different. Is mixing of vaccines acceptable? Yes. Should antibodies be tested? No, not reliable. Do we need boosters? Yes, in some. We don't know whether this will be expanded. Vaccines concern real but rare. So finally, will we achieve a virus that cannot transmit and infect others and has no chance to mutate? Not sure. So this is our ideal. Should not transmit, should not infect, should not have a chance to mutate. But I'm leaving you with more questions than answers. Thank you.
Sir, unmute, sir. I think you have to unmute. Sir, unmute.
Really great presentation, Madam Sudhar Sagar. Very short, sweet, to the point, and focused. Thank you very much. Still, we have many doubts. We are going to address them in the end.
Sure.
The next topic for the panel discussion today is anticoagulants and antiplatelets. Are you able to listen to me?
Yes, sir. Yes, sir.
Antiplatelets during and after COVID. We all know that lungs are affected majorly by the disease COVID, and it's much of the mortality and morbidity because of the lungs. But we also know that 30 to 40% of the people who suffer COVID, they do have thrombotic states and hypercoagulable states. And using anticoagulants really showed that favorable outcomes in all these individuals. So to address this, what we are going to do with anticoagulants and antiplatelets, we have Dr. Ravi. who is going to talk on this. Dr. Ravi, MD, FICP, presently Professor and HOD Department of General Medicine, Bangalore Medical College, Ethical Committee Member, Bangalore Medical College, ESI Medical College, MBGM Medical College, Nodal Officer, Program Director, ART Center, Bowring and Lady Curzon Hospital, where he worked in various capacities. Past Secretary, APA Karnataka Chapter, published papers both national and international journals, delivered lectures in the state as well as national conferences, member of Technical Advisory and Therapeutic Committee for COVID-19 Government of Kerala. I present Dr. Ravi. Ravi sir, go ahead.
Yes, sir. Good afternoon, everyone. Thank you, sir. Thank you for that kind introduction. First of all, thank the organizers for having. Am I audible, sir?
You're audible, sir.
Thanks the organizers for having given me an opportunity to speak on this anticoagulation and antiplatelets during and post COVID-19. As you all are aware, there is rising incidence of this thromboembolism secondary to COVID-19 has been a global concern with increase in the mortality rates. This thrombogenic potential of this SARS-CoV-2 has been attributed to the exaggerated inflammatory response, leading to endothelial dysfunction. This thromboinflammation is termed as CAHA, called as the COVID-19 associated hemostatic abnormality. So usage of this anticoagulants in COVID-19 remains an area of controversy with no definite guidelines published till date. So just a brief introduction of the incidence of this. If you can see over here, the incidence varies from as low as 20% to as low as from predicted up to 50% of patients at higher risk of developing DVT. A French study published about almost 16.7%, and a Dutch reported an incidence of venous thromboembolism of 27% despite the prophylaxis. So thromboembolism is one of the major cerebrovascular hazards that occurs in these patients, which is 20% high than, which is 20% of the critically ill patient, which is 3 to 4% higher than the critical viral pneumonias that we usually treat in these patients. So the mortality of these patients again is very high, as high as almost 20%, which has been published by Malas et al. So what are the various abnormalities or the factors which help in the detection or determination of these coagulation abnormalities in COVID-19? There are various of them, like your prothrombin time, APTT, fibrinogen, D-dimer, and your fibrinogen degradation products. This study, which is published by Tang et al., you can see about the 183 patients, where we had the survivors and the non-survivors were divided. And if you can see in the non-survivor group, the PT, APTT, fibrinogen were all significantly raised. You can see the D-dimer was almost raised by almost 247% difference was there in the D-dimer level. So this definitely is an indicator of this elevated D-dimer is an indication of a coagulation abnormality. A study again by you and colleagues showed that the coagulation parameters as D-dimer was increased for almost 260%. So what exactly is the pathogenesis of this coagulation abnormalities in COVID-19? It is exactly resembles your virtuous triad, where there is infection by the virus, leads to inflammation, the endothelial injury producing endothelitis caused by the SARS-CoV-2, and there is stasis of blood, especially in the critically ill patients with multiple comorbidities. This hypercoagulable state, in a study done by Mayer et al., 15% of the patients evaluated show plasma viscosity greater than 95% of the normal. There is usually an inflammatory process in the pulmonary alveoli, leading to pulmonary tissue edema and intravascular coagulopathy. Exactly what happens in these patients, you can see there is alteration in the ACE2 receptor levels. This alteration in the ACE2 receptor levels leads to the interaction of the SARS-CoV-2 with the endothelial cells, particularly the type 2 pneumocytes. This cell infection and the induced inflammation in the pericytes and endothelial cells may promote local apoptosis and inflammatory cytokines. There is inflammatory process in the pulmonary alveoli leading to pulmonary tissue edema and intravascular coagulopathy. There is a potent local and systemic cytokine production, and the platelets are activated and interact with the neutrophil. This produces what is called as a netosis, which is a neutrophil extracellular trap process which may stimulate thrombin production and the fibrin deposition. This excess of fibrin deposition and fibrinolysis shutdown leads to intravascular thrombosis, and finally the clinical thromboembolic complication which may affect the cause pulmonary embolism, deep vein thrombosis, the stroke, and the myocardial injury. This is exactly what happens in the pathogenesis of COVID-19. This is the same thing which so this of COVID coronavirus, there are exactly stage 1, stage 2, stage 3 are there, where initially in stage 1 you can see this thrombotic episodes only in the periphery of the lung, where the disease is usually mild, but platelet counts are normal and the prothrombin time was usually normal. As the disease progresses due to the release of interleukins and all other factors, you have the stage 2, where the D-dimer level is 3 to 6 times the upper limit of normal, and it progresses to stage 3, where the D-dimer level is more than 6 times the upper limit of normal. This is the patient where he's in the frank ARDS, and the patient is invariably in an ICU or on an ECMO. The stage 1 and stage 2 usually have a mild to moderate disease. It is very, very important to distinguish other conditions which mimic your COVID-associated hemostatic abnormality, like your sepsis-induced coagulopathy and your DIC and thrombotic microangiopathy. So it's very, very important over here to differentiate these things. You can see over here, particularly in patients with CAHA, that is hemostatic abnormality. If you see the D-dimer, initially it's just only mildly elevated. As the disease progresses, you can see over there, it is more than 6 times the upper limit of normal. You can see the D-dimer is elevated. The platelet counts usually initially are usually mild elevated and decreased initially in SIC and DIC, but here in CAHA, it's usually increased. So this has to be it's very important to identify these conditions, differentiating between SIC, DIC, and the COVID-associated hemostatic abnormalities. So with this brief background about the pathogenesis, the incidence, and the pathogenesis, what are the drugs and what are the guidelines that have been given to us? Number of trials, ongoing trials, none of them have been completed till date. I'll just mention a few over here. You can see this anticoagulants in critically ill patients with COVID-19. That's the impact trial. Again, the intervention was therapeutic dose of anticoagulation drugs, enoxaparin, unfractionated heparin, fondopirinax. The active comparator was the intermediate dose prophylaxis drugs. So none of these trials have actually been completed. So the exact data, the guidelines for use of these anticoagulants in patients with COVID and after COVID is very, very incomplete. So like that, you have various other trials, which I have described over here. Freedom COVID-19, where they tried apixaban along with prophylactic enoxaparin. Then you also have this Coalizio action trial COVID-19, where again, they use rivaroxaban, the direct oral anticoagulants, compared with the usual standard of care with prophylactic dose of enoxaparin. So there are plenty of RCTs, randomized controlled trials, which have been described in the various phases, and none of them have been completed. Keeping these randomized controlled trials, various guidelines have been framed. The current guidelines that have been framed by the CDC, the ISTH, the ACF, and the AH, if you see over there, none of them have given exactly what is to be given. The CDC states no mention about the duration of the anticoagulation, therapeutic anticoagulation. Then again, if the ISTH and IG guidelines, again, there is no mention of the duration of the therapeutic anticoagulation. The ACF guidelines says 3 months course for patients initiated on anticoagulations during hospitalization. The ASH, American Society, again, there is no mention of the duration of anticoagulation. The American College of Cardiology, again, does not mention about the duration of anticoagulation in these patients. So these are the current guidelines which are usually being given to treat these patients. So taking all these parameters into consideration, the various guidelines have been framed, or recommendations have been given to start oral anticoagulation in these patients. So before starting these patients on anticoagulants, we have to know what is about the risk scoring and planning anticoagulations. So anticoagulations have been the mainstay of prevention and treatment of thrombosis for decades. You have various of them: unfractionated and the low molecular weight heparins, vitamin K antagonists, and the direct oral anticoagulants. You have the direct thrombin inhibitors like dabigatran, direct factor 10A inhibitor like eAPAPICON and rivaroxaban. So it is important to consider the thrombotic risk and the bleeding risk of a patient while planning anticoagulation therapy. Recommendation is to use the risk scoring to decide on the intensity and duration of the anticoagulation therapy. Numerous scoring systems are available, like the Padua score model, Caprini risk assessment model, and the improved score. So numerous scoring system, Padua model, Caprini risk. The recommendation is to use Padua model, a comprehensive yet simple and a validated venous thromboembolism risk scoring tool in COVID-19. It consists of, as I mentioned earlier, the active cancer, the score of 3, previous deep VTE 3, reduced mobility 3. So score is given for each of these parameters. If the score is more than or equal to 4, a patient with a score of more is considered to be a high risk of venous thromboembolism. So once you assess the assessment of venous thromboembolism risk, you also have to assess the bleeding risk in these patients. It is important to assess the baseline bleeding risk. For this, you can use the Has-Bled score. The Has-Bled score, given the various parameters like hypertension, renal disease, liver disease, stroke. If the patient with a score of 0 to 1 is considered at low risk, and 3 or more is considered as high risk for bleeding. If you have a patient who has been admitted to the ICU, you have this ISTH and a DIC scoring. The recommendation is to use these patients in sick patients. Elevated ISTH DIC scoring of more than 5 has been shown to be associated with high likelihood of death due to thrombotic events in COVID-19 patients. So what are the various drugs available? I already told molecular heparin and unfractionated heparin. You have 3 categories: the prophylactic dose, the intermediate dose, and the therapeutic dose. For prophylactic dose, you give 40 milligrams daily. Intermediate dose, you give 60 milligrams once daily or 40 milligrams twice daily. And therapeutic, 60 milligrams per kg twice a day or 1 milligram per kg. The unfractionated heparin, it's 5,000 units subcutaneous, international units subcutaneous. The oral, you have eAPAPICON and rivaroxaban. Prophylactic 2.5 milligrams twice a day. Therapeutic 5 milligrams twice a day. Rivaroxaban 10 milligrams once a day, and therapeutic is 20 milligrams once a day. So keeping this parameters, you have the disease categorized of COVID disease as mild, moderate, and severe as per our Ministry of Health and Family Welfare. So if you come across a patient with mild pneumonia where the SpO2 is more than 95, you assess the bleeding risk in this patient using your Has-Bled score. And if the bleeding risk is high, there is no recommendations for anticoagulants. However, if the bleeding risk is low in this patient, you do a VTE risk, which by using the Padua model. And if the VTE risk is low, again, there is no necessary for anticoagulation. If it is high, you will have to use a prophylactic dose of anticoagulants in these patients. Prophylactic dose, as I already told you, it's enoxaparin can be used, or eAPAPICON or rivaroxaban can be used. If the next group is the patient with moderate disease, where the saturation is 90 to 94, respiratory rate is more than 30. You assess the bleeding risk. Again, if it is high, there is no need, no question of anticoagulation. If the bleeding risk is low, you have to consider for anticoagulation. The venous VTE risk by using the Padua model is used. And if it is low, a prophylactic dose of your anticoagulants has to be given. If it is high, an intermediate dose of anticoagulants using enoxaparin 60 milligrams once daily or 40 milligrams twice daily has to be given. You have these patients with severe pneumonia, critical disease, where the saturation is less than 90, respiration is more than 30. The bleeding risk you assess by using your Hasbled, and if it is definitely high, the prophylactic dose can be given in these patients with severe critical pneumonia, severe pneumonias. However, if it is low, you have assess the ISTH-DIC score. If it is more than 5, and if the answer is yes, you have to give the therapeutic dose. If it is low, then you assess the venous thromboembolism risk, and you give the prophylactic and the intermediate dose of thromboembolism, depending whether it is you have a score of more than 4 or less than 4. These are the recommendations that has been published by this article was published in JAPI. So now about the post-discharge prophylaxis in COVID-19. Post-discharge thromboprophylaxis following remains an issue of much debate. Routine administration in all patients with COVID-19 at the time of discharge is not recommended. The American Society, the CHEST, and do not elucidate the post-discharge thromboprophylaxis. However, NIH guidelines as well as the ISDH guidelines and the British Thoracic guidelines mention post-discharge prophylaxis based on the expert opinion. So what are these expert opinions? So decision regarding post-discharge should be individualized, patients with moderate to severe disease, and fulfilling any of the following criteria. So what is this criteria? This is based criteria called as a modified improved VTE scoring system. What are the parameters which consists? It consists of this is called as an MIV score, where it consists of previous VTE, known thrombophilia, current lower limb paralysis, and history of cancer, ICU stay, complete. Each of them have been given a scoring of 3, 2, 2, and an age more than 60 is given a score of 1. If this MIV score is more than 4, he is a candidate for post-discharge anticoagulation. If MIV is more than 2 with a D-dimer value of 2 times the upper limit of normal, and age more than 75, age more than 60 with D-dimer value of more than 2 times the upper limit of normal, he is a candidate for prophylactic oral anticoagulation on discharge. So these are the guidelines that have been mentioned by the expert panel. So follow-up, choice, and duration of anticoagulation. There is no role of routine measurement of D-dimer during post-discharge because you are using the DOACs. DOACs do not require INR monitoring. Preferred DOACs include rivaroxaban 10 milligrams once a day, betrixaban 160 milligrams on the first day, followed by 80 milligrams once a day, and apaxaban 2.5 milligrams 2 times per day, as per the studies that have been recommended by the expert panel. So a word of caution, in renal insufficiency, warfarin is preferred over DOACs. However, at eGFR 30 to 15, apaxaban 2.5 milligrams 2 times per day can be used. Regarding the duration, the FDA recommends rivaroxaban 10 milligrams for 31 to 39 days. That is approximately about 6 to 7 milligrams a day, followed by 80 milligrams once a day for about, again, same 6 to 7 weeks they are recommended. ACC, American Cardiology, suggests extended thromboprophylaxis with low molecular or DOACs for a maximum period of 45 days in case of high risk of venous thromboembolism. What about anticoagulations for COVID-19 patients on OPD basis? Should not be given as a routine to COVID-19 patients managed as outpatient. However, selected patients with COVID-19 who are not admitted to hospital with very high thrombotic risk but low bleeding risk can be given a prophylactic dose for about 4 to 6 weeks. So you have to assess the thrombotic risk and bleeding risk. If they have a high thrombotic risk, as per the Padova model, you can give them 4 to 6 weeks. That is what the recommendations say. Antiplatelet therapy have no role in thromboprophylaxis. They are not recommended as routine. However, a small retrospective study of 412 COVID-19 suggests aspirin use is associated with decreased ventilation, ICU admission. However, large data is needed for this. Patients with acute and chronic coronary syndromes who are already on antiplatelets may continue the same unless contraindicated. If there is an elevated bleeding risk, they can be changed to clopidogrel. Very, very important is your drug-drug interactions between coronavirus disease, the drugs that are used in the treatment of COVID, and your anticoagulants. If you see over here, the low risk, intermediate to the green is low risk, yellow is the intermediate risk, and the red one is the high risk individuals. So if when you are using this unfractionated and low molecular weight heparin, the remdesivir, azithromycin, methylprednisolone, tocilizumab have got very low risk. It comes to warfarin. If you ribavirin, anyway, we are not using it, but azithromycin was used in plenty in these patients with COVID-19. They had intermediate drug-drug interactions. Methylprednisolone, where it's recommended in all patients, and tocilizumab was used. Again, they have intermediate, mild to moderate drug interactions in these patients. So you should be very careful when you're using warfarin along with methylprednisolone and tocilizumab. The other things, your apaxibin, rivaroxaban, lopinavir, ritonavir, anyway, it was not used initially, only a few days it was used. But however, azithromycin again is having a very high drug-drug interaction with your apaxibin, rivaroxaban, that is your direct oral anticoagulants. And chloroquine also was phased out. I think that was not a problem in these patients. So aspirin, again, having an intermediate drug-drug interaction with methylprednisolone. So that's about the drug-drug interaction. So what are the future therapies? Determine the efficacy and safety of drugs previously tested for venous thromboembolism. You have sulodexide, antithrombin, thrombomodulin, and APC. None of them have randomized controlled studies in RCTs in patients with COVID-19. Sulodexide showed a reduction in recurrent VT events. Antithrombin have been studied in the context of sepsis-induced coagulopathy, not in patients with your CAHA. In special situation, patients with prosthetic heart valves, the current recommendation is that all patients with mechanical prosthetic heart valves, including those who are pregnant, may preferably be continued with your VKS, that is warfarin, with frequent INR monitoring. Pregnancy, low molecular weight heparin is appropriate if delivery is not expected within 24 hours and after delivery. Pregnant women who may need a faster discontinuation of anticoagulation may be placed on unfractionated heparin. DOACs are not proven to be safe during pregnancy. Anticoagulation therapy should be for 4 to 6 weeks postpartum for all COVID-19 patients and for at least 3 months in those with documented venous thromboembolism. Thrombocytopenia is one of the complications in about the rapid fall in platelet counts of more than 50% over 24 hours or less than 20,000 is of immune etiology. Anticoagulation therapy is unsafe when platelet count is less than 25 to 50,000. Liver disease carries a risk, of course, with the bleeding abnormalities. Thromboprophylaxis with low molecular weight heparin should be standard of care for all patients with cirrhosis of liver. Renal disease, CKD patients are at higher risk of bleeding and thrombotic complications and need close monitoring. Dose modification is necessary in these patients. Renal dose, low molecular weight heparin or unfractionated heparin at 10 to 14 units per kg per hour, targeting an APTT of 60 to 90 seconds is usually recommended. So the take-home message, venous thromboembolism secondary to COVID-19 has resulted in higher mortality. A vast majority of patients present with undiagnosed thromboembolism following COVID-19. Anticoagulation in moderate to severe and critical disease of COVID-19 is advisable depending on your Padua scoring and your Has blood scoring. Enoxaparin is the preferred low molecular weight heparin for anticoagulation in acute phase of venous thromboembolism. Post-discharge prophylaxis may be considered in patients with high risk of thromboembolic events after assessing the bleeding risk in those individuals. Rivaroxaban and apaxaban are preferred for post-discharge prophylaxis. Thank you.
Thank you, Dr. Ravi. I think I'm audible.
Yes, sir.
The last topic for today's panel discussion, the topic is post-COVID complications by Dr. Alladi Mohan, and the various names have been given to this condition: post-acute COVID, chronic COVID, long haul COVID, all these long-term effects of COVID. We do see many cases of mucormycosis and MIS and all. So we are going to listen to Alladi Mohan. Alladi Mohan is MD, FRCP, FICP, now professor with and head of the Department of Medicine, SWIMS, Tirupati. I'm thrilled seeing his. Hello? I'm thrilled seeing his biodata. He was the best outgoing student, first among the first ranking students. And he got 25 gold medals and prizes, including the Sri Mohan Lal Big Gold Medal, Allied Institute of Medical Sciences in New Delhi in 1994, Outstanding Referee Award in API 2002, first of the four Shakuntala Amir Chand Prizes, ICMR 2004, AP Scientist Award 2008, Best Teacher Award during 2011, more than 290 publications in reputed indexed international national journals, edited 4 books, including the popular textbook of tuberculosis, non-tuberculous mycobacterial diseases, 3rd edition, and the editor of Indian Journal of Chest Diseases and Allied Sciences during since 2010. Associate Editor, Lung India since 2010. Member, International Advisory Board, Hutchinson's Clinical Methods, 24th edition. Past Chairman, Andhra Pradesh Chapter of API, 2018-2019. Member, Governing Council, IACM. I present Dr. Aladi Mohan to present on post-COVID complications. Sir.
Thank you, sir, for a very kind and elaborate introduction. In the interest of time, I'll quickly go over to my presentation, which happens to be the presentation on post-COVID sequelae and complications. I have no funding for this talk, and I have no conflict of interest to declare. If you look at the natural history of COVID, it is evident that 10% of patients with COVID, they remain unwell even after 3 weeks. But a smaller, but there's no consensus on this number, maybe 5% or less, they have symptoms going on for a long time. This became evident within few months of onset of COVID outbreak last year. Now, there is a huge confusion on the terminology. Post-COVID, persistent post-COVID, long COVID, long haul COVID, post-acute COVID, chronic COVID, and so on. So varying time periods were assigned and defined in the 2020. But today, the most widely accepted definition, this is for the benefit of postgraduates, if there are some of them logged into this session, that we look at the aftermath of COVID as acute COVID, ongoing symptomatic COVID, and post-COVID. Acute COVID is signs and symptoms of COVID for up to 4 weeks. Ongoing symptomatic COVID is 4 to 12 weeks. And post-COVID-19 is beyond 12 weeks and are not explained by an alternative diagnosis. So acute, ongoing symptomatic, post-COVID. This is regarding the current least controversial definition of or terminology of post-COVID. Why at all post-COVID sequelae consequences occur? It could be unmasking of underlying comorbidities. It could be a residual ongoing damage from acute infection. There may be a persistent or a restricted viral replication, which is ongoing. Persistent immune activation, very popular in the social media, but no hard data, not much of hard data. And of course, the unknown etiologies which are being pursued. The post-COVID consequences are bizarre. They range from the post-ICU syndrome. After the discharge, we have cognitive impairment, mental health issues, physical impairment, and several reasons like deep sedation, drug usage, immobility, and all being implicated for that. And there are also important psychosocial manifestations. You see death of family, co-workers, not able to attend the funeral, loss of work, emotional trauma, stigmatization. We've seen several private practitioners admitted with COVID. They don't want anyone in the town to know that they have COVID because they may lose their practice and so on. there is a perceived life threat. So anxiety, depression, post-traumatic stress disorder, OCD, panic disorder and all, these are all seen in the immediate aftermath of COVID-19. The respiratory consequences can sometimes be devastating. We exactly don't know in whom this normal lung becomes a COVID lung like this. Over what period in time? Can we identify who go on to deteriorate like this? There are good questions with no tangible evidence-based answers. Post-COVID involvement is seen with all systems, not only respiratory. It is seen in endocrine and metabolic system, increased risk of hyperglycemia, unmasking of diabetes, hypocortisolism, increased risk of dyslipidemia, hypothyroidism, and so on. Musculoskeletal neuromuscular manifestations are too many, and the persistent aches and pains and reactive arthritis, these have actually impaired people who even wanted and who were motivated to get back to work. It prevented them from being functional. Psychiatric manifestations are several, and cardiological manifestations, increased incidence of cardiovascular disease, arrhythmias, heart failure, myocarditis, CAD, spate of MIs, and so on, palpitations, tachycardia, and even bradycardia, which one of my own postgraduates developed, are all described in long-term effects of COVID. One other threatening brief volcano which we faced over last couple of months was mucormycosis. In addition to this long list of risk factors for mucormycosis, which we have seen from our post-graduation time, COVID-19 has emerged as one more risk factor. It's a frightening disease. Most tangible explanation, I personally believe, is misuse, abuse of corticosteroids in inappropriate dosages for inordinate duration. The industrial oxygen myth and all, they are all there, but there is no tangible scientific proof. It is messed up COVID-19 management with corticosteroids, with over-enthusiasm, especially during the second wave, is my personal view. The site of involvement is seen rhino-orbital cerebral, pulmonary, cutaneous soft tissue, gastrointestinal, and rarely disseminated and other body sites. Whenever a post-COVID patient presents with new onset headache, facial pain, eye pain, numbness over the face, ptosis, blurring of vision, loss of vision, nasal discharge, epistaxis, this condition is suspected. The presence of blackish coloration of skin, nasal mucosal erythematous changes, necrotic eschars, periorbital swelling, proptopsis and all, and the features of cavernous sinus thrombosis. I think every physician has tackled handsful of mucormycosis as a consequence of COVID-19, at least for a brief period. Is there any role for pharmacological interventions? I already told you there is no way to identify who developed post-COVID consequences. What is the subgroup? What is the marking biomarker for this? We don't know. Post-COVID, several interventions have been used. Beta-2 agonists extensively, along with inhaled steroids. Watch for hypokalemia. This can result in intercostal muscle weakness and worsen the pre-existing hypoxemia. Vitamin D calcium supplementation, equivocal to positive results. Antifungal treatment with adjunctive loco-regional surgery for the mucormycosis. A word of caution, very enthusiastically, especially in the corporate sector, which consider themselves beyond the boundary of a guideline. So innovation, experimentation, adventurism is the norm there, not the standard of care following the guideline. This is my personal view. The use of antifibrotic agents, pirfenidone, nintedanib, baricitinib, these are all extensively tried, but anecdotally, some say it is improving, some say it is not, but there is no guideline saying that this should be used. Antifungal treatment, I have already mentioned, and the management of post-COVID-19 patients at primary care level is possible if they are not in the high-risk group and they are maintaining status quo with breathing exercises and yoga and other practices. However, the indications for referral include worsening breathlessness, falling saturations, unexplained chest pain, new confusion, and focal weakness. Elderly, those with diabetes and other comorbid conditions, those requiring oxygen supplementation at discharge are all the high-risk groups. So primary care referral should be the norm. While a good majority can be managed at primary care, they need to be referred to tertiary care. At the tertiary care, there is a team which manages the post-COVID scenario, like in every tertiary care center. And some patients may eventually require, after stabilization, domiciliary oxygen therapy. There is no consensus with regard to the use of corticosteroids, antifibrotics, etc. One consideration may be given individually. Anticoagulation is already covered by Dr. Ravi. Vaccine, yes, everybody, even COVID survivors, need vaccine. Professor Sudha has so elegantly told us. Before I conclude my presentation, so that we have some time or space for discussion, a 26-year-old high school teacher from Georgia described the symptoms of post-COVID pretty much nicely as shown in this poem. My chest hurts and head pounds, the body aches, the heart races. I can hardly move, it's extreme fatigue, brains in a fog, can't remember the name of my dog, lost my sleep and my appetite, feet are tingling, ears are ringing. It's a long haul COVID. We are learning, still learning about post-COVID, and I hope we eventually reduce the misery of all those with post-COVID. I conclude my presentation here, and I request our moderator, Professor Ramurthy Garu, to lead on to the question and answer session.
Thank you, Aladi Mohan. We started this panel discussion at about 2:15. Now it is beyond 3:15. In fact, the time given to us was only to 1 hour. I don't know whether we can accept some questions from the audience because it's a very burning topic of the present day topic, and the pandemic is on. So there must be so many questions on this. I take the help of Dr. Subbarao Garu to go ahead with the question and answer session. Subbarao Garu. Subbarao Garu?
Sir.
Are we going to accept good number of questions on this?
Sir, you have any questions in the chat box or your?
In my chat box, I don't have any. But I have a good number of questions from myself, from my side.
On your chat box, good number of questions.
No. I don't have questions in my chat box. In my brain,
okay, sir. Sir, then
1 or 2 questions we pose and we'll conclude this session. Okay.
Okay, so you're a senior person, learned person. So put forth your questions, sir.
Madam.
Yes, sir.
Sudha Vidyasagar.
Yes, sir.
This is suppose while giving a vaccine, we are forced to give steroids. Do you think any contraindication in that?
There is no contraindication, sir. But all immunosuppression is best reduced at the time of vaccination. Otherwise, the vaccination, the efficacy may come down. It's not a contraindication.
Okay, but efficacy may come down. If it is a must, we can go ahead with the combination.
Yes. We can avoid the immunosuppression at the time of vaccination. That's what our nephrologists do. They want to give immunosuppression for, say, SLE or whatever. They are doing it cyclically. Then they will put the vaccine a little away from the immunosuppression.
We have DNA vaccines, you know. So are they going to alter your chromosome or gene in a particular way that they are dangerous?
No, sir. They are not supposed to alter them at all. But
is there a possibility?
I don't think so, sir. I don't think so because I don't think it goes into the genome like that. It is a part of the vaccine only. It's not going to alter the host genome.
Dr. Subbarao, I think we can conclude this session.
Sir, thank you, sir. You give the concluding remarks, say thanks to the presenters, then hand it over back to me, sir.
Thank you, Aladi Mohan. Thank you, Ravi. Thank you, Sudha Vidyasagar. Really, it was an academic feast from all of you. Really, the way you spoke, excellent, and they show your exposure. commitment to the academics as well as the society. Thank you, one and all. Over to Dr. Subbarao.
Thank
you, sir. Thank you. Thank you, sir.
Sir, thanks to the moderator and the panelists. Then we'll go to the second meet the expert session of this afternoon. That's on the motility disorders in gastroenterology, to be moderated by Dr. A.V. Shivaprasad Garu, Senior Gastroenterologist from Visakhapatnam. The panelists will be Dr. K. Shravan, Dr. A. Chalpatrao, and Dr. Arun K. They'll be the experts who will discuss and answer your questions. And then the biodata of Dr. Shivaprasad Garu. He's a senior consultant gastroenterologist. He is from Institute of Gastroenterology, Visakhapatnam, and maybe
Sir,
from
I think we can save time by skipping this, no problem. We can go ahead with the session.
So you're being very magnanimous, sir. Thank you, sir. Thank you very much. then, sir, you can go start with and go ahead with the discussion, sir. Dr. Shivaprasad Garu, I'll hand it over to you.
Yes. I thank AP State Chapter for this opportunity. And this is an important session on topics in luminal gastroenterology, though it is entitled motility disorders. I think my speakers will agree that motility forms only one aspect of these disorders, but they are the most common and problematic disorders in practice, both for gastroenterologists and physicians. So as per the format, we'll have three speakers first, and after the three speakers are completed, we will go for a common question and answer session. So I'll first call upon the first speaker, that is Shravan Korapati, who is Senior Consultant Gastroenterologist at Pinnacle Hospital. He had done his MBBS and MD from Kurnool and his DM at Visakhapatnam. And after that, he has done an Advanced Therapeutic Endoscopy Fellowship at Pune, after which he has been in practice at Vizag. He has personal experience and studies in this field of chronic diarrhea. I have known from first-hand knowledge. And I can also say from first-hand that Shravan is a kind of postgraduate that, if in a class, if everybody has stuck with something, you turn to Shravan for the answer. So over to Shravan.
Good afternoon, everyone. Thank you, Shiva sir, for your kind words. And I thank the organizers for giving me this opportunity to speak on irritable bowel syndrome with you. Good afternoon, everyone. Let us start with a clinical case scenario. Here is a 45-year-old female who presented with 6 months history of watery diarrhea occurring almost 10 times per day with mild abdominal pain, which is relieved by opening her bowels. And there is no history of weight loss and no other associated symptoms, but she has been using NSAIDs for osteoarthritis but not on any other medication. And there is no relevant family history, and her clinical examination is unremarkable. Let us see how to approach this patient in subsequent slides. Functional gastro-GI disorders has been divided into predominantly that affect the upper GI tract or that affect the lower GI tract. But to say specifically, these functional GI disorders, they don't occur in isolation. They occur as a continuum because there will be symptomatic overlap between these conditions. Irritable bowel syndrome is a chronic, often debilitating condition, highly prevalent disorder of gut-brain interaction, and worldwide it is 10% in prevalence. In India, it is 4%, and most commonly affects women and individuals less than 50 years of age. And various pathophysiological factors has been speculated for this, and most of them are altered gut microbiota, altered endocrine metabolism, and bile acid malabsorption, increased permeability, leading to brain-gut dysregulation and altered motility of the intestine. The most common is the mechanistic theory, where hypomotility occurs in patients with constipation and hypermotility occurs in patients with IBS diarrhea type. And the recent one is the gut-brain disorder rather than brain-gut disorder, because each person may be having different gut microbiota. So whenever a person of different microbiota has been exposed to an insult, like any acute GE or food allergy, that leads to damaged mucosal permeability, leading to translocation of gut bacteria from the lumen into the submucosa, leading to activation of mast cells to Th2 pathway. That leads to release of cytokines, and these cytokines cause neuronal excitation and smooth muscle contraction. And these cytokines are also released into circulation, leading to extraintestinal manifestations. So this irritable bowel syndrome patients present with chronic abdominal pain and altered bowel habits like diarrhea and constipation. And abdominal pain mostly they say as cramping sensation, and the location characteristic of the pain vary widely, and there will be stressors like emotional stress and meals, and pain is frequently related to defecation. And diarrhea is of small to moderate volume, and most of the time these bowel movements occur during waking hours, and these bowel movements are preceded by pain, urgency, and sensation of incomplete evacuation. And patients of irritable bowel syndrome has been subdivided into based on the predominant bowel habit on days with abnormal movements, and these should be evaluated off medications that are used to treat bowel habit abnormalities. And the classification has been used with the help is Bristol stool form scale. Here the stool forms has been divided from type 1 to type 7, whereas 1 and 2 mostly these patients in constipation the hard lumps are nuts like stools. Type 6 and type 7 are the fluffy feces and watery stools. The subtypes are the predominant diarrhea type, predominant constipation type, mixed type, and unclassified type. For that, 25% is the rule. If the patient is having more than 25% of the stool form as type 6 and type 7, it is diarrhea type, and 1 and 2 type is constipation type. If it is both, then mixed type. If it is not fitting into any of this, then it is unclassified type. How to approach for a diagnosis in these irritable bowel syndrome patients? As we have discussed earlier, these mostly exist as a continuum rather than in isolation, and there will be symptomatic overlap between these conditions, and these conditions also mimic organic diseases, posing a challenge for the diagnosis. And there is no specific biomarker or test to confirm or to rule out diagnosis of IBS. So the clinical diagnosis requires fulfillment of a symptom-based diagnostic criteria and a limited evaluation to exclude underlying organic disease. And most commonly used symptom-based diagnostic criteria is the Rome-4 criteria. Here in the Rome-4 criteria, the recurrent abdominal pain occurring on average at least 1 day in a week for the past 3 months, associated with 2 or more of the following criteria like pain related to defecation, pain associated with change in frequency of stool, or associated with change in consistency of the stool. And other symptom-based criteria are the Manning criteria and Cruise criteria. And how to evaluate these patients? First, you have to take a complete history, including the onset and also the triggers, and complete drug history, because sometimes patients may be on some drugs that can alter the bowel habits, and complete physical examination, and limited laboratory tests like complete blood culture, C-reactive protein, and fecal calprotectin in patients with diarrhea to rule out inflammatory bowel disease. And there is a meta-analysis where patients with IBS symptoms and CRP of less than or equal to 0.5 and calprotectin of less than or equal to 40 microgram per gram, there was less than 1% pretest probability of IBD. Along with these tests, whenever the clinical suspicion of thyroid disorder is high, routine thyroid test can be indicated. And whenever a patient is from area where prevalence of celiac disease is high, diagnosis testing for celiac disease can be done. And patients present with new onset altered bowel habits or diarrhea in a more than 50 years of age, then colonoscopy is indicated. Along with these, some red flags should be seen that suggest an alternative diagnosis or coexisting other organic diseases like anemia, fever, rectal bleeding, weight loss, nocturnal symptoms of pain, family history of GI malignancy, IBD or celiac disease, or new onset of symptoms in patients more than 50 years of age. Additional diagnostic testing should be done for these patients who present with red flag signs. And there has been a quest for novel biomarkers that can help in the diagnosis of IBS. Among these are the cytolethal distending toxin B, which is produced with the gram-negative bacteria that can cause GE. And another one is the vinculin, that is an actin binding protein that regulates adhesion. There is a study by Pimentel et al. Where they have shown that when compared with healthy controls, IBD patients and celiac disease patients, patients with IBS are having high antibody titers to this anti-cytolethal distending toxin B and antivinculin antibody titers, where they have shown AUC of almost 0.81 for anti-cytolethal toxin antibody B, and for antivinculin antibodies AUC is 0.62. And specificity is 92%, and antivinculin has specificity of 84%. But these two biomarkers need further studies before they can be used clinically. So whenever a patient presents with defining symptoms of abdominal pain and altered bowel habits, along with features that support diagnosis of IBS is pain relieved or worsened by bowel movements, additional abdominal symptoms like bloating, distension, and non-GI symptoms like migraines, constant lethargy, and presence of any other functional GI disorders also support IBS diagnosis. And for the coming to the differential diagnosis, most commonly the malabsorption syndromes, infections, IBD, psychological disorders can be present. And to see the natural history of IBS, there has been a study done by El Sarag et al., where they have followed up patients who was diagnosed with IBS for almost 6 years. Less than 5% of IBS patients diagnosed with an alternative GI organic disorder. So repeated diagnostic evaluation is not warranted in these patients. Coming to our patient, here she is 45 years old female with 6 months history of diarrhea, that is stool form scale is 6, occurring 10 times per day with mild abdominal pain and relieved by opening her bowels. So she is fitting into the Rome criteria, but one thing that is most important is she is using NSAIDs for osteoarthritis. So in these patients, even though she fits into the clinical criteria of IBS, as she has been on NSAIDs that can cause microscopic colitis, colonoscopy and biopsies are required to rule out microscopic colitis in this patient before diagnosing her as irritable bowel syndrome. Coming to the treatment of these patients, we have to initially assess these patients first to identify the symptom triggers and to assess impact of these symptoms on daily life and to assess for psychological comorbidities, for other physical comorbidities, and explore patient values, preferences and goals, what he is expecting after the diagnosis or after the treatment. And this is a IBS severity score developed by Francis et al., where they have taken into 5 parameters and divided IBS symptoms into mild, moderate and severe. And the most important aspect in the management is the lifestyle modification. These patients require education and reassurance, and you should encourage physical activity and encourage healthy eating habits for these patients. And the dietary modification, low food map type has been speculated, and along with this, exclusion of gas producing foods like beans, onions and bananas, lactose avoidance, gluten avoidance, although it has shown some conflicting results, and food allergy testing. The role of food allergy testing is unclear. Coming to the low food map diet, these food maps are the fermentable oligosaccharides, disaccharides, monosaccharides and polyphenols. These short chain carbohydrates are poorly absorbed, so they become osmotically active in the intestinal lumen, where they are fermented, leading to symptoms of bloating and pain. So low FODMAP education consists of eliminating foods that contains high FODMAPs for up to 6 to 8 weeks. After that, symptom resolution, gradual reintroduction to determine individual tolerance to specific fermentable carbohydrates. So the foods that are high in FODMAPs that should be avoided are garlic, beans, onions, watermelons, battered meats, almonds, avocados, all these things. This is a randomized trial where in 92 patients with IBS-D, where they were assigned to 4-week therapy with low FODMAP diet or a modified NIH diet, that is small frequent meals, avoiding trigger foods and avoiding excess alcohol and caffeine. Here, the group on the low FODMAP diet exhibited significantly high rates of improvement in pain and also greater reduction in average daily scores of pain, abdomen, bloating, consistency, frequency, and urgency. Apart from this, adjunctive pharmacotherapy should be added for these patients for symptomatic improvement. Among these are the mainly is the antidiarrheal for IBS patients with diarrhea. Among the antidiarrheals, the main thing is the loperamide, which is a mu opioid receptor antagonist. It decreases the peristalsis and it prolongs GI transmit time. And adverse effects of this drug include abdominal cramps, constipation, and bloating. It was more effective than placebo for treatment of diarrhea by decreasing frequency, but not for the symptoms of bloating, abdominal discomfort, and global IBS symptoms. And the newer drug is the elixadolin for diarrhea patients. Elixadolin is a peripherally acting mu and kappa receptor agonist and delta receptor antagonist. It mainly acts by reducing the visceral hypersensitivity without completely disrupting the intestinal motility like loperamide. So mu and kappa agonism leads to reduction in visceral sensitivity and also slows down gut motility, but it has also having delta antagonism, so it decreases the risk of constipation when compared with loperamide. This is a study done by Lembo et al. IBS 371 and 372 trial, where they have seen the composite response over 12 weeks and 26 weeks. Patients on elixadolin performed better when compared with placebo. Even the abdominal pain response and Bristol stool form scale also showed improvement. And the dose is 100 mg twice day, and in patients with mild to moderate hepatic impairment, 75 mg twice daily. And adverse effects for this elixadoline are the constipation, nausea, pancreatitis, and sphincter of body spasm. So this drug is contraindicated in patients with history of pancreatitis and those without a gallbladder and those with history of alcoholism, alcohol abuse, and severe hepatic impairment. Another group of drugs are the serotonin receptor, particularly 5-HT3 antagonist. These drugs modulate the visceral afferent activity, thereby decreases the colonic motility and secretion and improve abdominal symptoms. Among these are the alosetron and ramosetron. Alosetron should be used exclusively in chronic severe IBS diarrhea female patients only, whereas ramosetron can be used in both male and female patients. And most important adverse effect for this group of drugs is ischemic colitis. This is a meta-analysis done by Jang et al., where they have shown that when compared with placebo, ramosetron significantly showed improvement in abnormal bowel habits and also improvement in stool consistency. And ramosetron is equally effective both in males and females when compared with placebo. This is the same meta-analysis. And another drug is the rifaximin, which is a orally acting broad spectrum antibiotic. It has shown good gut antibacterial activity with low microbial resistance, low systemic absorption, and high safety profile. The dose is 550 mg TID that has been used in the target trials, and it mainly acts by altering the gut microbiota. Both the target 1 and target 2 trials have shown that when compared with placebo, patients on rifaximin had shown adequate relief on global symptoms and also the stool consistency improvement. And after treatment for 2 weeks, these patients can get relapses, and further they have seen in the target trial, patients with relapsing symptoms of IBS, repeat rifaximin treatment also is well efficacious and well tolerated. And this study, target 3 trial, supported that approval for rifaximin for treatment up to 2 additional treatment for symptom recurrence. And another group of drugs are the tricyclic antidepressants. These tricyclic antidepressants, via their anticholinergic properties, they slow intestinal transit time, but these should be started at low doses because these drugs have delayed onset of action. At least 3 to 4 weeks of therapy should be attempted before increasing the dose. Among these are the amitriptyline, nortriptyline, imipramine, and desipramine. Next one is the bile acid sequestrants. There has been an open label study where they examined the presence of bile acid malabsorption and response to treatment with bile acid sequestrants in patients with IBS-D, where they have seen that more than 55.5% patients showed considerable response, but there are no control trials till now for these bile acid sequestrants to be used in patients with IBS-D. And antispasmodics, they can affect directly intestinal smooth muscle relaxation, or via their anticholinergic or anti-masking properties, they can decrease the pain. Among them are the dicyclomine and hyoscyamin. Next one is the fecal transplant. Actually, the most common theory.
Shravan, can you think of exceeding your time? Can you just come?
Two slides, sir. Last 2 slides. Fecal microbiota transplant. The changing the gut microbiome to improve symptoms shows appeal, but it has showed only limited evidence. And in next future, there could be a treatment for IBS-D based on the pathophysiology, like in patients with sodium channel mutation, these voltage-gated sodium channel blockers can be used, or patients with increased gut permeability, larazotide can be used, or reduced fecal bile acid, elobixibat can be used. All these drugs are in the pipeline for the IBS. So to summarize, the 5 golden rules of IBS are: use the positive diagnosis, limit the extent of investigations, address the patient fear and your own insecurities, and explain to patient what the gut-brain axis is, and counsel the patient making the treatment choices. Thank you.
Thank you, Shravan. I think that last slide really summarized the approach to IBS or almost all functional disorders that we should be holding. And actually, we should look at drug treatment as only a supportive. And I think the goal of therapy of functional disorders is to get the patient comfortable without drugs. So we go on. There are plenty of, I'm sure there will be questions coming up. Even if they are not, I have plenty of questions and comments to make. So we'll come back to that in the last session, in this discussion session. We go on now to the second topic, which is refractory GERD. And this will be addressed by Dr. Arun Karyampudi, who is Associate Professor of Gastroenterology at GSL Medical College, Rajahmundry. And he has a special interest in GI motility with publications and work in this field. And there is a number of original publications and faculty at various conferences. So the problem of GERD is extremely common one, and the problem of defining refractory GERD, I think, is more difficult than diagnosing GE reflux, which is often done easily. To address this difficult topic, that is, what is refractory GERD and how do we manage it? I pass on the session to Dr. Arun, please. Yes, Arun, you're online. Unmute yourself.
Giving you the approach and principles of treatment of this condition.
Okay, this is recorded.
Gastroesophageal reflux disease can present with typical or atypical symptoms. The typical symptoms include heartburn and regurgitation. On the other hand, atypical symptoms include non-cardiac chest pain, chronic cough, and asthma. Commonly, what we see in our patients presenting with gastroesophageal reflux disease are these three symptoms: heartburn, regurgitation, and chest pain. So before discussing what's refractory GERD, how to treat refractory GERD, first we need to know how GERD is classified. GERD is classified based on clinical, endoscopic, and pathophysiological presentations. Clinically, GERD can be classified as PPI responsive and PPI non-responsive GERD, what we typically call as refractory GERD. Endoscopically, we classify it into erosive reflux disease and non-erosive reflux disease. So when you find ulcers or erosions at the lower end of esophagus that are typical of reflux esophagitis, then we call the condition as erosive reflux disease. But when you do not find erosions or ulcers at the lower end of esophagus, then you call the condition as non-erosive reflux disease when patient has reflux symptoms. Pathophysiologically, GERD can be classified as pH positive GERD, that is what we call as true GERD, esophageal hypersensitivity, and functional heartburn. In pH positive GERD or true GERD, the patient has acid reflux or non-acid reflux on objective investigations such as pH metry. But on the other hand, if the patient does not have objective evidence of GERD, then they come into the category of esophageal hypersensitivity or functional heartburn. Generally, when a patient comes with typical GERD symptoms and absence of red flag signs, we put them on proton pump inhibitor trial. We usually give them a 2 to 4 week trial of proton pump inhibitor. Usually when patient has typical GERD, the response is rapid and they fairly respond within 2 weeks of treatment. Proton pump inhibitors are very good drugs when they are given at optimal doses. They usually heal of all the reflux esophagitis in almost 90% of patients. So the healing rate is fairly high. When you give 8 weeks of PPI therapy, you see healing in almost 90% of patients. But in some instances, you can have failure of PPI therapy. About 1/3 of patients fail to adequately respond to once daily PPI therapy. And when you put them on long-term therapy, almost 50% of them experience breakthrough symptoms. Approximately 10% of them will still have reflux symptoms when they are put on twice daily PPI. So, refractory GERD is typically defined as persistence of symptoms, typical symptoms such as heartburn or regurgitation that does not respond to a stable dose of double dose of PPI during a treatment period of at least 8 weeks. So before going into the discussion, I will just start off with a case capsule. So here is a 38-year-old gentleman with a BMI of 26 with no other comorbidities, presents to us with chest pain and heartburn for 1 year that used to increase after meals. His cardiac evaluation was normal. There was no significant relief with once daily PPI with prokinetic. So he was given esomeprazole of 40 mg and domperidone combination for 2 weeks, with which he did not have significant relief. When the PPI dose was doubled, he had partial symptom relief, but he did not have satisfactory relief in his symptoms. An endoscopy was done because he had GERD symptoms for a long time. It showed lax G junction with gastritis. So what to do next? How to approach this patient? So this patient, does he have refractory GERD? Should we refer the patient to a surgeon for an anti-reflux fundoplication? The refractory GERD can be seen in up to 5 to 10% of all patients who present to us with GERD. It's important because this condition is often associated with poor quality of life, psychological impairment, and poor sleep quality. So when you look at the types of refractory GERD, it can be broadly classified as truly refractory GERD and refractory reflux symptoms. You call a patient to have truly refractory GERD when you confirm the objective or you have a conclusive evidence of reflux in the patient, and on your therapy there is incomplete suppression of ongoing reflux. On the other hand, refractory reflux symptoms can be due to truly refractory GERD, or symptoms might not be related to reflux at all. So these symptoms might all be functional without any organic cause. So you need to start off with meticulous clinical evaluation. That patient has adequate lifestyle modification. You put the patient on lifestyle modification. You check the drug compliance and timing. PPI should be strictly taken 30 to 45 minutes before meals in empty stomach. You need to look for overlap with other functional GI disorders such as irritable bowel syndrome, functional dyspepsia, because presence of these overlap syndromes will make your treatment difficult. You should also inquire about nocturnal symptoms, extracerebral symptoms, and you should also ask the patient about any red flag signs or alarm symptoms. So the most important investigation that you do for any patient presenting with GERD is endoscopy. In endoscopy, you look at the grade of esophagitis, hiatus hernia, Barrett's esophagus, and peptic stricture. So on endoscopy, you can have on one extreme a totally normal esophagus with no erosions or ulcerations. This is often found in patients with refractory GERD. But on the other extreme, you can find an esophagus with severe extreme ulceration. You can see here the entire circumference of the lower end of esophagus is ulcerated. So when you find a esophagus like this one on the right side of the screen, you can be pretty sure that patient is having ongoing acid reflux. You can also switch on the narrowband imaging in your scope and look for dilated intercellular spaces. So when a patient has severe esophagitis, what we call as Los Angeles classification C and D, then you can be pretty sure that this patient has pathological acid reflux and he does not require any other acid studies to prove that patient has acid reflux. So when you look at the causes of refractory GERD, they can be reflux related or non-reflux related. Reflux related most commonly include residual acid reflux, that is your PPIs are not able to completely suppress the acid secretion. It can be because of non-acid or alkaline reflux, that the PPI is able to suppress the acid secretion, but the residual non-acid secretions or the alkaline secretions are refluxing into your esophagus. It can be because of nocturnal acid breakthrough in night times. At the night time, the gastric pH can drop below 4 for more than 1 hour, and during this time they can have acid reflux into the esophagus. Other causes of refractory GERD include non-reflux related causes. These most commonly include functional chest pain, functional heartburn, and esophageal motility disorders. So the most important investigation that we have in our armamentarium for investigating patients with refractory GERD is ambulatory reflex monitoring, what we commonly call as 24 hours pH metry. So if you look at indications of reflex monitoring, who should undergo this investigation? These include PPA refractory GERD, those patients who have atypical GERD, any patient before sending to a surgeon for fundoplication, you need to get reflex monitoring done to be sure that patient is really having reflex. So in pH metry, what you really look at is acid exposure time, reflex episodes, and reflex symptom association. That is, those symptoms that patient is experiencing, whether they are really related to the acid reflux or not. So what we have for reflex monitoring are these four, but the gold standard for reflex monitoring at present is combined multi-channel pH and impedance monitoring. So this technique combines both pH metry as well as impedance testing. Using pH metry, we can look at the esophageal acid exposure time, what we call as AET. It also combines impedance technique. Impedance is nothing but it will measure the reflex as a gaseous reflex or a liquid reflex, and if it is a liquid reflex, it can classify whether the reflex episode is acid or non-acid. So I am not going into the detail of impedance testing. You also can look at reflex symptom association when you do a 24 hours pH metry. As I told you, that you can really assess whether the symptoms of the patient are they really related to the acid reflux or non-acid reflux episodes or not. So how do you interpret pH impedance study? So when a patient has acid exposure time of more than 6% in 24 hours, it means the patient has a conclusive evidence of pathological acid reflux. If your acid study, if your acid exposure time is normal, you look at the number of reflux episodes. If the number of reflux episodes are more than 80, then it means that patient has GERD. So this is how a combination of pH and impedance testing is going to help you. So at the end of the pH impedance testing, you can classify the patients as true GERD, esophageal hypersensitivity, and functional heartburn. If a patient has positive conclusive evidence of pathological reflux, then you call the patient as having true GERD. If a patient does not have reflux, but he is symptomatic for the physiological reflux that he has, then his esophagus is sensitive to the physiological acid reflux the patient he has. So he actually has what we call as esophageal hypersensitivity. On the other hand, if a patient does not have any reflux and there is no symptom association with the reflux episodes, then he totally has a condition called as functional heartburn. So before doing pH metry, we commonly do esophageal high resolution manometry. This is to look at two things. One is the lower esophageal sphincter, other one is the esophageal body motility. So here is a representative image of esophageal high resolution manometry. So you look at the lower esophageal sphincter. What is the tone of the lower esophageal sphincter? Is it normal or is it lax, patulous, hypotensive? You can also assess the length of the hiatus hernia using esophageal high resolution manometry. You can also assess the patency of the motility of the esophageal body. If it's ineffective or weak peristalsis as shown in this picture, it means that even these kind of patients should not be referred to anti-reflux surgery. When you refer these patients to anti-reflux surgery, the failure rate in the post-operative period is very high. So if you look at the treatment of refractory GERD, it's broadly classified as medical, surgical, and endoscopic. Surgical management includes laparoscopic fundoplication, magnetic sphincter augmentation device. It's fairly a new technology. Endoscopic management includes radiofrequency ablation such as Stretta, transoral fundoplication such as Isofix, Gerdex, and TIF, and mucosal resection techniques such as anti-reflex mucosectomy or anti-reflex mucosal ablation, what we call as ARMS or ARMA. So once you know the exact pathophysiological mechanism behind refractory GERD, you classify these patients as having persistent acid reflux, non-acid reflux, esophageal hypersensitivity, and functional heartburn. If a patient has persistent acid reflux on PPA, what you do is you double the dose of PPA, you switch to a new PPA. You can also try newer long-acting PPAs which have a dual release mechanism. If a patient has predominant nocturnal symptoms, you can add a H2 blocker at night. If a patient has a large hiatus hernia and you expect an acid pocket in the hiatus hernia, you can even add alginate to neutralize the acid. If a patient has non-acid reflux, the options
Dr.
are very
Arun,
minimal.
how many minutes you have of your presentation left? It says 15 minutes on the presentation.
Prokinetics, they really not. They indirectly reduce the esophageal reflux by increasing gastric emptying. Baclofen can be tried in few patients, but it's often the therapy is interrupted because of side effects. Esophageal hypersensitivity and functional heartburn are often managed with neuromodulatory drugs such as tricyclic antidepressants and selective serotonin reuptake inhibitors, which reduce the sensitivity of the esophagus. When you refer a patient of refractory GERD or GERD to surgery or endotherapy for fundoplication, you need to look at the predictors of good outcome. If the patient does not have these predictors, kindly do not refer the patients or think twice before you refer the patient for surgery. So what are the predictors of good outcome? These include favorable response to PPA therapy. The patient should have at least a partial response to PPA therapy. Only then you can predict that patient might benefit from surgery. The patient should be having typical GERD symptoms. Surgery will improve only the typical symptoms. They are not going to help in atypical symptoms. The patient should undergo objective testing using 24 hours pH impedance to look for acid or non-acid reflux preoperatively. If the patient does not have objective reflux, kindly do not send the patient to the surgeon. The patient should have normal esophageal motility on high resolution manometer. If a patient has a weak peristalsis, then he is at a high risk of developing dysphagia in the postoperative period. So this is just the results of long-term results of laparoscopic fundoplication. Most of these patients develop improvement in their typical symptoms, but on long run, after 10 years, about 1/3 of these patients might develop relapse in their symptoms. So coming back to our case, the 38-year-old gentleman who had come with typical GERD symptoms with partial response to PPA, and he had a lax G junction on endoscopy. So what we do is we did a esophageal manometry. Esophageal manometry showed a very low pressure LES. He had an LES pressure of around 4 to 5, and he had a weak esophageal peristalsis. So for reference below, I have shown you the normal picture. This is how a normal esophageal peristalsis looks like, and this is what the patient had. So you can see here the peristaltic wave is broken and the pressure generated was very, very low. So what we call as DCI, the DCI was really low, less than 100. So this patient had a weak esophageal peristalsis with hypotensive LES. He also underwent 24 hours pH metry. Acid exposure time was normal. It was only 4.3%. The number of reflux episodes were only 55, and there was.
Can we stop the session here, please? As we're running over time.
So he was diagnosed to have functional heartburn and chest pain, and he was put on neuromodulatory drugs. The anti-reflux surgery in this patient is strictly contraindicated. What we need to do is we need to counsel the patient, explain the pathophysiology to the patient, and start him on neuromodulatory drugs. So I would like to end my presentation with my last slide. So when a patient comes with typical GERD symptoms, first you need to
Yeah, okay. Basically, I think the concept of having pre-recorded presentations is good. I thought that was the idea of having that will be make sure the speakers don't run over time, but that seems to have worked the other way in today's session. So anyway, we're running a little behind time. So over to Dr. Chalapati for the last topic of this session. And he'll be addressing the important topic of functional dyspepsia. Dr. Chalapati Rao did his MBBS from Visakhapatnam and then his MD and DM from PGI Chandigarh, after which he returned to Visakhapatnam and now he's senior consultant gastroenterologist at KIMS ICON. He is, to put it briefly, he's one of the leading figures of gastroenterology in the country. I think one of the few people from Andhra Pradesh who's recognized nationally. He has more than 45 national and international publications. He's a reviewer for many journals. He's an editorial board of journals, and he's a faculty at many national conferences. And as I said, I'm from the state of Andhra Pradesh. He's one of the few gastroenterologists who's recognized at the national level. And over to Chalapati for a talk on functional dyspepsia.
So thank you, sir. I would request you please stop the recording. I'll do it live. Okay. Can I share my screen?
We are seeing your screen.
Okay.
Again, it went back.
Organizers should unshare their screen. Otherwise, I can't share my screen.
Sure.
Or else you can run my recording, no problem.
Okay, if the recording is within time, we can run the recording.
Yeah.
Recording, please.
Yeah, please do that. Hi, good afternoon, everybody. My name is Dr. Chalapati. I'm gastroenterologist at Visakhapatnam. At the outset, I would like to thank the organizers at KIMS Medical College, Amlapuram, and I congratulate them for this wonderful meeting of AP State Chapter of APAPICON Annual Conference. The topic allotted to me by the organizers is on functional dyspepsia. So, it's quite a common disease. Just a second, my slides are not moving. Okay, so it's a type of functional GI disorder of gastroduodenal origin with prototypical symptoms of the epigastric pain and meal-related symptoms without any structural explanation. It is predominantly diagnosed based on symptoms, but unfortunately, it keeps coming back with a relapsing and remitting condition. So we often get a doubt: are we missing something? So are we dealing with the functional dyspepsia or with an organic dyspepsia? So that's the dilemma always we see when the patient is coming to us for the first time. But the reality is, it is the management and diagnosis of functional dyspepsia is quite challenging to every clinician, and it is often frustrating to the patient because they have to undergo multiple tests. It is highly prevalent in the community. Unfortunately, there is no highly effective treatment strategy. It keeps recurring in a relapsing remitting way, and there is no definitive diagnostic test. So when you find this kind of situation, what next? We keep testing further to evaluate the patient or refer this patient to a higher center, a gastroenterologist, or we try to understand the disease and start treating the patient. So let us see what is functional dyspepsia. Worldwide, uninvestigated dyspepsia is prevalent up to 20%, out of which functional dyspepsia, the prevalence is 5 to 16%. Almost 80% of any uninvestigated dyspepsia eventually turns out to be functional dyspepsia, meaning thereby there is no organic pathology. There are two subcategories in this: epigastric pain syndrome and postprandial distress syndrome. If you see the functional uninvestigated dyspepsia and you subject them for endoscopy, you see almost 72% are functional dyspepsia, meaning thereby they have normal endoscopies. Only 6% have peptic ulcer disease, some less than 0.5% have cancers, 1% have Barrett's esophagus, and almost 20% have erosive esophagitis. So functional dyspepsia is a big chunk in the uninvestigated dyspepsia population. Quite frequently, we see in prescriptions that patient is suffering from acid peptic disorder, peptic ulcer disease, etc. But without endoscopy, we cannot clearly say that if it is a peptic ulcer disease or not. And if we subject this whole lot of population, majority, that is more than 72%, they have normal endoscopy. Functional dyspepsia has a lot of overlap with other kind of functional GI disorders. For example, the gastroesophageal reflux disease can overlap in half of them. The prevalence of IBS is 8 times higher in functional dyspepsia than in general population. Other diseases like functional heartburn, psychological comorbidity, fatigue, fibromyalgia, overactive bladder, and other non-GI functional pain syndromes can coexist. Patients frequently suffer with somatization disorder. They can report multiple intolerances to drugs, and they can experience multiple atypical adverse events along with this functional dyspepsia. If you see the two subcategories, majority belong to the category of postprandial distress syndrome, that is up to 60%. 18% belong to epigastric pain syndrome, and 21% have an overlap between these two categories as well. So Rome 4 criteria was put upon in 2016, and functional dyspepsia is defined as one or more bothersome postprandial fullness, bothersome early satiety, epigastric pain, or burning sensation. And there is no evidence of structural disease on endoscopy, and the patient keeps suffering for the last 6 months with symptom duration onset at least 6 months before the diagnosis. Coming to the subcategory, postprandial distress syndrome, these patients, they suffer at least 3 days per week with a bothersome postprandial fullness, which impacts the usual activities, or bothersome early satiety, wherein they cannot finish their regular meal. The postprandial epigastric pain, the patients suffer with at least 1 day per week of symptoms with bothersome epigastric pain, which again impact the usual activities, and bothersome epigastric burning sensation, which can impact the usual activities. So these are the bloaters, these are the burners, as per the Rome 4 criteria. There are many risk factors which can be associated with functional dyspepsia, like female gender, smoking, history of NSAID abuse, H. pylori infection, obesity with high BMI, psychological comorbidity, especially anxiety and depression. Patients who have previous acute gastroenteritis are thrice more likely to have functional dyspepsia. Patients who consume heavy amount of fatty food, chilies, and carbs can have more prevalence of functional dyspepsia. So coming to the pathophysiology, it is complex. There is disorder in the gut-brain axis system. There can be stress, alteration in the corticotropin-releasing hormones. There is alteration in the neurotransmitters, which can change the pain processing. There will be associated somatization disorder. Frequently, there is history of childhood abuse associated with anxiety and depression. Along with that, there will be alteration in the bile acid pool in the paroxysmal small intestine, that is the duodenum. There will be alteration in the gastrointestinal microbiota, altered duodenal mucosal bacterial overgrowth, and overgrowth of pro-inflammatory bacteria. There can be altered duodenal-gastric reflux, duodenal eosinophilia is noted, subacute small intestinal bacterial overgrowth. There can be role of enteric pathogens. There will be rise in the intraduodenal acid and lipid concentrations, and coupled with visceral hypersensitivity as well. This can lead to duodenal immune alterations. There will be mucosal barrier dysfunction. Patients frequently report allergic and atopic background, leading on to mucosal hyperpermeability. This leads on to low-grade mucosal inflammation, and there can be altered enteric nerve function. And coming to the stomach, there can be impaired fundic relaxation. There can be associated H. pylori infection, visceral hypersensitivity, and patients can have delayed gastric emptying. So right from the brain till the duodenum into the stomach, there will be multifactorial pathogenesis, which is leading to functional dyspepsia, along with certain diet, especially the high FODMAP diet, and certain genetic polymorphisms involving GN beta 3 or ADR beta 2 genetic polymorphisms can be associated with functional dyspepsia and can lead to functional dyspepsia. So the same thing in a different picture. there is a genetic predisposition. It allows a lot of these pathogens and allergens to be presented to the APCs. There will be release of eotaxin, eosinophil activation. There will be enhanced Th2 cell response. There will be release of IL-4, IL-13. The B cell response is augmented. There will be release of pro-allergic IgE, eosinophil recruitment, further leading on to eosinophil degranulation, nerve infringement, nerve firing, and patients experience muscle contractions, cramps, and pains. Along with that, there will be increased epithelial permeability, which in turn leads to more pathogens and allergens entering the cell. Along with that, in the brain, because of the anxiety and stress response, there is disordered motility and visceral hypersensitivity, immune cell activation, pro-inflammatory cytokines will be increased, especially TNF-alpha, IL-10, and IL-1 beta, and that can lead to impaired gastric emptying. So all in all, the dysmotility type, that is the postprandial distress, it is predominantly because of the disruption of the fundal accommodation or delay in the gastric emptying, leading on to nausea, vomiting, early satiety, and weight loss. Epigastric pain gives ulcer-like syndromes and mediated by visceral hypersensitivity, and patients can experience epigastric pain and epigastric burning. So when the patient comes to your clinic, you will take the history. Especially, we need to concentrate on alarming symptoms like anemia, odynophagia, dysphagia, any previous GI bleeding, any previous endoscopy showing ulcer disease, patients having malnutrition, associated connective tissue disorder, bowel obstruction, and on examination, if there is any abdominal bruit, all these things point out to alarming symptoms. We need to be very careful. Unfortunately, there is no biomarker in the blood to detect the functional dyspepsia, and we usually go with a positive clinical diagnosis based on Rome 4 criteria discussed previously by me in the earlier slides. The common story is patients present to our clinic with bloating, satiety, epigastric fullness with meals, intermittent stabbing pain, especially in the epigastrium. Typically, they say that the symptoms begin with meal. Now, this is the difficulty that we start guessing that it could be peptic ulcer disease. But even without peptic ulcer disease also, even with normal endoscopy findings, these symptoms, it can happen in functional dyspepsia. Obviously, there should not be any vomitings. If there is any vomiting, it might indicate gastroparesis or gastric outlet obstruction, which we need to be careful of. The patient frequently comes to a gastroenterologist to us by saying, "Doctor, I had multiple endoscopes, ultrasound scans, they are all normal. So, but still I have symptoms. So tell me what's wrong with me." So that creates the difficulty. We need to concentrate if we need to get an endoscopy done. But as said, 80% they don't have any findings. But if there are persistent symptoms or alarming symptoms, it is worth to get an endoscopy done along with gastric biopsies, because that is the chance to diagnose any kind of H. pylori infection. But those patients where we don't subject them for non-invasive testing like endoscopy, H. pylori can still be detected by using stool H. pylori antigen test or urea breath test. And it is like test and treat policy. When it is tested for positive for H. pylori, we need to treat them. Gastric emptying studies, 25% have slow emptying. That's what studies say. But the yield of investigations is very low, and it is still recommended to have a positive clinical diagnosis to diagnose this difficult condition of functional dyspepsia in your clinic. Stomach and 2/3 of H. pylori, gastric pain, burning, interface between the enteric nervous system and the central nervous system. So if you come to the treatment algorithm, when you see a patient with epigastric pain, burning, satiety, or postprandial illness, just assess the alarming symptoms. If there are alarming symptoms, get an endoscopy done and treat in a relevant way if there is any organic disease. But if there are no organic alarming symptoms, then you test for H. pylori in high prevalent regions by using urea breath test or stool antigen test. Remember, you need to stop the proton pump inhibitors for at least a week. And if it is positive for H. pylori, then give eradication therapy at least for 10 to 14 days. Please don't give it for 7 days. If the H. pylori is less prevalent, then you see if it is a postprandial distress syndrome, then you add prokinetic drug like ecosamide or itopride or levosulpiride or domperidone or metoclopramide. And if you succeed, then stop the medications in 3 months. But if you don't get relief, or if it is not a postprandial distress syndrome, then you start adding acid suppression therapy, typically proton pump inhibitors, for a period of 4 to 8 weeks, and then stop the drug in 3 months. But if they don't respond, then start thinking of adding of tricyclic antidepressant like amitriptyline for at least 3 months. And if patient still doesn't respond, then consider adding psychological therapy or complementary or alternative therapies. Use more than one drug. So that's how you treat and approach these patients. So a word about H. pylori. You need to treat at least 7 patients of functional dyspepsia to get relief after eradication of H. pylori. The first line treatments are many. Typically, they are given for 10 to 14 days. And there are many combinations. The efficacy ranges between 80 to 90%. You should confirm eradication all using urea blood test or stool H. pylori antigen test at least 4 weeks after the treatment of this course. But the daily dilemma is you have given proton pump inhibitor, you have eradicated H. pylori, but patient still doesn't respond. Now the biggest question, what's next? So there are many treatments beyond H. pylori and proton pump inhibitors like antipsychotic drugs, tricyclic antidepressants, mirtazapine, H2 receptor antagonists, standard dose proton pump inhibitors, domperidone, itopride, tegaserod, ecosamide, high dose PPI, mozapride, and other antipsychotic drugs like SNRIs, SSRIs, etc., and 5-HT1A agonists. Some show benefit, some show no benefit over placebo. So typically we start with tricyclic antidepressants, especially in patients with moderate to severe symptoms, because they can alter the visceral and somatic perception, and symptoms improve without altering the sensation of gastric distension. There is improvement in global symptoms and pain. There is more improvement in epigastric pain syndrome than postprandial distress syndrome. Amitriptyline at a dose of 50 milligram improves almost half of these functional dyspepsia patients, and this is much better than escitalopram or placebo. Fundic relaxant, especially it improves the fundic accommodation, especially the buspirone. It is a 5-HT1A agonist. It is given at a dose of 10 mg 3 times a day, 15 minutes before meals. It increases the gastric accommodation by 60%, improves the postprandial fullness in almost 41% above the baseline, improves bloating in more than 1/4 of patients from baseline, and it may also work in those patients with rapid gastric emptying. Drugs like mirtazapine, it is a 5-HT2C antagonist and 5-HT3 agonist. It is given at a 15 milligram dose per time. It improves early satiety, nausea, and it can also cause at least 4 kilo weight gain at the end of 8 weeks. Prokinetics are used especially in patients with postprandial distress syndrome, in patients with bloating, etc. Like in this study, they have reported the benefit of cisapride and metoclopramide for a period of 4 weeks, and the benefit is lasted 2 weeks post-treatment also. So it has after effect. Prokinetics can be used. What about rifaximin? 400 milligram 3 times daily for 2 weeks. People have shown significant response at 8 weeks, 78% versus 52% versus comparing to placebo. It improves global symptoms, belching, as well as bloating. You can modulate the fundic accommodation in the stomach by using sumatriptan before a test meal in like tested in 14 healthy volunteers. It is a 5-HT1 agonist. It can augment the fundic accommodation. It delays the gastric emptying. It improves the bloating, discomfort, fullness, and nausea also. Behavioral therapy, multiple randomized trials, and this is one of the meta-analysis which favors the benefit of psychotherapy and cognitive behavioral therapy in patients who are suffering with functional dyspepsia refractory to above treatments. A word about complementary and alternative medicine. There are a lot of herbs, peppermint oil, milk thistle, diurnal release of menthol, caraway oil, etc., especially in those patients with severe symptoms. Capsaicin is used. It inhibits C-type nociceptive fibers, improves the pain. Acupuncture was also tried 5 sessions in a week with significant improvement in these symptoms. So the tips, postprandial distress syndrome, which are refractory to proton pump inhibitors, prokinetics, H. pylori eradication, try adding buspirone 10 milligram 3 times daily before meals, which augments the fundic relaxation, and also mirtazapine up to a dose of 15 milligram bedtime, especially in those with malnourishment and weight loss. Epigastric pain syndrome, amitriptyline 10 milligram bedtime and increase it as tolerated up to 50 milligram helps in patients with this kind of subcategory of patients. Adjunctive therapy like complementary and alternative medicine, behavioral therapy, cognitive behavioral therapy, psychotherapy may also be useful. So my last slide, take home message. The functional dyspepsia is a very common condition with negative endoscopy. Please be aware of it. There are a lot of overlaps with functional dyspepsia. There are a lot of overlaps with other functional GI disorders. There will be central neuromodulation, duodenal eosinophilia, mucosal inflammation, visceral hypersensitivity, impaired funding relaxation, and also psychosocial comorbidity in these patients. Treatments exist beyond proton pump inhibitors and H. pylori eradication, especially tricyclic antidepressants, mirtazapine, buspirone, and cognitive behavioral therapies, psychotherapies, and there are many complementary and alternative medications. So thank you all for the patient listening.
Thank you. I think we've kind of finished our time. The idea of having pre-recorded sessions was I expected the speakers would finish definitely in 15 minutes, but I was surprised to see that both of them had recorded their sessions for 20 minutes, which means they have used up their discussion time also. So anyway, I'll just think with the organizer's permission, I'll use the balance 2 minutes for just a couple of questions for anybody. So we'll give the priority to Shravan since he finished about 2 or 3 minutes before his time. Shravan, can you quickly highlight fecal calprotectin, which I think might be new for many physicians, what exactly it is and why exactly it's useful? Unmute yourself, please.
It is a protein in the stool, sir. Actually, the cutoff value should be less than 50 micrograms per gram of feces. If the patient is having less than 50 micrograms per gram, then definitely this patient is not having IBD. But one specific point is any recent GI infection, this fecal calprotectin can be spuriously high. And also in patients on NSAIDs, because of this ulcer, this fecal calprotectin will also be high. So whenever a patient is having high fecal calprotectin with diarrhea, we should take about the drug history and recent GI infection. If both of them are negative, then you can think about diagnosis of IBD in this patient.
Yeah, the point is fecal calprotectin comes from mucosal neutrophils. So that is important. So that indicates a kind of subclear, even if non-visible mucosal inflammation, and which will useful in distinguishing irritable bowel and functional and organic inflammatory disorders. And one more point, I think in Paris females, anal sphincter dysfunction is pretty common and often misdiagnosed as irritable bowel. I think a rectal examination is part and parcel of primary evaluation of every patient with diarrhea. And one comment I'd like to make on the side effects with H2 5-HT4 antagonists. These should be titrated based on symptoms. See, most of the times in clinical trials, they give fixed doses daily. So even if the patient gets constipated, the patient continues to take the drug as part of the trial. So that should be avoided. All our functional drugs for functional disorders should be titrated to the patient's symptoms, not given as a fixed dose. I think that is an important point to convey. And how would you distinguish irritable bowel syndrome diarrhea with chronic diarrhea, functional chronic diarrhea? I think that point also should be conveyed.
Yeah, functional chronic diarrhea and irritable bowel, both the symptomatology is almost similar. But these functional diarrhea patient will not be having any pain abdomen, and that is not related to any defecation. They present with only diarrhea rather than pain abdomen or abdominal cramps.
I think that's an important point, that pain distinguishes irritable bowel from functional constipation or functional diarrhea. And the Bristol Stool Form Scale defines the constipation or diarrhea, not the patient's definition. I think that's another point that should go across. Chalapati, I mean, I know H. pylori is a tricky topic, but you still recommend diagnosing and treating H. pylori in all patients with functional dyspepsia, even if the endoscopy, assuming the endoscopy is normal? In India.
Yeah, especially in pain predominant patients, I think we need to consider testing for H. pylori. If it gets positive, I think we need to treat that.
I mean, I should be selective. I don't think it
should be selective. Especially pain predominant.
Yeah. Dr. Arun, just one question. Most of the time we do pH testing to diagnose the presence of reflux. That is, we ask the patient to stop PPI and then you do the 24-hour pH testing to see whether the patient has true acid reflux or not. Is there any situation that you would think that you would do pH testing while on treatment?
Yes. So if you have a conclusive evidence of GERD, the patient has typical symptoms and there are telltale signs of GERD on endoscopy. For example, you have a severe reflux esophagitis. You start the patient on PPI and you don't have adequate response on PPI, then you do a PH study on PPI to see whether your PPIs are really working or not, whether your PPIs are able to suppress the acid or not. So that's the only situation where you do on PPI. Otherwise, as routine, we do it off PPI.
And a quick comment on the role of prokinetics in patient management of GERD.
No, I would say strictly no to prokinetics in GERD because prokinetics do not act on esophagus. They do not act on the lower esophageal sphincter. It will only improve GERD symptoms by increasing gastric emptying. So that will be my take on prokinetics. Kindly do not misuse prokinetics because they are all they should be given on short-term basis, and long-term basis you will end up having all sorts of complications such as neurological
side effects and other things. Thank you. With that, I think we'll hand over to the. Do we have 2 more minutes? I think we
go ahead, sir. Go ahead.
Oh yeah. Okay, then. Thank you. Then Shravan, would you also comment on how do you go about FODMAP avoidance? I mean, I think just giving the patient a list of things to avoid is not the answer. So how would you counsel patients about which foods to eat and not?
Yeah, actually, I will show the FODMAP diet chart, and I will specifically ask the patient to avoid these foods for at least 6 to 8 weeks. And after that, based on the symptoms, I will slowly introduce one particular type of food, and we can able to selectively see with which food the patient is having intolerance to specific carbohydrate. And based on that, we can reintroduce all the FODMAPs.
Yeah, I think that's an important thing to understand, that you shouldn't just give that paper to the patient and say avoid these. That's not the point. Either the patient should be able to recognize what foods suit gives them triggers symptoms or not, or you should go through the exercise of avoiding everything and reintroducing and seeing, then trying to identify. So any other questions in the box? Okay, I mean, there are many points that would come up in day-to-day management. In optimization of PPIs, would you think that we have to change the PPI, Dr. Arun?
So it all depends on the response the patient has.
No, if the patient appears not to be responding and you want to optimize the PPI therapy, then in what situation would you like to change the PPI also, apart from adjusting the time and other factors?
Yeah, first we need to look at the compliance. The timing of the PPI, whether the PPI is the usual PPI that you are using, or nowadays people are coming up with dual release PPIs and long acting PPIs and all those things. So whatever might be, PPIs are really, they are very good drugs. The usual PPIs, they heal off the esophagitis remarkably in 4 weeks to 8 weeks period. But if patient continues to have symptoms even after 8 weeks of PPI, in addition to an endoscopy, I think ideally 24 hours pH study should be done to that patient before switching on to other therapy or optimizing therapy for these patients.
Yeah, I think the timing of PPI is extremely important. Most patients tend to just take the PPI first thing in the morning and then forget about having anything to eat. We should understand the pharmacokinetics and pharmacodynamics, what happens once the PPI is absorbed, and again, when it is released, where it is released, when does it come into the circulation, when does it reach the parietal cell, when does the food stimulate the acid secretion, and you have to ensure that the time that the food is stimulating the acid secretion is also the time that the PPI is acting at the parietal cell, and it has reached the parietal cell and acting. It is, we have to understand first that, and then we will be able to explain to the patient exactly why and when he should take the PPIs. But most of the time with modern, at least pantoprazole, rabeprazole, esomeprazole, I think they are all equivalent, probably only with omeprazole. If the patient has been taking, one might try it because of slight differences in bioavailability and metabolism. It may make a case for changing omeprazole to a newer PPI if the patient has been taking omeprazole. But in most of the studies, once the patient is enrolled in the study and has been advised to take the PPI correctly, often it starts working, even though it appeared not to be working in the earlier practice. Okay, with that, I think we come to the end of this session. Yes, we have a question from sir. Can you unmute yourself? Yes, sir.
Yes, I'm audible, sir.
Yes, yes, go ahead.
Sir, my question relates to GERD and intervention. At what stage of refractory GERD intervention is done? I am late to tune in, sorry. At what stage of refractory stage or unresponsive GERD? That means the real indication for intervention is GERD.
Yeah, that's a good question, and it's a whole topic by itself. Arun, would you just address that briefly? When would you recommend, on basis of objective indicators, a patient to go for either endoscopic therapy or fundoplication?
So by definition, the refractory GERD is diagnosed at the end of 8 or 12 weeks after starting therapy. But in real practice, we rarely see a patient undergoing fundoplication or some endoscopic application after 12 weeks. It's generally like the patients, they present to us with these kind of symptoms, and they have been taking PPI for quite a long time. So usually we see patients taking PPI for 2 years and 3 years, and they come and say that like the symptoms, they really don't improve. So the first thing, if you ask me, like we need to assess them whether they are really having GERD or not, because see, the refractory GERD forms a very small proportion of all GERD patients. The truly refractory GERD, that they are not going to respond to any kind of therapy. They are only 5%. They are, I think it should be less than, studies have shown 5 to 10%. It's only 5% of all the patients who come to us with refractory symptoms. Usually the patients who are referred for a fundoplication are those who are on long-term PPIs and they are not willing to take PPIs. They are all PPI responders. They are all PPI responders, but after taking it for 2 to 3 years, they say that we are not ready to continue, or we will not continue PPIs in our future. So those are the patients who are usually referred to surgeon for fundoplication. But if you look at truly refractory GERD, I think we need to look at the pathophysiology behind these symptoms. So that's why I have stressed a lot on pH metry. Do a pH metry and see. What I often find is that these patients mostly have esophageal hypersensitivity or functional heartburn. So these are the patients you should never refer to a fundoplication.
Yeah, I would just like to reiterate that in many studies, failure of medical therapy has included patients who, as Arun said, just reluctant to take PPI. As far as I'm concerned, those patients don't need referral for surgery, they need counseling. Because if you look at the balance, the risks of continuing PPI, you would address the risk as to why the patient does not take fear of PPI. There are really no side effects of PPI. That it's also listed as cost of PPI, which is ridiculous in our country. So all these are form indications for surgery and intervention in Western studies, which I don't think really applies for us. Fear of PPI, reluctance to take PPI, cost of PPIs are really not an indication for surgery or intervention. They are like an indication for us to counsel the patients better and explain to them why they need to take PPIs, titrate the dose accordingly. And frankly speaking, as Arun said, if the patient does not respond to high dose PPI, he also will not respond to fundoplication, because that is the kind of patient who has a kind of symptoms which are not PPI responsive. You're doing the same thing. You're substituting the PPIs for the procedure. That is, they are interchangeable. So the 2 doses of PPIs are not giving relief of symptoms. Often they have other problems. So it is extremely rare to find a patient who has refractory acid reflux after 2 doses of PPI daily and going to benefit also from fundoplication or endoscopic therapy. So that's a very, very rare situation. Thank you. I think on that we'll end this session. Thank you very much for to the organizers for allowing us also to run a little over time into the discussion part. And over to the organizers, please. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Thank you, the panelists and the chairperson, for an excellent session. We have benefited a lot from your discussion and from your moderation and the various topics which are of interest to us, the practice physicians. Thank you, sir. Thank you, one and all. Now for the last session of the day, the final event of the day, Sripada Lakshmi Narayana Murthy Memorial Award Paper Session. Right? The cash awards for which have been sponsored by, or being sponsored by Dr. S.V. Ramanamurthy, Professor of Medicine, GSL Medical College, Rajahmundry, in memory of his father. The award committee has selected the following specific papers for final live presentation to be evaluated by the panel of judges. Our judges are: 1. Dr. Srinivas, Professor and Head of the Department, Andhra Medical College, Vizag. Second judge, Dr. T.V. Narayan Rao Garu, the Senior Consultant Physician of Vijayawada. The third judge, Dr. M.T. Abdul Razak, Professor and Head of the Department, Fatima Institute of Medical Sciences, Kurnool. And the shortlisted papers are by what? Meduri Sai Praval.
Sir, unmute yourself, sir.
Oh, yes. Meduri Sai Pravalika Santoshini from GEMS Srikakulam. Vakamula Rashmita from Rangana Medical College, Kakinada. Mundla Dharanidhar Reddy from Nellore Medical College, Narada Medical College, Nellore. Kanna Gopi Verma, Katuri Medical College, Guntur. Akshintala Kavyala Hare, Kurnool Medical College, Kurnool. Molugu Samhita from Government Medical College, Kadapa. These papers by these 6 contestants have been shortlisted for final award presentation. Now, I hope all the judges are online, logged in.
Okay.
Dr. Srinivas Garu, yes, I can see his that he's logged in. Dr. Narayan Rao Garu, yes, and Dr. Abdul Razak, yes. Thank you very much, sir. The judges. Now the contestants. 1, 2, 3, 4. I could see. I'm able to see only 4 people here. Pravalika, Dharanidhar Reddy, Samhita, Kavyamani, Rashmita. One more person, Gopi Verma. Gopi Verma, can you log in, please? Please raise hand. Reaction. Dr. Gopi Verma, please raise your hand. I can see you if you are over here. Okay, I think I hope that he'll join us shortly. Now for the judges, sir, the judges, sir, you have the evaluation forms with you. A maximum of 60 marks for each candidate. Independently you can evaluate, and finally by WhatsApp you can intimate us the results of your evaluation for all the candidates. We will total up all the marks and announce the prizes for the candidates. Right? Thank you, sir.
Sir,
now the first presentation. Sir, Chappan, sir.
Again, evaluation for Markin Raleigh, sir.
Raleigh, sir, you'll get it within. You'll get it within 1 minute by WhatsApp. Evaluation form, right, sir? You can just write down on the paper and send. I mean, don't need the form need not be sent to us. Sir. Just tell us the marks that you have got.
Yep.
Now for the first
marks and send by WhatsApp, sir.
Yes, sir. Or you can say, tell it online to me. Online, you can tell it to me. I'll make a note of it. Yes, sir? Okay. Okay, sir. Right now for the first presentation by Meduri Sai Pravalika Santoshini from GEMS Srikakulam.
Yes, sir. Good afternoon, sir.
Full screen, please.
Sir, am I audible, sir?
Yes, you are.
Yes, sir. Can I share the screen now, sir?
So, judges, please start your video.
Hello.
So, Narayana sir also.
Pravalika, you can start.
Yes, sir. Good afternoon, one and all. I'm Dr. Pravalika Santoshini, second year General Medicine PG from GEMS Srikakulam. I'm going to present paper on a prospective observational study of acid-base disorders in organophosphorus poisoning in a tertiary care center. Coming to introduction, pesticides include a wide variety of compounds which include insecticides, herbicides, fungicides, and others. There are more than 1,000 active substances in approximately 35,000 preparations. Organophosphorus poisoning is a serious hazard. Farmers are at higher risk for accidental exposure to organophosphorus poisoning as it can be absorbed from ingestion, inhalation, and tropical route. Of course, most common route is by ingestion. However, poisoning with suicidal intent is more common than accidental exposure. Intentional ingestion of organophosphorus pesticides has been common for the past 40 years. A fatal outcome is often related to delay in diagnosis or improper management. OP poisoning compounds are available as dust, granules, or liquids. They are well absorbed from the lungs, GI tract, skin, mucosal membranes, and conjunctiva following inhalation, ingestion, or tropical contact. Peak levels of most organophosphorus compounds appear around 6 hours after oral ingestion in man. Exposure to OP vapors rapidly causes upper airway irritation and bronchospasm, followed by systemic symptoms. Acute respiratory failure is the most common cause of death in OP poisoning due to increased secretions and inadequate ventilation. One of the causes for complications is an acid-base imbalance. Subsequent measures must be carried out by recognizing and correcting the acid-base disturbances at the earliest possible time. Evaluation of acid-base status in the OP poisoning patients plays a crucial role as it is early recognition can alter the management and prognosis. Aim of the study is to access the arterial blood gas analysis as a prognostic tool in OP poisoning patients. Coming to materials and methods, it is a prospective observational study was conducted among 50 patients presented to emergency department at Great Eastern Medical School and Hospital, Srikakulam from October 2020 to June 2021. All routine blood investigations like renal function test, liver function test, random blood sugars, complete blood picture, ECG, along with plasma cholinesterase levels and ABG were done at the time of admission. Coming to inclusion criteria, age more than 18 years, clinical features suggestive of organophosphorus poisoning, suggestive organophosphorus compound consumption as per relative, patient, referring doctor, and pesticide container, and who have given consent for participation in the study. Exclusion criteria, any mixed ingestions, time of consumption more than 24 hours, comorbidities like chronic kidney disease, chronic liver disease, chronic obstructive pulmonary disease, and congestive heart diseases. Coming to results, most number of patients who were consumed organophosphorus compounds were found to be between 20 to 40 years, which were 60% of the total number. The next significant group was 40 to 50 years, which had 7 patients. Males, 64% were the more predominant group in OP ingestion in this study. This is a graph showing age distribution where x-axis shows the age distribution, whereas y-axis shows the number of patients. The most prominent group was 21 to 30 years, where 20 patients were reported, whereas 31 to 40 years, 13 cases were reported. Of total, 33 cases among 21 to 40 years of age. Next predominant age group involved were 41 to 50 years, which were 7 patients. And there were 5 patients of organophosphorus poisoning noted less than 20 years of age, and 5 patients more than 50 years of age. This is a graph showing acid-base analysis and patient outcome, where the x-axis shows the acid-base disorders, whereas y-axis shows the number of patients. Among this, there were about 8 cases where there were normal arterial blood gas analysis. Of 50 cases, there were 5 cases reported with mixed acid-base disorders with 1 death reported. Among 12 cases of metabolic acidosis, 4 deaths were reported. Among 9 metabolic alkalosis, no deaths were reported. Of 6 cases, 2 deaths were reported in respiratory acidosis, and of 10 cases, 1 death were reported in respiratory alkalosis. Of 50 cases, 18 cases require invasive ventilation, and out of 50 cases, 42 patients recovered and 8 deaths were noted. Discussion. The diagnosis of organophosphorus pesticide poisoning is based on patient's history, clinical presentation, and lab investigations. In a patient with positive history, a typical order on the blood and characteristic symptoms, decreased RBC and plasma cholinesterase levels, it's not difficult to make out the diagnosis. Most of the patients presented to emergency department within 1 to 4 hours of ingestion. Most of them had received gastric lavage in the pre-hospital care setup. Serum cholinesterase levels were lowered in most of the cases. In organophosphorus poisoning, these organophosphorus compounds inhibit acetylcholinesterase activity and thereby decreasing acetylcholine degradation, increasing the accumulation of acetylcholine in the synaptic gap, thus leading to increased cholinergic symptom, disturbing neurotransmission of the central and peripheral nervous system. This excess synaptic acetylcholine stimulates muscarinic receptors and then depresses or paralyzes nicotinic receptors. Abnormal neuromuscular transmission mediated through nicotinic receptors may induce carbon dioxide retention and alter the acid-base balance. Retrospective analysis of various studies on opioid poisoning patients found a direct correlation between the severity of poisoning, mortality, and the presence of pretreatment acidosis, either metabolic or respiratory. Thus, the present study showed that among the acid-base disorders in the initial ABG and opioid poisoning, acidosis was associated with increased morbidity. Among the acidosis, metabolic acidosis is predominantly associated with morbidity, followed by respiratory acidosis and followed by mixed acidosis. Metabolic alkalosis and respiratory alkalosis were associated with decreased morbidity and less deaths were reported. Arterial blood gas was drawn from acid-base analysis. Around 76 cases had acid-base disturbances, whereas 24 had normal ABG reports. According to Maulali et al., a study conducted in Chennai, involved 20 cases, 85% has had acid-base disturbances and 15% had normal ABG reports. Conclusion. The present study highlights the importance of arterial blood gas analysis as an effective tool in quick assessment of prognosis in opioid poisoning patients. Special consideration should be given to patients presenting with acidosis, as it is concluded from this study. Predominantly, metabolic acidosis is associated with increased morbidity and mortality. As a result, the treatment can be intensified and implemented quickly without any delay. These are my references. Thank you.
Thank you, Sai Pravalika Santoshini.
Good
Now
afternoon.
for the second presenter, Vakamullu Rashmita from Rangana Medical College, Kakinada. Rashmita.
Good evening, sir. Am I audible, sir?
Yes, madam, you are audible. You can start your presentation.
Yes, sir. Sir, is my screen visible, sir?
Yep. Go ahead.
Good evening, everyone. I'm Dr. Rashmita, and I would like to present my paper on postprandial hypertriglyceridemia as a risk factor of
Just a minute, madam. I request Dr. Abdul Razak sir, the judge, to show the video, unmute, show video. Okay, madam, go ahead.
I would like to present my paper on postprandial hypertriglyceridemia as a risk factor of macrovascular complications in type 2 diabetes mellitus. Starting with the introduction, diabetes mellitus is a common endocrine disorder characterized by chronic hyperglycemia and disturbances of carbohydrate, fat, and protein metabolism. The prevalence of diabetes has been increasing widely in India and worldwide. Diabetes is a cause of significant mortality and morbidity due to its macro and microvascular complications. Dyslipidemia accompanying type 2 diabetes mellitus plays an important role in the pathogenesis of atherosclerotic vascular disease. The most important components of dyslipidemia are an elevated VLDL, LDL, triglycerides, and decreased HDL. The response to injury hypothesis of atherosclerosis states that the initial damage affects the arterial endothelium, leading to endothelial dysfunction. It has been hypothesized that hypertriglyceridemia induces endothelial dysfunction through the production of oxidative stress. Postprandial hypertriglyceridemia, irrespective of fasting triglyceride levels, has emerged as a significant risk factor for symptomatic and asymptomatic macrovascular disease. Increased serum triglyceride levels are associated with at least 4 pathogenic conditions, which include decreased serum HDL cholesterol levels, increased remnant lipoproteins, increased LDL, and increased thrombogenesis. In the insulin-resistant state, the production of VLDL is increased, and there is reduced lipoprotein lipase activity, which results in high triglyceride concentrations. The large amount of triglyceride-rich lipoproteins and the prolonged residence time in the circulation may lead to increased exchange of the poor lipid cholesterol ester for triglycerides. This process enriches the LDL and HDL with triglycerides, and these particles are subsequently more readily hydrolyzed by the hepatic lipase, resulting in smaller, denser LDL particles and lower concentrations of HDL. Coming to the materials and methods, this study was a case control study conducted for a period of 1 year on 100 patients visiting the outpatient department of Government General Hospital, Kakinada. Patients with duration of diabetes mellitus more than 1 year were included, and individuals without diabetes or their complications were taken as controls. Patients on lipid-lowering agents, patients with history of inherited disorders of lipid metabolism, and with history of endocrine disorders affecting lipid levels were excluded. Diagnosis of diabetes was made on the basis of American Diabetes Association criteria, which includes fasting plasma glucose more than 126 mg per deciliter, 2-hour postprandial glucose levels more than 200, and hemoglobin A1C more than 6.5%. The presence or absence of macrovascular complications was made on the basis of the following: clinical features suggestive of macrovascular events, electrocardiogram, echocardiogram, and ankle brachial index. After the diagnosis of type 2 diabetes mellitus and its complications was made, patients were divided into 3 groups. Group 1 included controls, Group 2 includes type 2 diabetes cases without macrovascular complications, and Group 3 includes type 2 diabetes cases with macrovascular complications. All the selected patients were subjected to a high-fat meal, which consisted of whipped cream. For lipid analysis, blood samples were collected after 8 hours of fasting, 2 hours and 4 hours of postprandial state. Serum was separated, and from the serum, total cholesterol, HDL, and triglycerides were estimated. From the above values, LDL cholesterol was estimated by using Treadwell formula. The information collected regarding all the selected cases were recorded in a master chart and data analysis was done. A p-value less than 0.05 is taken to denote significant relationship. Coming to the results, the total number of patients included in this study was 75 and 25 controls were included for comparative analysis. Among the total of 75 diabetic patients, 50 patients had no evidence of macrovascular complications and 25 patients had evidence of macrovascular complications. The male to female ratio was 3:2 in all three groups, and there was no statistically significant age difference among the 3 groups. The fasting and postprandial blood sugar values were analyzed in all the 3 groups. The mean fasting plasma glucose value was in group 1 was around 81.1 milligram per deciliter as compared to 128.5 milligram per deciliter in group 3. On the other hand, 2-hour postprandial glucose values in group 1 were 125.3 milligram per deciliter as opposed to 202.6 milligram per deciliter in group 3. The prevalence of hypercholesterolemia was more in group 2 and 3 than controls, and the difference was statistically significant. There was no significant difference in the HDL or LDL values between the 3 groups. Fasting triglyceride levels and post-flow triglyceride levels were analyzed. The mean fasting triglyceride levels in group 1 was around 121 milligram per deciliter as compared to 184 milligram per deciliter in group 3. The triglyceride values remained persistently elevated after 4 hours of giving a high fat meal. It was around 64% of the patients in group 2 had persistently elevated triglyceride levels and 84% of the patients in group 3 as compared to only 16% of the patients in group 1. The difference was statistically significant, indicating that postprandial hypertriglyceridemia may be more important in macrovascular complications than fasting levels. Hypertriglyceridemia at 4 hours after fat meal was compared between the 3 groups, and the results indicate that persistent hypertriglyceridemia at 4 hours post-load was seen more in patients with macrovascular complications as compared to the other 2 groups. Correlation between 4-hour post-load hypertriglyceridemia and blood sugar was analyzed. It was found that hypertriglyceridemia correlated significantly with both fasting and postprandial values. And the 4-hour postprandial hyperglycemia and hypertriglyceridemia correlated significantly in the presence of macrovascular complications. Mean cholesterol values were higher in patients with hypertriglyceridemia than in patients without hypertriglyceridemia. The 4-hour hypertriglyceridemia was compared with standard lipid ratios. Although there was no significant correlation between the triglyceride levels and the standard lipid ratios, the slightly higher ratios were seen in patients with hypertriglyceridemia. Coming to the discussion, this study was aimed to identify postprandial hypertriglyceridemia as a significant risk factor for vascular events in type 2 diabetes mellitus patients. Individuals with normal fasting triglyceride levels also exhibit varying postprandial triglyceride concentrations after a fatty test meal. Therefore, postprandial lipemia represents triglyceride metabolic capacity under challenge and is considered to be more informative for assessing the role of triglyceride metabolism in the development of atherosclerosis. In this study, fasting cholesterol levels correlated significantly with the triglyceride levels, and both were high in patients with vascular events. Another observation made in the study was that there was no significant difference in the LDL or HDL cholesterol values between the 3 groups. All the patients who had fasting triglyceridemia also had elevated postprandial levels, which is similar to the various studies in the past. It was found that postprandial triglyceridemia correlated better than fasting triglyceridemia with vascular events. There was also good correlation between fasting and postprandial blood sugars and postprandial triglyceridemia in patients with vascular events, similar to other studies in the past. It was also observed that while postprandial triglyceride abnormalities occur in type 2 diabetes mellitus patients, regardless of the presence or absence of macrovascular complications, the magnitude of abnormalities tend to be higher in those with macrovascular diseases, suggesting that higher postprandial triglyceride burden was associated with higher macrovascular diseases. However, the protocol for measuring postprandial hypertriglyceridemia needs to be formulated, and it is necessary to formulate precise guidelines on the time intervals for measuring postprandial triglyceride levels. The normal cutoff values have to be internationally standardized. If these guidelines are established, simple measurement of postprandial triglyceride levels and subsequent interventions may help to detect endothelial dysfunction in diabetes, thus elevating the mortality and morbidity associated with the disease. Finally, in conclusion, persistent and significant post-load hypertriglyceridemia was observed in diabetic patients with macrovascular complications compared to controls. Hence, it is a useful marker for predicting macrovascular complications. Postprandial hypertriglyceridemia was more significant than fasting triglyceridemia in complicated diabetes. Hypertriglyceridemia was observed independent of LDL, HDL, and standard lipid ratios. Detecting and correcting early postprandial hypertriglyceridemia with the help of a standardized fat challenge may be a useful therapeutic option in halting endothelial dysfunction and hence macrovascular complications. These are my references, and thank you.
Thank you, Rashmita.
Now
I request Dennis to ask a few questions. The
Can I
first
ask
two
a question,
candidates.
sir?
Yes, sir.
Yeah, definitely. That's what we want, sir. The first two candidates are finished.
Dr. Rashmita, the conclusion from your study seems to be that there is a definite relation between postprandial hypertriglyceridemia and macrovascular disease.
Yes, sir.
As we understand, macrovascular disease is a multifactorial etiology, isn't it?
Yes, sir.
Did you adjust for any co-founders in your study? There are many co-founders which can lead to macrovascular disease. How did you adjust for the co-founders, like presence or absence of hypertension, presence of or absence of smoking, presence or absence of other risk factors? Did you look into them and adjust for the co-founders?
Few of them I have done, sir. I couldn't adjust for many of them, sir. Like I calculated the BMI also, sir, but BMI was it was statistically insignificant, sir.
Okay. Is there any method to reduce the postprandial hypertriglyceridemia? We can reduce the hyperglycemia, isn't it? We can go for low glucose or anything that we can easily reduce it. But you said the postprandial hyperlipidemia itself is a risk factor for macrovascular complications. Is there any method to reduce this one? After
Sir, by decreasing the insulin resistance, we can target postprandial triglycerides, sir.
I don't think so. Because this is not a parameter which can be reduced in just a few minutes, just like glucose. It takes a very long time for hyperglycemia and hyperlipidemia to be controlled.
Okay.
Okay. Next speaker, sir. Next presenter, sir.
Subara, sir.
Sir, any questions to the first presenter, sir?
Yeah, if she's online, I would like to ask her one question.
Sir, good afternoon,
Dr.
sir.
Pravalika, you are there?
Sir, yes, sir.
So at the end of your presentation and your study, you have concluded that certain patterns as far as acid-base gas analysis,
Yes,
you can go more aggressively or more appropriate treatment. So what exactly you mean by saying that you can institute an appropriate treatment? I think a case of organophosphorus poisoning is always considered to be a medical emergency, isn't it?
yes, sir. Yes, sir.
Suppose if you see a patient with organophosphorus poisoning and then metabolic acidosis, what else you can do, or what did you do in your study population?
In our hospital setup, sir, once the patient has arrived, we have, along with the initial stabilization, we have sent ABG, sir, initially. Then we have seen according to ABG, we have divided the patient into acidosis. Sir, based on the ABG, we have done, sir. If there is metabolic acidosis, we have given the bicarbonate, sir. There is respiratory acidosis, we have gone for intubation, sir. Invasive ventilation, sir. And early intubation was done, sir. If the patient GCS is also poor, then also we have intubated this patient, sir.
I got another supplementary question for you, sir. Can I have one more?
Continue, sir.
I just want to know, did you find any association between the blood gas analysis and the incidence of the prolonged neuroparalytic kind of thing, intermediate syndrome? I think you might have heard intermediate syndrome.
Yes, sir. Yes,
which
sir.
can happen following organophosphorus injection. Did you find any relation between the incidence of intermediate syndrome and a particular pattern of acid-base disorder?
No, sir. I in my study I have not seen any correlation.
Did you look for any association?
No, sir.
That's all
I mean,
from
I
my
have-
side, sir.
Okay.
Okay, that's nice. That's okay. Dr. Srinivas, sir, please.
Pravalika,
Sir.
you said that the prognosis is good in patients with alkalosis rather than
Yes.
acidosis.
Yes, sir.
Do you think that we go and going on treating for producing alkalosis in the patients that are treating with atropine and pralidoxime? No, we are not doing that, isn't it?
Yes, sir.
So that is not the criteria, isn't it? So you mean to say that if you induce acidosis, alkalosis in these patients, the prognosis will be good.
Yes, sir.
That is
No,
not the
sir.
criteria for the patient.
No, sir. No, sir. In patients with acid-base disorder, along with the atropine and pralidoxime, initial correction, I mean, ABG disorders, whatever they may present, correction of that will give more, mortality and morbidity benefits, sir. Along with the atropine and pralidoxime, we have supplemented with acid-base disorder treatment, sir.
So in patients who doesn't have any acidosis, you won't induce alkalosis, isn't it? Right. That should not be done, isn't it? Okay.
Good one, sir. Good
Yes,
one,
sir.
sir.
Correct. Okay. Next speaker.
Next presentation, please.
Disorders.
Thank you. Thank you.
Hello, sir. Am I audible, sir?
Next speaker is Mr. Dharanidhar Reddy from Narayana Medical College, Nellore. Start your presentation, Dr. Reddy.
Good evening. Good evening, sir. Can you hear me, sir?
Yes, slide is visible. You are audible. Go ahead.
Yes, sir. Today's my topic is regarding the clinical profile and correlation of thrombocytopenia and splenic size with grading of esophageal varices in cirrhosis of liver patients, sir. And my co-author is Dr. M. Rajesh Kumar, Professor and HOD, Department of General Medicine, Narayana Medical College, Nellore, sir.
Go for a
Yes,
full
sir.
screen view, Dr. Reddy.
Yes, sir.
Okay.
Sir, give me a second. Coming to the introduction, sir, thrombocytopenia is a condition defined by the presence of low platelet counts in the circulation. It is the most common hematological abnormality encountered in the chronic liver disease patients. It has been reported in 64 to 84% of patients with liver cirrhosis or fibrosis with different etiologies. Portal hypertension is another significant and complex element associated with liver cirrhosis. It is involved in the development of splenomegaly, ascites, and gastroesophageal varices. Various studies demonstrated the correlation between the presence of esophageal varices, portal vein diameter, and the spleen size. These studies have reported that in cirrhotic patients with portal hypertension, risk for the development of gastroesophageal varices and grades of varices with increased diameter of portal vein by more than 12.25 centimeters. In summary, platelet count with spleen diameter ratio, fibrotest, and fibroscan are promising non-invasive methods in liver cirrhosis patients. However, a proper validation is required to predict their true role in correlation with thrombocytopenia and splenic size with different grading of esophageal varices in liver cirrhosis patients. Coming to the material and methods, all the patients admitted in the Department of Medicine and attending outpatient Department of Medicine and Department of Medical Gastroenterology of Narayana Medical College and Hospital during the period of November 2019 to October 2020, fitting into the inclusion criteria were included in the study. The inclusion criteria are as follows: patient with liver cirrhosis without any past history of upper or lower GI bleed, diagnosis of liver cirrhosis based on a combination of history, clinical findings, impaired liver function test, deranged clotting profile, and abdominal ultrasound. Coming to the exclusion criteria, patient with previous or present history of variceal bleed, patients on previous or current treatment with beta blockers, diuretics, or antiplatelet drugs, patients who have undergone sclerosis or band ligation of esophageal like tapes or surgery for the portal hypertension. Patients having fever associated with thrombocytopenia in the past and the history of fever in the past 15 days are being excluded, along with patients who are drugs are associated with thrombocytopenia. Coming to the cirrhosis of liver, cirrhosis is a progressive liver disease. It involves the deposition of scar tissues at the place of healthy liver tissues. Formation of scar tissues in the liver blocks the blood flow, resulting in decreased ability in liver desoxygenation and synthetic functions. Liver cirrhosis is an irreversible chronic injury of the hepatic parenchyma and extensive fibrosis and formation of regenerative nodules. The clinical features of cirrhosis are follows as jaundice, coagulopathy, edema, and variety of metabolic abnormalities. Distorted vasculature in cirrhotic liver leads to portal hypertension and severe sequential pathophysiologies, including splenomegaly and gastroesophageal varices. Moreover, hepatic encephalopathy and ascites result from the both portal hypertension and hepatocellular insufficiency. Coming to the results, the observation in the study related to the characteristic of the cases and controls, biochemical profile, and clinical abnormalities are analyzed in the study population of 50. 42 were males and 8 were females. This is the table showing the distribution of enrolled patients according to their age groups. Incidence of cirrhosis was highest in the age group of 30 to 40 and 51 to 60 years. This is the pictorial representation, sir, showing 31 to 40 years are 12 members out of 50 and 51 to 60 years are 12 members out of 50 patients. Coming to the gender distribution, mostly it is male predominant, sir. Out of 50 patients, 42 were males and 8 were females. Coming to the clinical symptoms, this is the table showing the majority of the patients presented with abdominal distension constituting 36%, followed with pedal edema and constituting of 24%. This is a pictorial representation regarding the various symptoms where we'll be having the mostly people of the abdominal distension. These are past histories are coming to the patients who had been with a previous history of any cholelithiasis or consumption of any compound and all those things where we are having this correlation. Coming to the distribution of cases based on the causes of cirrhosis. Among all the 50 enrolled patients, the cause of cirrhosis was found to be highest for alcoholism in 80% and non-alcoholic in 20%. Whereas generally in the literature, it is in the world when we conclude it is as the mostly alcohol is the most common cause, whereas in coming to the India, it is mostly hepatitis B virus. Coming to the clinical signs noted among the patients were almost commonly ascites, constituting 28%, and pedal edema along with icterus accounting for 20%. Coming to the distribution of cases, according to the presence or absence of encephalopathy, out of 39 patients are not having without any encephalopathy changes. Only 11 out of 50 are having the encephalopathy changes. Coming to the distribution of patients based on the platelet count, which our study includes the platelet count and the splenic diameter ratio. It is between the 50,000 to 1 lakh, and totally 22 patients accounting for 44% are having. Coming to the viral markers, they are negative. Out of 50, 47 were tested negative. Coming to spleen bipolar diameter, which is our the current study, a majority of the patients belonging to the category with spleen diameter, bipolar diameter between 100 to 200 mm, accounting for about 60%, followed by less than 100, accounting for 40% of the patients. Coming to the distribution based on the presence or absence of ascites, almost 42% out of 50 were tested as positive for ascites. Coming to the distribution based on the presence or absence of varices, out of 50 patients, 44%, which accounts for 88%, have been presented with varices. Coming to the distribution of cases, according to the grades of varices, based on the endoscopic grading, the grading of the varices in study population showed 36% incidence of grade 2 and grade 1, whereas 16% of grade 3 varices, while varices were absent in 12% of the patients. Coming to the distribution of the cases, according to the child book score, that is the number of patients greater than score of greater than 10, includes the patients of 32, which concludes the 66% of our study. Coming to the distribution based on the platelet count and the spleen diameter ratio, it's about the ratio between the 501 to 1000. It accounts for the 24 patients, which accounts for the 48% of our study. This is the comparison of baseline characteristic of patients should be studied based on the presence and absence of varices. Relationship between the non-invasive parameters like age, serum bilirubin, serum albumin, hemoglobin, platelet count, spleen bipolar diameter, and platelet count spleen diameter ratio to the presence of varices was studied of this SGOT, SGPT, and total protein PT had statistical significance. This is the correlation of platelet count, spleen bipolar diameter, and platelet spleen ratio with grades of varices, where we will be having that almost between 501 to 1000 of the platelet count and spleen diameter ratio. We are having the 24 patients. From the above table, it is clearly evident that majority of the patients with esophageal varices had platelet count below 1 lakh with 22 patients and spleen diameter in the range of 100 to 2 mm, constituting of 64, and also the platelet count and spleen diameter ratio of 501 to 1000. Correlation of encephalopathy with grades of varices, where encephalopathy changes is grade 2, it is having 5 patients. Correlation of child book score with grades of varices, sir, with the child book score of grade varices, we are having grade 2 of 12 patients with grade child book score of C. The conclusion, the cause of cirrhosis was found to be the alcoholism in 80% and non-alcoholic was 20% among all the 50 enrolled subjects in our study patients. Ascites was found the most commonly associated clinical signs among the enrolled patients, constituting 98% and pedal edema of 82%. Features of encephalopathy are present only in 18% of all the enrolled patients. Most of the patients belong to the platelet count group between the 50,000 and 1 lakh. Viral markers are positive only in 3 patients, which accounts for 6%. And majority of the patients belong to the category spleen bipolar diameter ratio between the 100 to 200 mm, followed by less than 100, accounting for 40% of the patients. On correlation of platelet count, spleen diameter, spleen bipolar diameter, and platelet count, spleen diameter ratio with grades of varices revealed that majority of the patients with esophageal varices had platelet count below 1 lakh with 22 patients and spleen bipolar diameter in the range of 100 to 200 mm, constituting 64%, and also the platelet and spleen diameter ratio of 501 to 1000. Thank you, sir.
Dr. Reddy?
Sir.
I have got a small question for you.
Sure, sir.
What was the method you have used in estimating the platelet count?
I mean, we'll go for the manual count, sir. For the accuracy.
Okay. Because right. And the conclusion, I was a bit surprised. In your introduction, you said that in India, hepatitis B is supposed to be the leading cause of cirrhosis,
Yes, sir,
but
yes,
you
sir.
found the opposite, isn't it?
Yes, sir. Yes, sir. So that's what, sir. While during the results also, I have informed that because based on the literature, it's clearly stating that whole the world alcohol is the main cause. When coming to the India, it is the hepatitis B followed by the hepatitis C in most parts. Actually, in the Madhya Pradesh also recently a study has been done 3 years back itself where it has been showed that hepatitis B is the most common cause. But surprisingly, in my study, it was alcohol, sir, most of the patients.
Yeah, I think you should publish this. And you are sure that you have checked the manual platelet count?
Yes, sir. Yes, sir. Definitely, sir. It's between the 50,000 to 1 lakh is the most commonly, sir.
Right, Reddy. That's all from my side.
Okay, sir. Thank you, sir.
Dr. Reddy,
sir, good evening.
How does it help you, this the so-called platelet count? You mean to say the varicose rupture is more common in patients who have lesser platelet count?
No, sir. Actually, one thing is that, sir, because of that liver injury, there will be 2 mechanisms, sir. We will be looking after the TPO, sir. TPO is synthesized in the liver, which we are having direct effect on the bone marrow suppression, sir. And otherwise, we'll in the secondarily there will be destruction of the platelets. So these 2 mechanisms combine and will have an effect on the esophageal varicose bleed. So most of the time, along with that portal hypertension, we can't exclude the portal. We can't see the portal hypertension and this platelet count and splenic size as separate. Together, collaboratively, this will cause the more chances for the esophageal varices. And one more thing is from my study is that most of the times, even the general physician is treating all these cases where that in the grade 2, tier 2 cities or tier 3 cities where we are not having lack of gastroenterologist or endoscopic procedure, we can rely on this platelet count ratio and simple ultrasound method where we're looking for the spleen diameter so that we can predict for the chance of the esophageal varices, first thing. And one more thing is that it is also cost effective method where we'll be definitely looking at the complete blood picture and the ultrasound for the patients of cirrhosis. Okay. That's what the main motto of the study is like this.
So we need not go for an endoscopy where it's
yes,
not
sir,
available.
Definitely, sir. Definitely.
Okay.
Definitely.
Right. Okay.
Dr. Reddy, can I ask you one more question?
Sure, sir.
Your patient seems to be, most of them seems to be alcoholics, isn't it?
Yeah, definitely, sir. Yes, sir.
In that case, suppose if there is some hematological factors, maldistribution or malnourishment, like B12 deficiency and other things, that would definitely affect the platelet count, isn't it?
Yes, sir. Yes, sir. Yes, sir. Mostly the limitation of the study is this thing only, sir. I forgot to mention about this thing where the patients who are the chronic patients, chronic liver cirrhosis of the liver patients, who are what you said is the malnourishment, are slowly they may be improving. I mean, in the different stages, sir. I mean, some are seriously ill, critically ill patients where they may not get back to the normal position. But there's some patients, some group of patients which, like you mentioned, and which are who malnourished and some chronic patients, there will be some bias regarding our results, sir. There may be a definite chance.
Excellent presentation, Reddy. I liked it.
Thank you, sir. Thank you, sir.
Hello. Thank you,
Nice
Dr. Reddy.
presentation. Nice.
Thank you, sir.
Nice presentation. Good.
Hello.
Thank you, sir. Thank you, sir.
Thank you, Dr. Reddy, for a nice presentation. The judges liked it. Now for the next candidate, Akshintala Kavya Lahari from Karnool Medical College, Karnool. Madam, are you logged in? Kavya Lahari.
Yes, sir.
Okay, madam, start your presentation.
Sir, 1 second, sir. So, good evening, sir. I am Dr. Kavya Lahari, final year postgraduate from Karnool Medical College, sir. My study is whether liver affects the heart. Is there any correlation between the cardiac impairment and severity of the liver disease? This is an era of liver transplantation, sir. But various unexpected cardiac deaths have occurred in the people who have undergone liver transplantation or after certain procedures like TIPS and peritoneal venous shunting. It was noted that the cardiac output is seemed to increase after these procedures, which may overburden the heart. So the pre-existing cardiac dysfunction is accounting for the morbidity and mortality in these patients. Also, certain authors state that there is an increase in diastolic dysfunction in these patients, leading to increased morbidity and mortality. So my aim is
Please scroll your slides, madam. Please scroll your slides. Okay.
So Cirrhosis of liver is a common condition seen in medical practice, which is defined as destruction of liver tissue that is replaced by fibrosis and nodule formation. Advanced liver cirrhosis is associated with hyperdynamic circulation with reduced cardiac output and decreased systemic vascular resistance. It was explained that the circulatory dysfunction in cirrhotic patients is mainly because of arterial vasodilatation that occurs in splanchnic bed with compensatory vasoconstriction in excess splanchnic organs. My aim of the study is to evaluate the clinical aspects of cirrhosis and to ascertain a relation between cirrhosis of liver and its effect on cardiac structure and function. Patients who are confirmed of hepatic cirrhosis by ultrasound and patients aged more than 18 years were included in my study. Patients aged less than 18 years and pre-existing cardiac abnormalities were excluded. Total of 100 patients were taken into study with a study period of 1 year. It is a prospective observational study. Patients with cirrhosis of liver were diagnosed using an ultrasound. ECG was done to know about the electrical activity of heart. 2D echo was done to assess the cardiac structure in special reference to left ventricular mass, ejection fraction, left atrial diameter, and an MO to assess E/A ratio. Analysis was done to evaluate the results of study. Significance was assessed at 5% level of significance. Results. The age distribution widely ranged from the youngest patient being 25 years and the elderly being 80 years, and mean standard deviation is 47 plus or minus 11 years. Out of the 100 patients, 82 were males and 18 were females. The most common cause of cirrhosis in my study is alcoholism, constituting 67%. Of the other 33%, 17% constituted chronic hepatitis. One patient had autoimmune hepatitis, and the remaining 15% the cause is not known. The most common presenting symptom was abdominal distension, followed by jaundice, followed by fatigue, which is followed by abdominal pain and breathlessness. 13 patients had hematemesis in my study. All the patients had moderate to severe ascites. Jaundice was seen in 84% of the people, with bilirubin ranging from 0.7 to 18.9. Moderate to severe anemia was noted in 80% of the patients, and 66% of the patients had platelet count less than 1.5 lakhs. All the patients had elevated blood urea levels, with the highest blood urea being 101, and 84 patients had elevated serum creatinine. Prothrombin time was prolonged in all patients, and electrolyte abnormalities constituted hyponatremia, which is observed in 66% of the patients. Coming to cardiac changes, electrocardiographic changes were noted in 71% of the patients, with QTc prolongation defined in males more than 430 milliseconds and females more than 450 milliseconds is noted in 63% of the patients. ST segment depressions and asymmetric T-wave inversions were noted in 5%. Both QTc prolongation and ST changes were seen in 3% of the people. No changes were noted in 29% of the people. Echocardiographic parameter. In my study, 43% patients had left atrial diameter more than 40 millimeters, with the mean left atrial diameter being 37.5. Ejection fraction of the study patients is 61.7 plus or minus 5.6. Mean LV mass is 223 plus or minus 54.79, and which is seen in 66% of the study population, and left ventricular diastolic dysfunction is seen in 84% of the people. There is no significant relationship between alcoholism and LV mass. A 54 patient had MELD score more than 30, and there is a significant relationship between the patient with MELD score more than 30 with LV mass. 91 patients were of Chalper classification C. Why these cardiac changes occur in cirrhotic patients? Electrocardiographic changes like QT prolongation more than 440 milliseconds is seen even with a mild rise in portal pressure, which is due to delayed repolarization secondary to potassium channel abnormalities. Electrical and mechanical dysynchrony occurs, which is due to decreased density of LTAP of calcium channel, which may lead to reduction in excitation and contraction coupling. Chronotropic and inotropic incompetence is seen. Evidence of overt cardiac contractile dysfunction despite a decrease in preload and afterload is seen in cirrhotic patients. The heart of cirrhotic patients are unable to raise their heart rate after exercise, posture, or drugs. This is due to defect in cardiovascular reflex regulation and decreased sensitivity to sympathetic nervous system. Systolic dysfunction. Systolic function is usually normal or increased at rest. It becomes impaired after stress, leading to inotropic or chronotropic incompetence. Basically, the cardiac contractility depends upon the LV pressure to LV volume ratio. The greater is the ratio, the greater is the cardiac contractility. Despite the presence of normal EF in the pre-ascitic patients, there is a low systolic pressure volume ratio leading to abnormal contractility in these patients. Left atrial diameter is 37.5 plus or minus 4.5, which is in accordance with the Wong et al. Study and Fauci et al. Study. Left ventricular ejection fraction is 61.7 plus or minus 5.6. This normal left ventricular ejection fraction may be a paradoxical EF, which is due to decrease in both preload and afterload in these patients, which causes decrease in end systolic volume and end diastolic volume. Diastolic dysfunction. Ascitic patient had a thicker LV wall and lower E/A ratio, indicating a higher impedance to venous flow. The significant cardiac abnormality in cirrhotic patients is myocardial hypertrophy. LV mass was significantly raised in 66% of the study population, with a mean value of 223 plus or minus 54.79, which is similar to the study done by Hamami et al. Study. This increase in LV mass is because of left ventricular remodeling and also certain growth factors like TNF alpha, endothelin, angiotensin factors, and increase in interstitial fibrosis, subendothelial edema, leading to increase in LV mass. Left ventricular diastolic dysfunction is seen in 84% of the people. which is due to left ventricular remodeling, and also because of the ascites, there will be elevation of the diaphragm and increased intrathoracic pressure, leading to decreased LV expansion of the ventricles. Conclusions: the patients with cirrhosis who have overt cardiac dysfunction may or may not manifest with symptoms or signs. So all patients with cirrhosis should be screened for structural and functional cardiac abnormalities. Impaired cardiac function is often undiagnosed in cirrhosis. It leads to an increased risk of death, especially in setting of acutely decompensated cirrhosis. Also, increase in cardiac abnormalities may lead to impaired perfusion, leading to increased risk of hepatorenal syndrome, and also increased risk of arrhythmias during an acute conditions like GI hemorrhages. Poor prognostic markers include increased level of serum bilirubin, increased INR, serum creatinine, and a patient with higher MELD score. Increase in MELD score is directly proportional to increase in cardiac abnormalities. So it would be a better criteria to include patients on transplant recipient list to be screened for underlying cardiac abnormalities. Thank you for giving me this opportunity, sir.
Dr. Kavya,
Sir, good evening, sir.
I would like to ask you two small questions, very, very small ones. What is the most important cause of left atrial enlargement and left ventricular hypertrophy in Indian population?
Sir, hypertension, sir.
Then did you adjust for hypertension?
Yes, sir. I have excluded the patients with hypertension, sir.
You didn't mention anything about that in your presentation.
Sir, patients with cardiac abnormalities like ischemic heart disease, myocardial infarction, and systemic disorders like diabetes and hypertension were excluded in the study, sir.
Okay, so these are all patients without hypertension, you mean to
yes,
say?
Sir. Yes, sir.
Okay. What about alcohol? Because there are two common things which can happen in the set of population that you have studied. Alcohol affects both the heart as well as say liver. It can cause cirrhosis in the liver, and it can cause alcoholic cardiomyopathy in the heart condition or cardiovascular status. Did you look into that?
Yes, sir. In my study, there is no significance between alcoholism and LV mass, sir. And also in alcoholic patients, the dilated cardiomyopathy, there will be systolic dysfunction, sir. But in our study, systolic dysfunction is not present, sir.
Right. That's all from my side.
Thank you, sir.
Kavya,
sir,
you
good
said
evening, sir.
good evening. These patients, you said after exercise, they have not. There is no significant increase in the heart rate.
Yes, sir.
Most of these people with cirrhosis, usually
yes,
what we do is we put them on beta blockers, isn't it?
Yes,
have you
sir.
excluded that? That may be one of the reasons why the heart rate might have not increased after exercise.
No, sir, I have not excluded that.
That you have to see whether the patient is on beta blockers for varices. And ultimately, in the conclusion, you said this is a good index for transplantation, isn't it?
Yes, sir. Actually, the patients with MELD score more than we take into consideration MELD more than 20 for liver transplantation, sir. But there was a significant consideration with MELD more than with higher MELD score with the increase in cardiac abnormality, sir. So if we transplant the patient with higher MELD score, the pre-existing cardiac dysfunction may affect the people after liver transplantation, sir. So we can keep a criteria for that, sir.
Okay, in the future, it may be important. Right now, we are not going for so many liver transplants, isn't it?
Yes,
Hello.
sir. Yes, sir. Sir, good evening, sir.
Hello.
Dr. Rajak, sir, please come online, sir.
Kavya, I am asking one question. We are told peripheral resistance decreases in the cirrhosis patient. How can they develop left ventricular hypertrophy when peripheral resistance is decreased? The left ventricular diastolic pressure itself cannot cause the concentric hypertrophy or remodeling of the heart.
Sir, the remodeling of the patient induces because of increased sensitivity to sympathetic nervous system. So there will be overactivity of sympathetic
peripheral
nervous system.
resistance is one of the important factors for developing a left ventricular hypertrophy. You said in this your presentation that peripheral resistance decreases in these patients. When peripheral resistance decreases, where is the chance of getting left ventricular hypertrophy?
Sir,
only diastolic distension cannot produce left ventricular hypertrophy. There should be peripheral resistance increase should be there to get the remodeling or left ventricular hypertrophy result.
Sir, myocardial hypertrophy in these patients is also because of increased growth factors, sir. Endothelin, angiotensin, all these factors also come into role for myocardial hypertrophy, sir.
How many people have noted developing left heart failure when you told that diastolic dysfunction is there, left ventricular hypertrophy is there? You have observed the symptoms of dyspnea, orthopnea, P&D in these patients noted, indicating left ventricular dysfunction.
sir, we can't say that, sir. Already patients will be presenting with ascites. Sir.
This, if
So-
you share left ventricular hypertrophy, it is a serious matter. Patient may go into left heart failure. You have to take the history in these cases. If you say that left ventricular hypertrophy results, you have to take a dyspnea, orthopnea, PND, each and every case, so that you can know that left ventricular hypertrophy is occurring.
But,
That may lead to this left ventricular failure.
Sir, these patients will be having ascites, sir. So elevated diaphragm, the patient might not have noticed, sir. They couldn't say whether it is dyspnea because of left heart failure or it is because of the elevated diaphragm secondary to ascites, sir.
Dyspnea, because of ascites, you can get discomfort while lying down. Orthopnea, you can easily make down after making the patient sitting position. Relief he gets in the relief of the bronchial distress or discomfort, respiratory discomfort relieved after while sitting posture for some time. That shows you the dyspnea while lying down is due to not only the pressure of the ascites on the diaphragm, but also due to the left ventricular failure developing there. Making the patient sitting in the sitting position, he should get a relief of the dyspnea. If it is a left ventricular failure, is the cause for her respiratory distress or breathlessness occurring. It is not due to ascites. If due to ascites, it go down while sitting posture, and the relief occurs because of orthopnea is relieved while sitting posture.
Okay,
You are telling both will not go together. Left ventricular, what you call left ventricular.
LV dysfunction, sir.
Okay.
Sir, shall we go on with the next? Yes, sir. Next
Time is
presenter.
over. Time is
Hello.
over, sir.
Thank you, sir.
Next presenter.
Okay.
Thank you, Kavya Lahari. Now the next presenter is Molugu Samhita from Government Medical College, Kadapa. Madam, are you online? Samhita, yes. Please start your presentation, madam.
Is it visible? Is my slide visible, sir? Hello? Hello? Hello, sir?
Madam, you are not audible clearly. Can you raise the volume?
Yes, sir. One second.
You can start something.
Yes, sir. Good evening, everyone. I'm
Yes,
Dr.
thank
Molugu
you, sir.
Samhita. Good evening, everyone. I'm Dr. Molugu Samhita, second year postgraduate from Government Medical College, Kadapa. And my paper is regarding a study of renal dysfunction in patients of chronic obstructive pulmonary disease. Coming to the introduction, chronic obstructive pulmonary disease is characterized by persistent, progressive limitation of the airflow, which is associated with chronic inflammation as a result of significant exposure to noxious gases and particles. It is a preventable public health problem. The prevalence is associated with increased prevalence of smoking. There will be other risk factors also like air pollution, alpha-1 antitrypsin deficiency, and occupational exposure to dust, silica, and the symptoms are persistent cough, sputum, and breathlessness. They are broadly classified into pink puffers, that is emphysematous group, and blue bloaters, that is the chronic bronchitis group, according to the phenotype. COPD is considered the sixth leading cause of mortality worldwide. The COPD is associated with some diseases like congestive cardiac failure, arrhythmias, peripheral artery disease, coronary artery disease, diabetes, hypertension, and chronic renal failure. Some theories have been proposed regarding the renal dysfunction in COPD patients, like because of the higher levels of carbon dioxide and local sympathetic discharge in COPD, there will be increased renal arteriolar resistance causing renal dysfunction. And also COPD may cause secondary pulmonary hypertension, thereby worsening the renal functions. There are some studies showing the higher instance of coronary artery disease in COPD patients, thereby increasing the instance of cardiorenal syndrome. Coming to the aims and objectives, the aim of this study is to estimate the instance of renal failure in patients of COPD in a tertiary care hospital. Objectives are to compare the instance of renal failure and hyponatremia and also to determine whether these are more common in COPD patients when compared with the general population, and also to find out importance of periodic GFR assessment among COPD patients for the early detection and monitoring of renal impairment. Coming to the materials and methods, this is a study conducted over a period of 1 year in 100 patients in Government Medical College and Hospital, Kadapa. And it is an observational analytical case control study with inclusion criteria of age more than or equal to 18 years and patients who are diagnosed to have COPD based on the clinical features and spirometry. We have excluded patients who are less than 18 years and patients with COPD who had other comorbid illnesses like diabetes, hypertension, coronary artery disease, cardiac failure, cirrhosis, and ingestion of nephrotoxic drugs because these are likely to cause renal dysfunction. Coming to the materials and methods, age and sex-matched persons without COPD and other illnesses have been, which are known to affect the renal failure, are selected from the general population as controls. And these, along with the cases, were subjected to history-taking, clinical examination, and investigations like chest X-ray, serum creatinine, blood urea, serum electrolytes, and other relevant investigations. The creatinine clearance was estimated using a 4-variable MDRT formula, which is as given below, and a creatinine clearance of less than 60 ml per minute per 1.73 meter square is defined as a renal failure. Coming to the observational results, in my study, we found that the mean age is 50 plus or minus 6 years, and the majority of the participants were male. Age and gender were comparable among the groups. Coming to the variables, there is a distribution of hemoglobin level. We have taken HP less than 12 in females and less than 13 in males as anemia, and 43% of the cases and 26% of the controls have shown anemia with a p-value less than 0.05, which is significant. And coming to the serum albumin levels, we have measured about regarding the hypoalbuminemia, that is less than 3 grams albumin, is seen in 23% of the cases and 10% of the controls, with the p-value being significant. Coming to the urea levels, if it is more than 40, it is seen in 51% of the cases and 12% of the controls, with p-value being 0.01. And creatinine levels, it was found higher. We have taken the creatinine if it is more than 1.1 in females and 1.3 in males. It is found higher in 42% of the cases and 6% of the controls, with p-value being significant. And sodium levels, as it will be decreased in this study, sodium level of less than 135 milliequivalents per liter was considered hyponatremia, seen in 62% and 11% of the cases and controls respectively, with the p-value being significant. Potassium levels, we have measured for hypokalemia, that is potassium less than 3.5 milliequivalents per liter, but we have found 5% of the cases and 2% of the controls had hypokalemia, with p-value being insignificant in this study. And creatinine clearance, as already described using the MDRT formula, that is modification of diet and renal dysfunction formula, if it is less than 60 ml per minute per 1.73 meter square, the creatinine clearance was seen in 46% of the cases and of the controls, with the p-value being significant. The results of the study are the statistically significant difference is found between the COPD patients and the control groups for creatinine clearance, hyponatremia, serum creatinine, hemoglobin, and serum albumin. Discussion, all the things which I have discussed till now have been mentioned here, so I'm skipping the slides. And coming to the conclusion, I conclude by saying that in this study, there's higher instance of chronic renal failure and hyponatremia, more in COPD patient than the control population, with renal failure present in 46% and hyponatremia 62% among patients with COPD. And also, we have to do for the early detection and monitoring of renal impairment in COPD patients, periodic assessment of the GFR must be done, is recommended. And further, we can do studies to investigate the prevalence of CKD among the patients by a multicentric approach, and for also the consequences of acute exacerbations and drugs used in the treatment of renal dysfunction. These are the references for my study. Thank you for giving me this opportunity.
Thank you, Dr. Samhita. Now the judges.
One question to you.
Sir.
Hello.
Good evening, sir. Good evening, sir.
Good evening. One question to you. Have you ruled out chronic car pulmonale in these cases or included?
Yes, sir. No, sir. We have excluded chronic car pulmonale, sir.
Okay.
Sir.
Samhita,
Sir, good evening, sir.
you said there seems to be a very significant association between COPD and hyponatremia.
Yes, sir.
Can you postulate what could be the reason?
So COPD, because of some mechanisms like because of the increased carbon dioxide retention and local increased adrenergic reactions, there will be sympathetic overactivity causing renal vasoconstriction, sir. Because of that, renal dysfunction will be seen, and also there will be to make, but GFR should be maintained in the initial stages, sir, so that because the GFR should be normal and there's a decreased renal plasma flow, the filtration fraction should be increased. Because to increase this filtration fraction, the RAS system will get activated, resulting in sodium and water retention, leading to hyponatremia, sir, hypervolemic hyponatremia.
I don't really think RAS activation will lead to hyponatremia. RAS activation will lead to both sodium as sodium retention, isn't it?
Yes, sir.
Hyper is a possibility. Hypernatremia is a possibility rather than.
So actually,
yes, sir. Yes, sir. Okay, leave that. Srinivas, sir, all yours.
Samhita,
good evening, sir.
Most of these people on COPD, they'll be in long-term steroids, isn't it?
Yes, sir.
Have you correlated this renal failure with the amount of doses they are taking? Steroids.
No.
They'll be on steroids for long periods of time. So people will be taking a moderate amount of steroids or heavier doses also. Have you correlated the dose relation with the renal impairment? That you have not done.
No, so we have limited our study only to these parameters. And these are the patients who came with COPD on that OP day. We have taken the parameters.
Okay.
Samhita, one more question from my side. Since you have excluded all hypertensive patients, did you?
Yes, sir. Yes, sir.
Why?
Because it has an effect on renal function, sir. Hypertension itself can cause decreased renal function.
Okay. Anyway, I think the percentages of incidence of renal failure as well as hyponatremia seems to be very, very high. I think the few studies which I have looked into really didn't show so much incidence of hyponatremia in association with COPD. It's really surprising. I think probably some of your juniors can take it up and probably do it on a bigger scale.
Sure.
Next presenter, the last. Okay, Samhita, good.
Sir, Dr. Gopi Verma, Dr. Kanna Gopi Verma is not logged in. So we have given him a final call, but not yet logged in. So we'll drop that contestant, sir. So it's only among the 5 people who have presented the papers now. After this, we will select 3 people, first, second, and third prizes. Now, will you be kind enough to tell me the scores now itself, sir?
Sir, we will share in the group, sir, if you don't mind.
Okay, no problem, sir. No problem, sir.
In
But
the next
then
10,
tomorrow
15
morning.
minutes, yeah, in the next 15-20 minutes, I'll share in the group, sir.
Okay, sir. Okay, sir. Thank you, sir. Thank you very much.
Maximum score out of 60 will be sufficient, isn't it, sir?
Yes.
Total score.
That's all.
Yes.
For
Thank you,
100,
sir.
Sir?
Thank you,
we're
sir.
taking 100 marks and maximum we told 60.
No,
Yes,
sir,
sir.
I think it is out of 60. No, sir. Maximum is 60, sir.
Yeah,
Out of 60,
60. Maximum is 60, sir. Yes,
maximum marks.
Maximum is 60, sir.
So
Right, sir.
total is 100. We are taking maximum marks 60. You are telling maximum 60. We have to
With
give
more than out of
maximum
60
marks.
Yes, sir.
Out of, yes, sir. Out of 60, we have to award.
Okay.
Thank you, sir.
Okay, sir. Yes. Thank you very much, sir. Dr. Narayan Rao Garu, Dr. Srinivas, sir, Dr. Abdul Razak. You have been very helpful, staying so late in the evening with us, and hope you will compute your scores and give me an answer.
Thank you, sir.
Thank you very much.
Thank you, sir. Bye-bye.
Okay, sir. Bye, sir. Sir, tomorrow to announce the prizes, sir.
Right, sir. Thank you.
Okay, sir.
Thank you, sir. Thank you very much, sir. Now, today's schedule has been completed successfully with all your cooperation, patronage, and participation. Let's again meet tomorrow morning by 9 a.m. sharp. Thank you. Thank you, one and all.
So we have to submit the extremist.
Sir, yes.
We have
Yes,
to
sir.
send the mark through WhatsApp or through
WhatsApp group, sir. WhatsApp group, sir.
Okay. Thank you very much.
Thank you, sir. Thank you.